Welcome back. I know this was not the exam you guys would have loved to give. I know sometimes the exams are not as expected, but seriously, I feel that all you MCI students have got to learn this lesson, that now you are considered at par with the PG entrance students, which is very good. There was always this thing that your exam is very easy and then you should just go and somehow pass this, and then you have to go and give the tough exam. So you start tough. You give a good tough exam. So now you are on par with the PG entrance exam. So what is the benefit of this? You have already given one tough exam when you go into your internship, whereas those guys have not given any tough exam right from the time of their MBBS entrance. You guys have already given one tough exam. When you give this MCI exam, you pass that, you're already 10 steps ahead of the PG entrance students. Not that they are not any good anymore, but my idea to convince you people here is that please understand that you are now going to give tough exams so that you're prepared for the PG entrance exams right from now itself. So it's good. Go ahead and read as much as you can, and please make use of the apps which have been given to you. PrepLadder takes pride in giving you all the subjects in a very clinical manner and detailed discussions on cases. Our app is not full of one-liners and things which you have to mug, which is never going to give you the concepts and never going to help you in such exams which are coming. From the last 2-3 exams I've seen, Gynae has been coming in something like 15 to 70 direct or indirect questions, and if you have understood the concepts, it will be very easy for you. Alright, with that introduction, let's get into the first question for this exam. Okay, a lady presented 5 days after normal vaginal delivery with heaviness in the breast. She complained that her baby is unable to latch on the breast for the breastfeeding. Now, a latch is the baby's mouth sticking onto the mother's breast so that the baby can suckle and derive milk. Now, the latch is not perfect. The baby is not able to take any feed. When does this happen? This can happen in many reasons. It can also happen when the baby is having a improper formation of the mouth, if there is a cleft lip or a cleft palate, or if there is a tongue tie. There are numerous reasons for lactation failure from the baby's side. From the mother's side, it could be mastitis, it could be a case of inverted nipples or cracked nipples. There are so many reasons. So that's why I said, are these the choices really? Because when I put this MCQ on the Facebook, most of you gave me these choices. Some of you also wrote inverted nipples. So that is also one reason. But yes, the answer to this question, in spite of all the choices which I have discussed with you so far, the most common cause is breast engorgement. Now that breast engorgement can lead on, around 10% of these patients will lead on to have mastitis, but mastitis is not the commonest cause. Inverted nipple fortunately is not the commonest cause. Inverted nipples is a very big disaster for pregnant women, because when you see them in the antenatal OPD and you see inverted nipples, start doing therapy now. Why? Because when they deliver, the baby is not able to suckle on the breast because the nipple is inverted, there is nothing to latch on, and the baby cannot be trained because he is just a newborn. So the nipple has to be pulled out while in the antenatal time, so that after the delivery the mother does not have breast engorgement, and that can be a very painful situation, and the baby will be crying because he is not getting enough milk, and the mother will be screaming louder because her breasts are very engorged and very painful. Alright, so those are the causes. In this, the major most cause and the most common cause which we see, which causes lactation failure amongst the choices given and also in general practice, is the breast engorgement. So we'll go with this answer, breast engorgement. Yes, breast abscess also will cause a patient to have a lot of tenderness and she'll be unable to feed, and mastitis also is a very much more commoner situation from breast abscess. Of course, not all cases of mastitis will become breast abscesses. Try to understand, mastitis is inflammation, abscess is fluctuant mass behind the breast, okay, within the breast, behind the nipple I meant. So all of these can cause lactation failure. A choice of lactation failure, again, this is making me a little worried about the choices you people have recalled. Maybe because there were a lot of long clinical questions and you could not remember all the choices, I can understand. So these are all the cause of lactation failure. So lactation failure itself has a choice. I'm a little surprised, but yes, there can be hypothalamic causes of the mother, there can be causes of the baby which can cause lactation failure. So I'm not totally disregarding this choice. So whatever the choices are given, and even if the choices are not given, carry home message, breast engorgement is a common cause of lactation not being able to deliver to the baby. Okay, so the answer is breast engorgement. It's common in women who do not breastfeed sometimes when they are unable to breastfeed because they are too anesthetized after a cesarean section and that was done under general anesthesia, or that the baby is not too well and he's in the nursery and the time between starting the breastfeeding and the ideal time, which is 1 hour. All of you know that the ideal time is 1 hour. Now that time has gone off and it's on almost 2 or 3 days and the breast keeps filling up, and that's why too full a breast and too engorged nipple might be very difficult for a small baby to start getting used to. So that could be a problem. So women who do not breastfeed or could not breastfeed for some reason, milk leakage and breast pain would be a presentation, and this peaks around 3 to 5 days after delivery. The treatment is analgesia and cool packs. But the cold packs, a lot of people are comfortable with the cold packs, but let me tell you what works best should be given. We keep telling them cold packs, but some of these women are, they are much more happy if you give them a warm compress. So what makes the woman feel a little bit more relieved of the pain, that works best. Although cool packs is the best management of giving some local respite. Now breast support, a binder or a sports bra, something which is tightly holding the breast from moving, because it's an inflamed breast or engorged breast, any such problem, it's better that the breast doesn't move much. Too much of movement will cause the patient to have more discomfort. So bind such breasts or give them minimal movement. That's one very effective way of giving a relief. And do not suppress the lactation. Now that's one mistake all of us do. A lot of people, when they are practicing, they feel that okay, the breast is having a problem, okay, give the baby top feed, give him some formula feed and stop this. You can make a baby have breast milk even if there is mastitis. The normal breast, suppose the right breast has a problem, there is a mastitis or engorged breast, but the left breast is all right, tell the mother to feed the baby from the left breast first, and while the baby is feeding on the left breast, the stimulus goes and the letdown happens, so the other breast which is having mastitis also starts getting ready for the breastfeeding. The problem with mastitis is not that the milk is bad for the baby or it is impure for the baby. Don't get into these concepts. It's just that the nipple is a little swollen. It's difficult for the baby to latch. So now he's got used to the breast milk coming from the left breast. He gets a fill from there and then he wants more milk. Now transfer him to the right breast. He'll know that okay, fine. He has to work a little bit harder to grasp the nipple. Once the nipple is grasped, the letdown has already started because of the feeding of the left breast. All right. So never stop breastfeeding in mastitis or in breast engorgement. Encourage the mother to breastfeed, and of course you must train the baby also. How do you train a newborn baby? Do not give up breastfeeding moment he starts crying. There's a slightly engorged breast and the baby is trying to breastfeed, and moment he puts his mouth on the breast, it seems a little bigger and he just withdraws and starts crying. Do not give him top feed just yet. Wait for some time. That's a very practical advice which I give to women who have just delivered. The baby starts crying and the mother says, "Bacha ro raha hai, let me give him top feed from somewhere." No, don't do that. Tell the baby that moment you try, you will get milk. So he must understand that. So keep the baby to the breast. Let him suckle on it. He doesn't get, don't breastfeed. Let him cry. Crying is good for the lungs. Newborn babies crying, it's good exercise for the lungs. Then put him to breast again till he gets to know that I have to try to get breast milk. Moment I start, I will get. Once he gets into the habit of trying and getting milk, then he'll always take the effort to start suckling. If he cries and moment he starts crying, the mother gives him a spoon to feed, he'll get used to spoon feeding, and that spoon feeding stays for life. All right. So make sure that you make the baby also train a little bit. Let him cry a couple of times. It's all right. It'll take 10-15 minutes. It'll take half an hour sometimes for the baby to get accustomed to having an effort from his side, putting an effort from his side onto the breast and suckling on the breast. So once he gets used to the effort that I have to put an effort and then I get milk, fine. It's good training for the baby. All right. So what are the other causes of a baby not being able to breastfeed or lactation failure? Like I told you before, sore and cracked nipples, inverted nipples, engorged breast, mastitis, previous surgeries on the breast, neonatal causes like the baby is unwell and he's in the nursery, or baby is having some deformities of the palate or the lip, and insufficient or unsuitable milk as in some infections. All right. So let's move on. to the next question. A 14-week pregnant woman came to the outpatient department for a medical termination of pregnancy. It is after 12 weeks where it is a little difficult to make the best choice of the abortive patient, and it's generally good advice that more than one doctor is discussing and seeing the patient profile and making this decision of doing the MTP. All right. How much dose of misoprostol is to be given to this patient? Now, misoprostol is an abortive patient, it is PGE1, and when you give PGE1, it is going to cause uterine contractions, and the contraction cause the eventual opening of the cervix and expulsion of the fetus. Okay, so it is like inducing a mini labor with misoprostol, but the dose is much higher. If the patient is at term and using misoprostol for induction of labor, we use only something like 25 milligrams. Okay. Now, the dose here is 800, 400, 200, 100. Again, were these the choices? Because the choices given to me, some people said 600 and some people said 800. Both the choices were sent to me. Actually, both are correct. Okay, it is 600 to 800. So, I hope that was not the choice. Between 600 and 800, if you have to choose, go with 800 because that is what is more effective. That's why we always give 800. So, the answer to this question is 800. So, 800 micrograms vaginally is the dose, and yes. For second trimester abortion, when you give PGE1 600 to 800 microgram vaginally, you can follow it up with 400 microgram vaginally or buccally every 3 hours. So, how many such doses you can give? That is also, I think, one question which was asked. I have not included that question here. I think some of you asked me on the Facebook that, sir, how many maximum doses of misoprostol can be given? So, we can give up to total 5 doses. All right. So, when we give this vaginal dose, we can follow it up by 400 microgram vaginally or buccally every 3 hours, and a total of 5 doses can be given for the expulsion to happen. And most women will expel with this, and when sometimes they don't expel even with this, we go to some other methods, and those other methods not the purview of this discussion here, but I can tell you this much, that an escalating dose of oxytocin can be used, that we can start with something like 50 units in a 500 ml saline bottle, and we can start it at a fixed rate like 20 drops per minute, and then once that bottle gets over, then we can make it 100, next we can make it 150 international units, like that. An escalating dose of oxytocin can also be given to induce an abortion. But yes, high dose of oxytocin has its own side effects like water intoxication, hypotension, can also be hypertension, but mostly hypotension. All right. So, the answer is 800 micrograms and up to total 5 doses can be used. Question number 3, a patient presented with secondary amenorrhea 3 months post delivery. Before surgical intervention is considered, which of the following can be done? They are trying to ask us a question that a woman has delivered and for 3 months she is not having any periods, which is all right. We know that a woman who is delivered, she would be breastfeeding, and as long as breastfeeding is happening, most women don't get periods. If she is not breastfeeding properly, then she can get some irregular periods. Okay, even if women do not breastfeed altogether for roughly 1 or 2 months, they also mostly don't get periods. So, this is a very simple question, that in a case of a woman who is just delivered and not getting periods, up to 6 to 8 months, we are not worried really too much. But yes, make sure that she is taking some contraception method like a barrier, at least, if nothing else. Progesterone pills are the best management, we know that, but at least some contraception is used, because this does not mean that she can occasionally ovulate. Lactation amenorrhea, I am telling you before I answer this question, is not a perfect method of contraception. Lactation amenorrhea gives contraception, correct, but not perfect contraception. We have discussed that in detail in our app. Please don't be in any misconception that is the best method. The best method during lactation amenorrhea is the progesterone pill. Okay. Now, which of the following can be done for this woman? Now, since she is a case of lactation amenorrhea, nothing much has to be done. The answer is assurance or reassurance, whatever way you want to say. Now, OCP to induce a cycle, we don't have to do now. She is not a case of ovarian failure. Similarly, pulsatile GnRH to stimulate the ovary. This is not a case of hypothalamic pituitary failure. There we use GnRH therapy, pulsatile. Progesterone to give a withdrawal bleed. That happens when a woman is having estrogens already, but not having progesterones to cause secretion in the endometrium. PCOS cases, we do a progesterone withdrawal. All right. So, none of these conditions exist here. She is a woman who is delivered and having lactation amenorrhea. So, the answer is assurance. Okay, so what is the principle of lactation amenorrhea? All of you know the basic well, that the pituitary is the organ which is stimulating the FSH and LH release to act on the ovary, which you know very well makes estrogen to make the endometrium proliferate and progesterone to make the endometrium secretory. This is the one part of the action of the pituitary. Now this is because of the GnRH which is coming from the hypothalamus. GN, gonadotropin releasing hormone. This comes from the hypothalamus, acts on the pituitary and releases the FSH and LH. So FSH and LH are known as the gonadotropin. Now that is one part of the action. The other part of the pituitary, which is the anterior pituitary, releases the prolactin, and the posterior pituitary releases the oxytocin. So the prolactin which is released makes the milk. The milk production is because of the prolactin, and the oxytocin which comes out because of the suckling on the breast by the baby, that causes the oxytocin release, and oxytocin causes the contraction of the myoepithelial cells around the lobule, and that compression of that causes the milk expression. So yes, the production is because of prolactin and the release is because of oxytocin. Now what does this prolactin also do? This prolactin is known to inhibit the GnRH. So you know the GnRH, gonadotropin releasing hormone, is required for the gonadotropin release. LH and FSH is based on GnRH release from the pituitary. Now when the pituitary is making a lot of prolactin, it also gives a feedback to the GnRH. So when the GnRH is inhibited, there will be no LH and FSH, and when there is no LH and FSH, obviously there is no follicular growth. When there is no FSH, there is no follicular growth. When there is no LH, there is no follicular rupture. That's why there is no ovulation, and that's why there are no periods. So why is a woman having lactation amenorrhea? Because she is breastfeeding, increasing prolactin, and that prolactin inhibits the GnRH. That's the relation which I wanted to discuss with you before I finish this answer. Answer is definitely lactation amenorrhea, but we must know how prolactin inhibits the GnRH and why this is the cause of the lactation amenorrhea. One more thing, since now the questions are getting a little tough, what is the level of prolactin in the period of breastfeeding? During the time of breastfeeding, what is the level of prolactin? It's not always high, it's actually low, it's normal or lower than normal. In lactation, the level is low or lower than normal. So how does it increase? Every time the baby suckles on the breast, the prolactin increases. So there is an episodic increase of prolactin, okay? The prolactin is not constantly high in the breastfeeding time. Every time the baby suckles on the breast, prolactin increases, and that inhibits the GnRH. So yes, to have constant suppression of GnRH, constant breastfeeding is required. That is almost every hourly or every 2 hourly, at least 12 times to 14 times in a day. That kind of breastfeeding no woman can do. She'll have to sleep in the night, isn't it? She'll have to rest for some time, and that time, 8 to 10 hours, if she's not breastfeeding the child, then the prolactin is not high. And the prolactin is not high, the GnRH can escape, and that can cause follicular growth because the GnRH will cause the stimulation of FSH. So that's why constant breastfeeding is required to have good lactation amenorrhea and good inhibition of ovulation. So yes, that's why it is not a very, very effective method. Lactation amenorrhea for contraception is not a very effective method because no woman can breastfeed continuously every hourly in 24 hours. That is impossible. So that kind of breastfeeding is not possible. That's why it's not a very reliable method. So what I told you in the beginning of this question, I'm explaining you now based on this diagram. Okay. So let's move on. NC question number 4. 14-year-old girl presents with primary amenorrhea. On examination, secondary sexual characters are seen. A lot of questions on primary amenorrhea, secondary amenorrhea this time. I hope these were all the questions because I think I got 18 combinations of these questions in my email, and I tried to reduce it down to 7-8 questions in this paper, and I hope they are not repetitive. Okay. So 18-year-old girl presents with primary amenorrhea. On examination, secondary sexual characters are seen. Uterus and ovaries were seen to be normal on the ultrasonography. So basically it means a young girl of 14 years has not had periods. You examined her, axillary hair, pubic hair is there is some breast growth. So what is the hurry? At 14, we are not bothered. So yes, we've always discussed in our classes that at 13 years, we call it delayed periods. If till 13 she has not had periods, we call it delayed. But if secondary sexual characters are present, then we can wait till 15 years. And at 15 also she doesn't get periods, then we say it is delayed periods. So yes, she is having secondary sexual characters, this question, she is having secondary sexual characters and she is just 14. I will wait till 15 at least for her to be called delayed periods. So, again I will say reassurance. So, lot of questions on amenorrhea and lot of reassurance answers in this paper. Okay. Karyotyping, UPT, urine pregnancy test, yes, I will see the answer to this question is reassurance, alright. Now, urine pregnancy test. If you really ask me, any woman who is not having periods, you will do a pregnancy test, but this is a child and I do not want to say this answer, and at your stage, let us not think of rare things, you know, a young girl not getting periods, it is probably because of just that she is not the age where her periods will start, she has got secondary sexual characters, let us wait for another 1 year till 15 to call it delayed. Yes, they can be abused, young girls are abused day in and day out in most of the countries. Our country also, we have had so many such instances, and if they are misused, they can get pregnant. Yes, I mean, if you really ask me, I will do a urine pregnancy test. Actually, I will do one test, but just to go with the basic question which was asked and the situation which is given, 14 secondary sexual characters present and not getting periods, primary amenorrhea. Okay, the answer here is to just reassure. Of course, take the girl with her mother only and nobody else, and just quietly ask the mother that I hope she was not, you know, nobody troubled her, you know, ask in a way that the mother does not get too scandalized, okay, because most of the times the person who abuses such young girls are relatives, isn't it? So, you can quietly ask this. I am telling you this as a gynecologist who sees so many such mishaps happening in our society, and they keep coming to us, but as a gynecologist I am telling you this. For the answer, reassurance is the answer for this question. Okay. So, let us move on and see question number 5. A 19-year-old girl presented with weight loss, secondary amenorrhea now, 19 years old, secondary amenorrhea, and a constant fear that she will gain weight. You know, she is very conscious that she does not want to gain weight. Alteration in which of the following is responsible for this presentation? Now, if all of these were the questions, they are really trying to bully you people this exam. But like I said, tough times make tough people, isn't it? So, yes, 19-year-old girl, secondary amenorrhea, that means she was having regular periods and not having periods now, and she is having constant fear. She is very worried about her weight gain. I mean, if she gains weight, she is not going to like it. So, stress, she is stressed out, she is anxious. Stress is known to cause the hypothalamic suppression, and stress is a known factor which will reduce the hypothalamic influences onto the pituitary. So, what is the hypothalamic influence on the pituitary? It is the GnRH, isn't it? So, the GnRH suppression, because of hypothalamic suppression, there is GnRH suppression, and GnRH is not there, gonadotropin releasing hormone is not there, there will be no gonadotropins like FSH and LH to cause the follicular growth, and if there is no follicular growth, there is no estrogen, and after rupture there is no progesterone, alright. So, yes, the answer to this question is GnRH. HCG is the cause, secondary amenorrhea. Yeah, HCG does not cause secondary amenorrhea. Yes, maybe she is pregnant. Yes, I will rule out a pregnancy test definitely, just as I said in the last question, and 19 is definitely the age where she can actually legally get pregnant also, and she can be in a relation. But yes, the presentation of this question is there is weight loss and she is having a fear that she will gain weight. So, this goes into the hypothalamic amenorrhea causes, stress because of the constant fear of weight gain, anorexia nervosa, bulimia nervosa, all these conditions can cause secondary amenorrhea. So, the history is more sensitive of a hypothalamic cause of, not a pregnancy related cause. I am sure that all of you know that any woman having amenorrhea think of pregnancy, but the two questions which we discussed just now, they are suggesting very obvious answers, alright. So, the answer here is GnRH, okay, fine. So, answer is GnRH, anorexia nervosa is a cause of hypothalamic amenorrhea. So, what are the other causes of hypothalamic amenorrhea? Mental stress, too much of weight loss, leptin deficiency is now being purported as a cause. You know, leptin is required for the metabolism of the food and also regulates the appetite of a person, and if there is leptin deficiency, it is known to contribute to the weight loss. And intensive exercise, you know, the people who run marathons and who are always exercising, people who are into athletics in a very severe manner, those girls, yes, they do suffer from amenorrhea because of the physical stress. Yes, it is a very well known fact. Chronic debilitating diseases, and brain surgeries and tumors where the hypothalamic pituitary axis is disrupted. Okay, so all of these, even if the axis is not disrupted, just the stress of surgery alone is enough to cause the hypothalamus not to work well. All right, so those are the cause of hypothalamic amenorrhea. Let's see question number 6. A patient presented to the outpatient department symptoms of lower abdominal pain, dyspareunia, that is painful intercourse, and pelvic examination showed adnexal tenderness. What is adnexal tenderness? That around the uterus, next to the uterus. In fact, I have done a pervaginal examination. This is the tube, and when I do a pervaginal examination, when I put my finger into this fornix, this area is tender, adnexal. Uterus is tender, correct. Now this is the adnexa. The ovary comes in the adnexa actually somewhere here. Okay, so there is tenderness in this area, adnexal, next to the uterus, adnexa, left and right adnexa like we call it. Okay, if you become gynecologist, adnexal masses is a major long question and something which will come in your final MD exam also, adnexal masses. Okay, that's some other discussion, we'll have it later. So when there is adnexal tenderness, uterine tenderness, lower abdominal tenderness, cervical motion tenderness, that is, if you can imagine that the uterus is inflamed, isn't it? An inflamed uterus, the peritoneum is somewhat like this. So this peritoneum also will be actually inflamed. So when I go in and do a pervaginal examination, let's say here, I've done a pervaginal examination. Suppose this is, these are two of my fingers, and I get into the vagina and I move the cervix, I move the cervix like this. So when I move the cervix with my fingers, the uterus will move, it is inflamed, it will cause pain, and also the peritoneum which is over the uterus, it is inflamed. A movement of an inflamed peritoneum will cause pain again. So cervical motion tenderness, uterine tenderness, adnexal tenderness, lower abdominal pain is a classical scenario of pelvic infection. So this is a history of PID. We've discussed PID so many times in our app, and so many questions we've discussed PID. They did not ask you what is the diagnosis. You should know it is PID because Dr. Vijay has taken a class for you and you've seen my app. As simple as that. We've done the PID class and I've told you the triad of lower abdominal pain or uterine pain along with cervical motion tenderness and adnexal tenderness. You know that's the triad. So you know it's PID. Now the question is, what could be the long-term sequelae of this condition? What could be the problems, complications of PID in a woman? So yes, with PID we know that this passage, this passage of the fallopian tube here from the internal opening of the tubes here. Can you see? This is the opening of the tubes here. This can get blocked because of the inflammation. So this ostia, we call them the ostia, the tubal ostia, the uterine cavity is here. This is the cavity and the tubal opening from the cavity and going like this. This is the passage of the tube. Now this ostia gets blocked. This ostia can get blocked with the infection, and that blockade of the ostia causes tubal blockade, and that can cause infertility later on. So yes, what could be the long-term sequelae of this condition? Now I would go with infertility in this. Amenorrhea, to be very frank, amenorrhea can happen, isn't it? If there is so much of infection, let's see, we'll take this out from here. If there is so much of infection can cause fibrosis of the uterine lining, can cause Asherman syndrome. Infections do cause, tuberculosis is an infection. Other infection can also cause Asherman syndrome, but not so commonly. So since it's not a common answer, between amenorrhea because of Asherman and infertility is really more common. Okay, so yes, my answer would be infertility, definitely, maybe amenorrhea because of this. Yes, infections can cause pregnancy losses also. Infections of the uterus are known to cause, in any patient who's got a recurrent pregnancy loss, I do cultures of the uterine cavity, I take endometrial biopsy and see if there is a chronic long-term infection which is causing the abortion, I do that. But again, between these four choices, pelvic organ prolapse because infection, actually no, that will not be the association, definitely not this. But other three can be associations. Definitely the answer here they are looking for in these choices is infertility. Alright, answer here is infertility. Single best answer would be infertility. Like I said, chronic pelvic pain can happen, secondary amenorrhea can happen, okay, but the answer is infertility. Now I am discussing all these because once you get related questions like this, you are not getting straight one-liners. you must have a all round information about the topics which you are discussing. Now, question number 7, 32-year-old unmarried woman came with secondary amenorrhea. She was having regular normal flow periods until now. So, unmarried, trying to say not sexually active, secondary amenorrhea. She was having regular normal flow periods till now. Nothing was found on the pelvic examination. No other associated complaints are there. What will you do next? Now, 32 is good enough age for us not to go for the information that she is not sexually active. You know, most women who are not married and get pregnant give you this history. So, you know, even for a young girl of 14, I said I will do a urine pregnancy test unofficially, or, you know, trying to get the mother in confidence and doing it. Now, this is a 32-year-old woman and she says, I am unmarried. All right, you got amenorrhea, I am going to do the pregnancy test first. Definitely pregnancy test first, and if she is not pregnant, then we will see what is the cause of secondary amenorrhea. Maybe she is not ovulating. Let me give a progesterone challenge test. This question, definitely I will do a urine pregnancy test first. Yes, if that is negative, if it is positive, you know you are dealing with a pregnancy. If the urine pregnancy test is negative, then it could be because of poor pituitary work, poor hypothalamic work. So, look at the LH and FSH levels. If they are low, then you know it is a level of the central level problem, that the hypothalamus and pituitary is not working. If it is low estrogen levels, then that means the ovary is not working. It could be an ovarian failure. All right. So, yes, I will look at these things also, but first is a urine pregnancy test. All right, let us move on. So, answer is urine pregnancy test, rule out pregnancy first. Question number 8. A patient has presented with smelly greenish vaginal discharge 5 days after delivery, early in puerperium, because some of you said she presented in puerperium. So, I have included both the terms. So, smelly greenish vaginal discharge suggesting infective foul smelling discharge from the vagina after delivery can happen because of numerous reasons, but mostly it is postpartum endometritis or infections after the delivery of the genital tract, especially the uterus, because uterus is a culture media. After delivery, you know, the uterus has a lot of lochia coming out and the cervix is open, vagina is having a lot of bacteria as it is, and they can ascend into the cervix, into the uterus and cause infections and endometritis, and there is so much of blood. So, it's the uterus, the ideal culture media at that moment. There is blood, there is a closed space, and this area is next to the anus and perineum, which is a very close kind of place. So, that place can harbor so many bacteria which can cause endometritis. So, keeping oneself clean is a very important prerequisite. Anyone who is delivering and should be in a very clean environment. Okay. Remember that in puerperium we always tell women not to leave home for 42 days. Some customs say 45, some say 42, and in the books it is 6 weeks, again 42 days. So, it is understood by the society since ages and also by science that around 6 weeks the woman is having immunosuppression. She should not be harboring too much out of the house because she may catch some bugs easily. She might go to unclean place. So, wherever she is staying, she stays very clean in a very clean environment so that she does not get infections. So, yes, what is the next line of management here? I would want to do an ultrasound definitely to see if there is anything inside the uterus, anything retained bit or any retained product. But before that, since it is given as a choice, see, if per vaginal examination was not in the choice, I would have marked ultrasonography. But since this is in the choice, I would have to say per vaginal examination. Definitely, I will examine her first. She is saying I am having white discharge. She is saying I am having foul smelling discharge. It is itchy and it is smelly and I do not like this. I will always see her first, isn't it? I will see her in the OPD. I will do a perspective exam and see what kind of discharge is coming out. I will take a culture of that. I will send it for a culture sensitivity, what bacteria is growing and what is the antibiotic which is sensitive to it. I will take a cervical swab, or even you know, after 5 days the cervix is still open enough to take a swab stick. A swab stick is just like this pen. So, I put it into the cervix and go as much high as I can. I can go into the uterus, take a swab and take that out. Endometrial swab also I can do. So, I will do all these things. And of course, I look for some products if they are coming out, any membranes which are stuck on the cervix. If the cervix is having some erosion which has got infected and causing all this discharge, if there is any lateral vaginal tear which was missed in the delivery and now that is infected. There are so many things which can be there in the local examination which can be the cause. All right. You could have left a mop. You have done the delivery and you have kept a a gauze piece inside or a mop inside, and you forgot to take it out, because at that moment she was bleeding. You put in a mop and then you went to have your tea, and then you had 7 more deliveries in the labor room, or you had your friend coming over for dinner and you were too busy discussing with him or her, and after some time you realize that your duty is over, you must go home, it's 8 in the morning, and you forgot to take out the mop. That's the most common reason for mops being missed. Within the vagina, the mop is there, and that becomes a foreign body with so much of lochia inside. You have to do it just once in your life, and the kind of thrashing you will get from his scene you will never forget for the rest of your life. And fortunately, I saw it happening with somebody, and I know that it's a very disastrous situation for the patient, of course, and definitely for the resident who missed it, because it can cause very bad septic shock to the woman. Fortunately, the patients which I've seen who had retained mops, they've all survived. So yes, I want you to do a per vaginal examination, per speckle examination, definitely. So the answer is local examination first. Rule out small bits of tissues within the cervix, polyps, some placental polyps can be there, placental products which were there inside, they are hanging from the cervix and they are getting infected, or cervical erosions which could be infected, gauze pieces, mops, or to take a swab of the cervix and the endometrium. This is not from a book, this is from personal experience that I am telling you. I am not quoting any book from here, this is all personal experience. Always do a per speculum examination first, okay. Definitely do an ultrasound and we will give antibiotics. Answers are correct, but in the sequence of things, first per speculum examination. Right. Question number 9. What is the common obstetric or gynecological condition where this procedure is done? So they are showing you an artery which is splitting, and they are naming the artery also. They are telling you this is the external iliac artery here. So this could be the internal iliac artery here. This is the antidivision here. This is the posterior division here. So we know that this is the obviously the right internal iliac artery which they are trying to show. So when you have this internal iliac artery and they are picking up the anterior branch and they are ligating it. Can you see there is a thread here? See, this is the thread which is going like this. There is a thread in this clamp and they are pulling it under the artery. So they are trying to ligate the internal iliac artery. So when do we do that? When this internal iliac artery, which is actually giving the uterine artery, which is the major supply of blood to the uterus, and if that is bleeding too much, if the uterus is bleeding because of any particular cause, then we must be doing this ligation. So what is the answer? So definitely, what is the common reason they are asking? See, there can be so many causes. There could be gynecological bleeding, there could be obstetric bleeding. Obstetric can be because of PPH, it can be because of placenta previa which is bleeding too much, or abruption which bled too much and the uterus is still bleeding, or a accreta more commonly than other two which I mentioned, that could be bleeding. Patient is going to shock. There are so many causes where I have to do a internal artery ligation. But which is the common cause, which is the more likely cause, and the cause which is important for basic knowledge for you people? What can cause more bleeding in obs and gynae than any other causes? Definitely PPH. So internal artery ligation you should know, which has been discussed many times in your app, and I have taught you about this, and I have also told you that atonic PPH may require internal artery ligation if nothing else works. Okay, so the answer is atonic PPH. Now DUB after hysterectomy, now this is a choice, I don't know, some 3 students have recalled this, so I could not help but keep it here. So bleeding after hysterectomy, I think that's what the student meant. Dysfunctional uterine bleeding actually means that the uterus is intact. Okay, so the choice is also not very appropriate, but I recalled it so that more people can relate with the choice which you people gave me. So yes, bleeding after hysterectomy, yes, I can do after hysterectomy also. If the hysterectomy has been done and the bleeding not stopping, I have to go and do the ligation of the internal arteries. Yes, correct. And it can be bleeding from a CS cervix. See, vulva, I don't ligate the internal artery usually. Obviously, I will be doing some local radiotherapy which is known to stop bleeding. I will be doing local measures, okay. Definitely not. So out of A, B and C, 3 good causes for which I can do an internal artery ligation. Definitely the answer which is more likely to be seen causes is the PPH because of atonicity. So the answer to this question is B, okay. So let's move on and see question number 10. A male had a vasectomy 1 month ago. Even after the procedure, his wife is now pregnant. That is, they are having intercourse after vasectomy because the husband thinks he is safe now. What happens that the distal part, you know, this is the testes and this is the vas, and this vas, of course it goes through the prostatic part, and then it it becomes the ejaculatory duct, and then it comes into the urethra. I'm just making a shortcut here. So suppose you've ligated here, you've done the vasectomy here. This whole passage, this passage which is distal to it, this much passage will be having sperms still. So the distal part to the block will still have sperms, and those sperms may take almost 3 months to totally go out of the body of the. So the reproductive tract still may have sperms. So 1 month is not enough. Even this month, if they've been having intercourse, they should have been told that they should have intercourse with a barrier at least. So the problem is that he's not been properly counseled. He should be counseled that at least for 3 months he should be using barriers or some other method of contraception which the couple decides, or for 20 ejaculates. We used to be taught, when I was in MBBS, I was taught 3 months and 30 ejaculates, but Williams Obstetrics says 3 months and 20 ejaculates. So that's what has been mentioned in the app also. So for that time, they should be careful, 3 months or 20 ejaculates. Okay. So what advice should have been given? Abstinence? No, abstinence is a impractical advice. Use condom for 3 months, maybe this is a good answer. Abstinence? No. So OCP is for 1 month for the wife, 1 month is again not enough, and 1 month of hormonal contraceptive, again not enough. Alright. So the answer to this question is A. So sperms can be seen in the semen up to 3 months after ligation. So repeat semen analysis after 3 months, and if azoospermia is recorded, then they can have unprotected intercourse. So after 3 months, we must do the semen analysis, and that should show azoospermia. So what are the recommendations? There are a lot of recommendations. They say at least 2 semen samples. Semen will come out, but it will not have sperms. After vasectomy, there will be semen. There will not be sperms in the semen. So I should say semen analysis should be done, and that should show no sperms. They should show azoospermia. So that has to be documented. After that documentation only, you will tell the person that you are now free to go and have unprotected intercourse. Okay. So generally we do it after 3 months, but the recommendations, the American recommendations are that you must do one at 8 weeks and one at 16 weeks, that is 2 months and 4 months. Some books say once after 3 months, but if they ask you 2, what is the interval? You can say 1 at 2 months and 1 at end of 4 months. Okay. So that is a recommendation by the Americans. There are so many recommendations that I don't want you to get confused. Roughly, if they ask you once, then you just say after 3 months, do a sample. If it is spermia, he is safe to have unprotected coitus. Okay. Question number 11. A 38-year-old para 3 live 3 woman presents with severe secondary dysmenorrhea. And now there is no amenorrhea here. Okay. Secondary dysmenorrhea. That is pain which is starting good 3-4 days before the periods and lasting throughout the periods. Suppose she is bleeding for 5 days, she is having pain for those 5 days also, in addition to the 3-4 days before. That is secondary dysmenorrhea or congestive dysmenorrhea. On ultrasonography, there is a uniform enlargement of the uterus up to 10 centimeters. Uniform enlargement generally goes against a fibroid. They are trying to tell you it is not fibroid by this uniform enlargement. Although it can be 10 centimeters easily, a fibroid can be way bigger than 10, it can be 20-30 centimeters fibroids also. Okay. What is the provisional diagnosis? So para 3 live 3, multiparous woman, uniform enlargement, and severe secondary dysmenorrhea. Some people use the term progressive dysmenorrhea, a condition called adenomyosis, because in fibroids also you can see congestive, but it is mostly I think mostly because of fibroid there is a lot of spasm of the uterus. So there can be spasmodic dysmenorrhea also in fibroids. So the problem is that those spasms can cause pain, but they can be secondary dysmenorrhea also in fibroids, and mostly that is how they present. But the uniform enlargement is going against a fibroid. 3 children again goes against a fibroid, because such a big fibroid causing pain is generally a multiparous woman. It does not go, because a woman with fibroids will not have so many children easily. There will be more infertile women and maybe just one child with fibroids, not too many. So it goes against a fibroid by the history itself. So the answer here is adenomyosis. Adenomyosis uterus, remember, it is never more than 14 centimeters, or some books says never more than 14 weeks of pregnant uterine size. PID, the uterus will never grow so big in a PID. Uterus will never grow to be enlarged. It will be a little congested, correct, but it will not be swollen. It will not become 10 centimeters in size. Fibroid could be a second choice answer here. My best answer here is adenomyosis. Endometriosis again definitely not. So, this is a could be answer. Definite answer of this question is adenomyosis. Alright. You know adenomyosis, don't you? It is adenomyosis is basically the blood of the uterine cavity is going out of the cavity. From the cavity it is going out and it is going to the uterine muscle. It is making lakes of uterine blood, endometrial blood in the uterine cavity. But sometimes these lakes are not seen. Sometimes just specks of this is seen, specks of endometrial blood in the uterine muscle, and this blood causes a reaction and the muscles become hypertrophied around these small deposits of endometrial blood, and those can cause myohyperplasia. So, uterus is generalized enlargement of the uterus is seen like that. Okay. So, that generalized uniform enlargement is significant of adenomyosis. So, answer is adenomyosis here. You can see here this MRI picture, and I will try to trace the uterus for you. See, this is the uterus here, this is the uterus, and this is the cervix here, and this is the endometrium here. Can you see this? And now you see this, there is a lake of endometrial blood in the uterine muscle. Then there are these specks of tissues. Can you see these white things on the MRI? They are looking like this. There are specks of myohyperplasia, which will become a little hyperechoic. Even on the ultrasound you can see something like this. Okay. So, this is the uterine cavity and all of this is hypertrophied uterine muscle. Okay. So, this is a case of adenomyosis. Question number 12. A patient presented with bleeding per vaginum in labor and a tender tense abdomen on palpation. So, she is in labor, let us say she is a term patient who is in labor. I mean, they have not specified preterm labor, anything like that. So, let us assume she is term. Her blood pressure is 150 by 100, which is high, cervical dilatation 5 centimeters and fully effaced, that is she is in established labor. So, there can be pain abdomen, but there is bleeding per vaginum and tender and tense abdomen. So, the uterus is actually whenever you palpate the abdomen of this woman, it is tense, always tense. So, uterus should relax between two contractions, isn't it? So, this uterus is always tense, and when you put your fingers on the uterus, it is tender, it hurts the woman. So, tense and tender with bleeding per vaginum, classical description of a, yes, abruptio placentae. So, painful bleeding, that is abruptio placentae. Painless bleeding we say placenta previa. So, its a likely diagnosis is abruptio placentae. It can be placenta accreta. Placenta accreta does not bleed before the woman has delivered. Placenta previa can bleed like that before the woman has delivered, but tense and tender associated with hypertension. Oh, I forgot to mention hypertension's significance. Hypertension and tense and tender uterus, that is definitely abruption, because abruption is mostly related with hypertension. Alright. So, this is definitely answer is abruptio placentae and not placenta accreta, definitely not placenta previa. Vasa previa is again painless bleeding. Alright, vasa previa is the vessels of the baby, the umbilical vessels without the cord, the naked vessels are going over the internal os and they break up and start bleeding. So, answer is abruptio placentae for this. Question number 13. A patient was using intrauterine contraceptive device as a method of contraception. After 2 months of usage, she presented with a repeated blackouts, syncopal attacks. Both these choices were recalled by students to the emergency room. What is the likely cause? So, with an IUCD as a contraception and the woman has now come with blackouts, they are trying to tell that after 2 months of IUCD, she probably has conceived with an IUCD. That is why, because IUCD per se causing a shock is very rare. Yes, we know IUCDs can cause infections, it can cause PID, it can cause sepsis, and sepsis can cause shock. That is a little rare for her to present in such a drastic thing. She would have come to you with discharge per vaginum, and she could have come to you with foul smelling discharge, uterine tenderness, fever, something should have come to you with. Coming straight away with a shock, no. But acute presentation with a shock can happen without any knowledge in ruptured ectopic pregnancy. So, yes, I think the answer here is not anything else but ectopic pregnancy. But yes, recurrent abortion, no, I mean, there's no such history suggestive here. Sepsis can be a second cause. So, this is my first cause. Sepsis can be a cause. Coagulation abnormality, not likely as yet. Uncontrolled sepsis, uncorrected sepsis can cause any problem later on, can cause DIC also, but that's not the cause here. The answer is definitely ectopic pregnancy. Now, I want you to recall one part of ectopic pregnancy information which I have given you, that a normal woman, when she has a pregnancy, the chance of that pregnancy to be in the fallopian tube is just 1 to 2%, 1 to 2%, and in the uterus it is 98 to 99%. When a woman is having an IUCD and now she conceives, where is the pregnancy? She has a IUCD in situ, the thread is coming out. Now she conceives, where is the baby? Now don't say it is always an ectopic. Now that's what is a problem. IUCD increases ectopic, not at all. If at all she gets pregnant, more likely to be ectopic than normal woman. Let me explain what I said in this last statement. If 100 women using IUCDs conceive, suppose there are 100 failures, there are 10,000 women who are using IUCDs and 100 failures, that means 100 women are pregnant with IUCDs. So, those pregnant women with IUCDs, where will the baby be? The baby will be in the uterus 95% of times. Yes, the incidence of ectopic will increase if at all she conceives. Overall, the incidence of pregnancy with IUCD reduces, incidence of ectopic reduces. With an IUCD conceives, she conceives, rule out an ectopic. That's the only information which is important. So, don't think that IUCD is equal to ectopic pregnancy, then nobody will use IUCDs. It is one of the favorite methods, isn't it? Remember, I used to teach you, fill it and forget it. Put an IUCD, don't have to remember about contraception every time a couple has intercourse, isn't it? 5 years ka chutti ho gaya. Doesn't have to bother about contraception at all. So, please do not be under the misconception that IUCD is equal to ectopic. They have given you this question to make you think that yes, it is a complication of an IUCD with the pregnancy, can be an ectopic, which is the answer here, but do not think IUCD is equal to always ectopic. Okay? During a laparotomy of a 60-year-old woman, a mass is seen next to the uterus as shown in this picture. So, okay, fine, this is the uterus and this is the mass which they are trying to talk. This uterus also, this much only is the uterus actually, and this is maybe another mass on the other side of the ovary. I can't make out left or right here. So, here there is a large mass next to the uterus as shown in the picture. Large mass next to the uterus in a 60-year-old woman. Look, ovarian masses, ovarian tumors, generally the peak age of incidence is the 6th to the 7th decade, that is the 50s to the 60s. So, this is a woman of 60 years and there is a mass next to the uterus. For all PG entrance exam and for FMGE exam, the answer is ovarian tumors, alright. So, this is ovarian tumor or ovarian cancer, yes, and hydrosalpinx cannot grow so big, and hydrosalpinx is not, this is not the time for presentation of a hydrosalpinx, okay. And fibroid, yes, adnexal tumors can be fibroids, a pedunculated fibroid, yes, it can be a pedunculated fibroid, a uterus is like that, and this could be, there could be a fibroid also presenting like that, a subserous pedunculated fibroid, but the age is against that. A large fibroid will present before 50 years, around 50 years or 52, 53, around menopause or maybe just afterwards. It cannot happen that there is a fibroid which is an estrogen dependent tumor which is growing because of high estrogens. Now the woman has stopped periods, she is menopausal, she is 60, now the fibroid presents. That is the rarest of presentations of a fibroid. So, it can be, if this was a 45-year-old woman with a adnexal mass which is big, I could have said fibroid, I could have said ovarian tumors, but the age is 60 years and there is a large tumor next to the uterus, most likely it is a ovarian tumor. And fibroids are not so commonly subserous. Fibroids are mostly, I mean pedunculated subserous not so common, they are mostly intramural fibroids which are common. So, that is why it is going against a fibroid and the age is definitely against it, okay. So, yes, tuberculous TB adnexa does not come with such a huge mass, it is generally just a swollen ovary, a hydrosalpinx tube, slightly bulky adnexa, not such a huge adnexa, alright, and there will be collected fluid between the bowel, what we call that as encysted ascites, that can happen, but not definitely like this. So, this is not tuberculosis also. And tough question again, But since a large mass next to the uterus, that's also easy at the same time. Question number 14, answer is A, ovarian cancer, large biloculated cystic adnexal mass in position ovary with a lot of vascularity, ovarian cancer. Question number 15, a lady during labor presented with persistent occipito-posterior presentation, okay, occipito-posterior, and manual rotation was tried, but it was unsuccessful. That is, the fetus is, look here, if there was a pelvis something like this, that is a gynecoid pelvis, okay, pelvis is rounded, in front also it is a little rounded. So, if there is a baby like this, if I want to rotate it, you know, I can put my hand inside, hold the head of the baby and rotate, because this is posterior, this is anterior, and I want occipito-anterior delivery to happen, then I can rotate this like this and it can become this way. So, that is what is known as the anterior rotation. It is possible. Occipito-posterior can become occipito-transverse and then it can finally become occipito-anterior also. It can spontaneously happen or you can do with your hands also. But if the pelvis is somewhat like this, straight side walls, if the pelvic walls are so straight and the baby is like this, see, there is no place for the baby to turn. This action cannot happen, this turning action cannot happen, this is posterior, this is anterior. So, this is a gynecoid pelvis and this is the next common pelvis known as anthropoid, straight side walls. When the side walls are straight and narrow also at the same time, then the turning of this is not possible, this cannot happen. So, manual rotation was not possible. This we have explained in the labor video, and even for the MCI video we have told you this very nicely, that in a case of occipito-posterior delivery can happen. In occipito-posterior it can spontaneously rotate to anterior and deliver, which is the 80% times, or it can stay occipito-posterior and deliver face to pubis. Remember I told you the occiput is posterior, so the face will be anterior. So, that is face to pubis delivery can happen, or it can come and get stuck in occipito-transverse. I can do a manual rotation. Okay. Now, they have asked that it is already a case of occipito-posterior and you want to rotate it. Now, trying to rotate occipito-posterior to occipito-anterior is possible only in a roomy pelvis, and a roomy pelvis will be a gynecoid pelvis. So, which of the following is the type of pelvis where the rotation is not possible? So, it is the amalgamation of all the labor videos which you have seen in the app. So, if you see that, you know that rotation is possible. I have told you in my videos that deep transverse arrest is common in android pelvis, persistent occipito-posterior is common in anthropoid pelvis. That has been taught to you, and that is what has come in an applied question here. So, the answer here is anthropoid pelvis. So, you know the most common pelvis is the gynecoid, and then the next is the second most common is anthropoid, and the third most common is the android, and the rarest of the pelvis is the platypeloid. Okay, fine. So, the answer to this question is B for Bombay, anthropoid. Okay. Now, question number 16. Gravida 2, para 1, live 1. Lady underwent a LSAS in the previous pregnancy for fetal distress. Okay, fetal distress is the most common cause of cesarean section nowadays, you know that. This time, that is the present pregnancy, she is G2, you know, G2 means she is pregnant for the second time. G, gravida is a state of pregnancy. You know, don't get confused. Sometimes you say that's a woman of 60 years and how many children you have? Sir, I have 2 children. So, you are gravida 3, para 2, live 2. No, she cannot be a gravida. She is 60 years. She is not pregnant and she cannot be pregnant. So, always say P2L2. But if the woman is pregnant now, suppose it is a 20-year-old woman who has 2 children before. Now, we say she is pregnant for the 3rd time. So, gravida 3, para 2, live 2. Okay, gravida is a state of being pregnant. So, she is pregnant now because G is written here. So, gravida 2, para 1, live 1 underwent cesarean section in the previous pregnancy for fetal distress. This time she had an uneventful vaginal birth after cesarean section. VBAC, okay, we have discussed this also, vaginal birth after cesarean. It is also known as trial of labor after cesarean, TOLAC, that is also a term. VBAC, TOLAC, these are all the terms which are TOLAC, trial of labor after cesarean. So, she had a successful trial of labor after cesarean or she had a successful vaginal birth after cesarean, means the same. But the placenta could not be removed completely. The cord snapped on traction, but the plastener did not deliver. She also started to bleed more profusely now. So, you have done the control cord traction, the cord snapped, you tried harder, you maybe put your hand inside and tried to take the plastener, it did not come out completely. So, part of the plastener is stuck. So, they are trying to say there is a previous cesarean, and when there is a previous cesarean, there is a scar on the uterus, and this scar on the uterus probably has a placenta stuck to it very, very badly. So, this scar here and the placenta is stuck to it. So, that is what is known as a placenta accreta. One of the common causes of placenta accreta is a previous cesarean section, and now there is a lot of controversy. Williams Obstetrics definitely says that placenta previa is the commonest cause and previous cesarean is the next common cause. A placenta which is stuck to the cesarean scar or any part of the uterus, but where there is a scar, there are more chances of placenta accreta as compared to normal uterus. So, yes, it is stuck to the uterus and not coming out, it is a placenta accreta. It cannot be section sutured lobe because the placenta is not totally removed. You remove the placenta, you are satisfied it is completely removed, and then later on the ultrasound you see a small lobe inside, because the whole placenta, this whole lobe of placenta was removed, but a small lobe of placenta, the suction sutured lobe, stayed back. So, that is not the cause here. Inversion of the uterus, you would have seen the uterus will invert, so that is not the cause, and placenta accreta is definitely the answer. Placenta previa will bleed before delivery, not after delivery so much. Okay. So, answer is placenta accreta. Question number 17. Patient had history of severe heart disease and she is now, that is severe heart disease NYHA 3 and 4. Now, she presented with a large fibroid. So, large fibroid, that means probably they are planning a surgery, since anesthesiologists have been mentioned here. Anesthesiologists classified her as a moderate risk. I hope this was the language of the question. I think the anesthetist will also take this question in the discussions. Which procedure is not to be performed in this risk patient of heart disease? She is a case of heart disease, severe heart disease. She is anyway NYHA 3 and 4 when she is a severe heart disease, and it's a moderate risk, that is she can die in the surgery also. That is a moderate risk of that happening by the anesthetist assessment. So, what should not be done? So, she can die during a total abdominal hysterectomy, when we open the abdomen and do the hysterectomy, or a vaginal hysterectomy, either way she can die. Now, vaginal hysterectomy cannot be done for a fibroid. Generally, this is not the answer here. I mean, like, some of us can do vaginal hysterectomies for a fibroid also, but those are rare surgeries. So, do not get confused with such rare information which you may be having. So, this is not to be done. We can do a total abdominal hysterectomy, that itself is a risk. We can do laparoscopic hysterectomy, we can do subtotal hysterectomy. These are the options. Definitely vaginal hysterectomy is not the option. Now, out of these three options, subtotal hysterectomy is outdated. We do not do subtotal anymore. We do a total removal. While the cervix inside, and if you are not able to do a total hysterectomy because the cervix was stuck and there was very large amount of adhesions and there was lot of difficulty in surgery, and you could take out only uterus and the cervix had to be left back. These are very rare things. I mean, subtotal is totally out of work. Nobody does that. Because some reason you had to do is a different thing. So, subtotal is not done. So, this is also out. Now, that leaves us with two choices here, that is total abdominal hysterectomy and laparoscopic hysterectomy. So, between these two, which is a safer surgery now by this question, which is safer for this patient? Total abdominal hysterectomy can also kill her, but more risk is a laparoscopic hysterectomy. Why? Laparoscopic hysterectomy will definitely take more time than a open hysterectomy. And when you are doing laparoscopy, you are distending the abdomen. Distending the abdomen will also cause the diaphragm to go up, and that will compromise the breathing of the patient. So, you will have to go on pumping so that the lung will expand in spite of the increased pressure in the abdomen. So, that will cause lot of problems with the CO2 retention and the acid base balance of the patient, and there could be a lot of CO2 retained in the patient when there is a laparoscopic surgery done. In normal patients also, in this patient who has got a heart disease, the cardiac function is compromised, the oxygenation is compromised as it is. So, such patients who are high risk for surgery, we do not do laparoscopic procedure. Okay. So, the definite answer, there is no doubt about this answer, that I will not do a laparoscopic procedure. The answer for this question is definitely C. Positive pressure pneumoperitoneum with CO2 has deleterious effect on the cardiovascular system, definitely. Now, question number 18, first sign of magnesium sulfate toxicity. At last, one simple question. Magnesium sulfate, 4 to 7 milliequivalents per liter should be the level, and that is the time, that is the level at which you can stop the convulsions. But yes, you must also understand that if you are not very careful with the monitoring, I have always told you that when you are giving magnesium sulfate therapy and after giving the loading dose, that you have done loading, after that you must give the maintenance. Now, when you are giving the maintenance, that time you must give it 4 hourly, we must give 5 grams intramuscular. Now, that is the maintenance dose. Now, you will give maintenance only when the respiratory rate is more than 12 at least, but I would say 14 and more. At least 12 definitely, but we say 14. Okay. Now, you will say which book says this, which book, I mean please do not get into this confusion. At least 12, correct, I agree with you, but at least 12 is the basic requirement. So, 14 and more is good practical knowledge, and the output of urine should be more than 100 ml in the last 4 hours, and the knee jerks should be present. So, these are the prerequisites before I give the next dose. So, first sign of magnesium sulfate toxicity, I am going to give the next dose. After 4 hours, I am going to give, I have loaded the 5 grams, and 5 grams is loaded in 10 ml of volume. So, that 10 ml of injection I am going to give. Before that, I must see the knee jerks, the respiratory rate and the output and all, and I see that the knee jerks are absent. Now, that is the first sign that the magnesium is too much in the circulation, because that causes cerebral separation. To stop the convulsion, you need cerebral separation, but there is so much of separation that the reflexes are being lost. So, now do not give the next injection. So, magnesium sulfate toxicity, first sign is loss of the deep tendon reflexes like the knee jerk, or we also call it the patellar reflex. So, yes, this is something which is given in your question bank and also in your app videos. So, 4 to 7 milliequivalents is the level which is normal therapeutic level, 8 to 10 patellar reflex is lost, and 10 to 15 there is respiratory depression, 12 to 15 respiratory paralysis, and 25 to 30 there is cardiac arrest. And of course, the antidote for magnesium sulfate toxicity is calcium gluconate. Alright, question number 19. Identify the X-ray shown here. Now, this is a X-ray of a radiograph rather of a hysterosalpingogram. It is showing you the cannula, this is the leech cannula, this one, this is the cannula, and they put in the dye. The dye have gone just this way to the uterus, and it's looking like a very small uterus. So, yes, you must see a uterus something like this. You must see a full cavity within itself like this, and this is how you must be seeing. Okay, and then you will see the fallopian tube which they are patent or not, the dye will come out here. So, yes, in this patient, what you are seeing? You are seeing that there is only one horn seen. So, the uterus is made up of 2 horns, and you are seeing only one horn here like this. So, yes, if both the horns are seen and the uterus is a nice cavity, then we say it is a normal uterus, but now you are seeing only one horn, then we say it is a unicornuate uterus, is not it? Septate uterus would have looked something like this on the hysterosalpingography. You would have seen that this would have been dark, like this, and this cavity would have looked like that. So, that would have been a septate, but this is a case of unicornuate uterus. Bicornuate, you will see still wider, you will see something like this, that is the bicornuate uterus. So, it is not septate, it is not bicornuate. Diadelphys, definitely not. In diadelphys, you will see something like this, you will see one uterus here and the cervix here, and you will see the vagina like this, and you will see another cervix here like this, and vagina like this. This is what sometimes I like to show you diadelphys. Recently, I was operating on a patient, and we had the HSG of this patient also, and diadelphys uterus is something like this. So, definitely the answer to this question is a unicornuate uterus. Okay. Unicornuate uterus, what it can do? It is a small uterus. So, what do you do for the treatment? You do not do anything for the treatment. Unicornuate uterus, the other horn is not there. It is a small uterus, we agree. It can cause abortions, it can cause preterm labor. But most of the times, preterm labor is generally around 35 to 36 weeks, and we are able to give a live baby. And there are numerous instances where a unicornuate uterus has given a full term pregnancy. So, yes, it can cause preterm labor, it can cause abortions, but yes, mostly it comes to us with a late preterm labor around 35, 36 or term labor. Okay. So, unicornate uterus, there is no surgical correction required until unless there is too many problems, and those surgical corrections are very, very rare surgeries, alright. So, just forget about that. Unicornate uterus, abortions, preterm labor or term deliveries, these are what you generally see as the presentations. Okay, question number 20. A 19-year-old girl with primary amenorrhea and normal secondary sexual characteristics. Primary amenorrhea, 19-year-old girl not having periods so far, okay. Normal secondary sexual characters. So, she is a girl with normal secondary sexual characters. So, that means maybe the brain, hypothalamus, pituitary, everything is fine, the secondary sexual development has happened, that means growth hormone, GnRH, everything is okay. Now, she is not having periods. So, on examination, that is on a pelvic examination, uterus was absent. So, it does look like a case where there is a end organ, that is the uterine deficiency, either the uterus is absent or the uterus is totally scarred because of tuberculosis which started early, that can also be a cause. But yes, more likely that the uterus is absent. She has never had periods, and when you do a PV, you do not feel a uterus. Next, what will you do? I will definitely do an ultrasound to confirm what I saw on the per vaginal exam or the per rectal exam. Also, when I did see that I didn't see that there was a uterus. So, I will confirm my finding with the ultrasonography first. So, karyotyping I will definitely do, but karyotyping is generally a confirmatory thing. See, a clinical suspicion and clinical assessment and a diagnosis should be made in the OPD. Then you have investigations to support your suspicion or disregard your suspicion and give you some other answer. But as clinicians, you must have your answers in the OPD itself. You would have made a diagnosis, a working diagnosis of this likely, maybe this. So, yes, this is definitely look like a case of a Mullerian agenesis, or also known as the Mayer-Rokitansky-Kushner-Hauser syndrome or Mullerian agenesis. So, this does looks like that, uterus was absent, and the next investigation to be done, confirmed by an ultrasound whether the uterus is small or it is totally absent, or wait, there is no uterus inside, in fact there are no ovaries, there is undescended testes. Is it a boy with testicular feminization? That also can present like this, but in testicular feminization, why it cannot be testicular feminization? Because secondary sexual characters are there. In testicular feminization, that is the only clinically distinguishable sign, that in testicular feminization there are no secondary sexual characters. Okay. So, this clinically itself I have the diagnosis, I will confirm it with ultrasonography, and later I will definitely do the LH and FSH to see whether it is high or low. In this woman it will be definitely normal, because there is absence of ovary, there is absence of uterus, ovary will be working, ovary will be ovulating, but there is no uterus. So, LH and FSH will be normal, just that there is no uterus and there is no periods. Okay. So, I will do all of these investigations, but definitely first is ultrasonography, and I will do the LH and the FSH. I will also see the estradiol amount, and I will definitely do a karyotyping later to confirm my suspicions, but not the first. So, definitely not karyotyping as the answer, ultrasonography first is the answer. USG will be most helpful to know presence or absence of uterus, which we already know in the examination here. So, yes, next we will do the karyotype. So, what I had a suspicion in the clinics, I will do the confirmation on the ultrasonography, and then I will do the karyotype to get the final answer. In this condition, MRKH and androgen insensitivity are the two main things on my mind. Okay. Let us see question number 21. A 29-year-old nulliparous lady presents with endometriosis and infertility. On laparoscopy, there were severe pelvic adhesions and the uterus had bowel stuck to the fundus with dense adhesions. The ovaries were cystic, each was around 6 to 8 centimeter in size, and both were stuck to each other, kissing ovaries like we call them. So, this is endometriosis with the ovaries stuck to each other, and the patient has infertility, she is 29. And more or less this question is correct, because I posted this question to a few of my acquaintances in your students, and I posted also on the Facebook. They said more or less these are the this was the language, and GnRH and looks can be given. OCP is hysterectomy with oophorectomy, bilateral cystectomy with adhesiolysis. These are the choices. Now she is 29, she is infertile and she has endometriosis, severe adhesions and a cystic ovary of 6 to 8 centimeters. So, if she wants to conceive, what are you going to do first? If she wants to conceive, these cysts have to be taken out. So, on laparoscopy they have already said they were dense adhesions. So on laparoscopy, when there are dense adhesions and there is this cyst, I would definitely take out the cyst. I will remove the bowel adhesions from the uterus. I will remove the ovaries from kissing each other. I will do the enucleation of the endometriotic cyst, and I will try to save as much of ovarian tissue as it is possible. So, I will definitely do a surgery. Yes, it is a time consuming surgery. Laparoscopic adhesive can take the genie out of you. It will be a long surgery, it will be a back breaking, long standing position. You are standing with two, instruments in your hand, you are looking at the camera and operating, and it can be a very tiring surgery. Sometimes endometriosis takes 4 to 6 hours because of those dense adhesions. So, I will definitely do a surgery. It will be a demanding surgery. I will do adhesive lysis. I will remove the cysts, and then I will want this patient to undergo the infertility treatment. So, bilateral cystectomy, adhesive lysis, prepare for IVF. Was this a choice? I mean, maybe I want to say start infertility treatment next, which could be intrauterine insemination if the tubes are good, or it could be in vitro fertilization. So, I do not know whether the choices have been recalled properly, but definitely I will do a surgery here. So, not hysterectomy, she is infertile. Hysterectomy, oophorectomy, if she has completed a family and she is beyond 35 years, maybe this could have been the answer, but definitely not. OCPs, Gianna logs, you are doing a laparoscopy and you have big cysts in the patient's scene. To close and just give GnRH and OCPs, that is what something we give for very young girls who do not want a surgery right now. When there is a big cyst and there is adhesions and she is infertile, I like to correct all of that and then do the treatment of infertility, which could be IUI, intrauterine insemination, or IVF. Again, tough question, but if you look at the situation given to you, definitely the answer should have been surgery and management. Okay, so answer is D, and I have given a picture of one of my patients. Unfortunately, the picture of the adhesions just like this, I mean the question which was asked, and just like that I had this patient, and if you would like to see that, you will appreciate that this patient is having some cautery marks here. There was bowel stuck here. See the question, they were bowel stuck to the fundus with dense adhesions, pelvic adhesions, and they were kissing ovaries. All of that was there in this patient. Somehow that picture I could not get to you because the resident who has them is not well, she is not with me, and I could get the picture in my, and see, if you can see, this is a screenshot. This is a picture taken by a camera, by a phone held camera, and it is not the recording of the surgery which is done by very sophisticated instruments. So, since it was your discussion here, I got this picture to tell you that there was adhesion here, and can you see there is an ovary here and this ovary here. See this, there are cautery signs even on this ovary. That means this ovary and this ovary were stuck. Can you see the cautery signs here? The ovary was stuck to each other and they were stuck in the pouch of Douglas, and the bowel was stuck to this. So, everything was totally having adhesions, and just like I told you, when we have such patients, we will take the effort of doing a proper clearance. And see, this actually looks, I mean if I show this picture to you once again, this is the end op result for this severe case of endometriosis. Question number 22, a 52-year-old female came with 16 months of amenorrhea. The test results that would expect would be 52-year with 16 months of amenorrhea. Now, when it is 16 months, anything more than 12 months, that is 1 year, is known as menopause in this age group. Now, she has reached menopause, that is why she is not having periods. Now, when she is not having periods, what would be the test? By the so many times we have discussed the GnRH pulse and the LH and FSH. So, if you see this diagram here, that the hypothalamus acting the pituitary and FSH and LH is released. Now, if the woman is getting to have ovary function, then only estrogen and progesterone will be made. But now the woman is 52, so the ovaries are already old, so there are no follicles, so there is no estrogen, there is no progesterone. So, when this estrogen progesterone is not there, this feedback of estrogen progesterone to the brain is not there. So, the brain will stimulate the pituitary that okay, go and make more FSH and more LH, so that the ovary is stimulated, but there is no ovary to respond. So, what happens when there is no negative feedback? Hypothalamus goes on stimulating the pituitary with more GnRH, and the FSH will increase and the LH will increase. So, that is a hallmark of a menopause woman, that there will be a high LH and a high FSH. That is the answer to this question. Of course, this can also happen in some other situations. You could have a woman who's had a oophorectomy, let's say she is 40 years and you did a hysterectomy for a large fibroid and you also took out the ovaries. So, then also again this situation can come, there are no ovaries and the hypothalamus go on acting on this and there will be high LH and high FSH. So, it can happen even after a surgical failure, surgical menopause and surgical ovarian failure also same values will come. It can also happen when a woman has ovaries getting destroyed. You gave radiation to a woman, let's say for a CT scan for a road traffic accident of a pelvis or of a thigh, I mean there was a femur fracture and you did a CT scan twice or thrice, all that radiation also can spoil the ovary. Again, she is only 25 years and the radiation has spoiled the ovary. So, when the radiation spoiled the ovary, again the ovary will not make estrogen progesterone and the FSH LH will increase. So, the same picture you will see in menopause, also in ovarian failure, which is premature ovarian failure, also you will get the same picture. I am telling you extra stuff because the same question can be asked in a different way next time. Alright, so the answer to this question is menopause. Now, question number 23 was this one line which I got, and which is the hormone responsible for lactation? LH, FSH, GH, they have some peripheral role, but definitely the only hormone which is coming close to lactation here is oxytocin, because once the baby suckles on the breast, the feedback makes the oxytocin come out, and that oxytocin, when it acts on the myoepithelial fibers, it causes a contraction. So, the milk let down will be because of this oxytocin. So, I would have loved to see prolactin here and oxytocin. Prolactin and oxytocin together is the answer, that is the best choice, but they have given only oxytocin, go with that. Question number 24, minimal antenatal visits required according to WHO. Now, when we think in terms of minimal visits, in our country the healthcare facilities were so limited. So, earlier we used to say at least 3 visits hona chahiye, 3 visits. First trimester there should be, first or second trimester together there should be 1 visit, and in the third trimester there should be 2 visits. This is what we used to read as MBBS students. Then now the WHO recommendation was that should be focused ANC management, focused ANC, that is FANC, focused antenatal care. In focused antenatal care, they said that there should be at least 4 visits. So, 1 should be in the first trimester and second visit should be in the second trimester and 2 visits in the third trimester. But that was till 2016. Now they say that there should be 1 in the first trimester, there should be 2 in the second trimester, and there should be 5 in the third trimester. Now, this is what is the protocol ever since 2018 onwards. So, if they have asked WHO, all the references of WHO now say that there should be at least minimal 8 visits, I mean, I will be really happy if women come 8 times in my country to show me in the antenatal period. I mean, that will be the perfect thing, because nobody says that 3 or 4 is enough anymore, because they say that is known to give so many complications. So, if you really want to have a minimum, make it 8. You can have as many visits, and the visit should have a direct contact. Visit should not be the word used, that is also the recommendation by WHO. Visit should not be the term used. You should say contact. The patient should have a contact with the healthcare worker or doctor especially, and that doctor should see a patient properly at least 8 times. More than that, even better. So, now answer is 8. So, those who answered 4, unfortunately that is a old recommendation of WHO, and what I was taught 3 is not even a choice anymore. Alright, so the answer is 8. Okay. So, question number 25, which of the following is a drug used for dilatation of the cervix? I think all of them will cause dilatation. If you give these prostaglandins, they cause contraction and eventual dilatation, but primarily dilatation is the question, and the only method which directly causes cervical dilatation, that is a laminara tent. It is a seaweed which we put into the cervix around 6 to 8 hours, and when you put in the cervix, it will absorb the fluids, and hygroscopic action we call it. This will start getting swollen, and that swollen tent, laminara tent, seaweed, this swollen seaweed, as it swells up, it'll dilate the cervix. So when it has got a thread attached to it like this. So you just pull the thread out, cervix is dilated, you start the oxytocin or give some prostaglandins to complete the abortion. Okay. So primarily causing dilatation is laminar tent. Was dilapan a choice? I mean, if both were the choices, then it's really tough for me to answer, because both are used for primary cervical dilatation. Dilapan is another, it's an artificial thing which is again based on hygroscopic. So seaweed is laminar tent, dilapan is artificial gel kind of thing which goes into the cervix and it swells up and causes dilatation of the cervix, and it's a sterile gel kind of instrument. It's a instrument which you put in the cervix. Again, it works on the hygroscopic method of swelling up when it is placed in the cervix. So if both of them were given, then it's an unfair question, I think. And I hope both are not the choices. Okay. So in the choices which have been recalled by a few more students than others, laminar tent is the best answer here. Okay. Question number 26, medical termination of pregnancy cannot be done under which of these following situations? For a large family, I mean, I have too many children, I am pregnant, please take this child off. You should have been smarter before. I am so sorry, I can't do abortion now. For large families, definitely not a indication. Failed contraception, disability of the fetus, harmful to the mother, definitely indications for doing an MTP. And large family is definitely not the answer here. So MTP indications are continuation of pregnancy is a risk to the mother's life. She's a severe heart disease case, or she's a severe aortic stenosis where she should not be conceiving. She's got a Eisenmenger, whatever, she's going to die because of the pregnancy, abort. Substantial risk to the fetus, anomalous baby, a large diaphragmatic hernia with pulmonary artery hypertension developing, or a patient having anencephaly, or a large hydrocephalus, baby cannot survive, or any such disorder which is going to cause a deleterious effect on the baby's life. So those babies should be aborted. Pregnancy due to rape, self-explanatory, doesn't want the child because she's been raped, and contraceptive failure. You know what? The most common indication for which abortions is done in the country is this: contraception failure. Women just walks into a clinic and says, sir, I want to abort this child, and you say, why? Because we did not have a contraception, or we used a contraception, it did not work. Basically, we don't even ask this question because she can say anything. I mean, abstinence is a form of contraception. We had sex and we had pregnancy. So, or we did not do abstinence. So that is also conception failure, isn't it? So it's a virtual certificate for any woman to get an abortion done at her will. So yes, contraceptive failure is a common reason for which abortions are done. Now, the question which all of you have always asked to me, and as recent as 4 hours back on the Facebook, I was answering this, that what is the time of doing MTP in India? Now, please, for God's sakes, this is September when I am doing this recording. Your exam was on 31st of August 2020, and this is September when I am doing your recording, and so far no such ruling has come. Abortion is 20 weeks or lesser. Yes, and those who are saying 24 weeks are not correct. 24 weeks is in the West. 24 weeks is a proposal. We have proposed to make it 24 weeks. That proposal has not been tabled yet. The parliament has to be in session, and the parliament has to pass this. Then the Lok Sabha and the Rajya Sabha, then it has to become an act. So it has not gone under all that. Yes, this proposal has been given many times. It's been made a proposal, it's been made a bill, but it has not been passed yet. So for it to become an act, it has to be passed by the parliament. So please, some of you are under the misconception that you've been taught by somebody, and I don't know, there's so much of confusion about this. For God's sakes, and all of you who are my MCI students, and if some PG students are seeing this, please understand there is no change in this. It's 20 weeks still. Now, there are a lot of anomalies. There is anomalies missed by some radiologists, he missed, and now at 24 weeks when you did an ultrasound, now the baby is bigger, and you see gross anomalies, that there is a diaphragmatic hernia, or there's an anencephaly, and there is the kidneys are missing, or whatever, non-compatible with life. Even then you can't abort. Why? Because you have to get a permission from the court. Yes, you have to get a permission from the pediatric surgeon, or if there's a cranial defect, a neurosurgeon has to say that these are non-viable with life, you can abort. Then you have to get a permission from the court to abort this. These are rare circumstances, and you can have a humanitarian discussion and the court may decide in the favor of the mother, but it's not a law yet. So don't say 24 weeks tak abortion can be done. No, that's not a law yet. Okay, so don't get into this confusion at all. 20 weeks and lesser, MTP. All right. Viability of a baby. When is a baby likely to survive after delivery? That is 28 weeks. After 28 weeks in India, we say viability. Now this is not asked. Nobody is asking this question anymore, because more and more pediatricians are working very hard, neonatologists are working very hard, and 24 weeks, 26 weeks we are able to save such babies nowadays. But this is still a grey area. So viability is 28 weeks. By most of our accounts, by most hospitals, we say viability is 28 weeks. Why they are not asking this question? Because quite a few hospitals are now trying to save babies at 26 weeks also. So that's why this question is not asked to you. But definitely 20 weeks and lesser, MTP, I'm sure of the answer. Okay. Question number 27. A multigravid grad of 4, para 3, live 3, present with labor pains. On examination, the cervix was 5 centimeters dilated and doctor was unable to feel the presenting part. What is the likely diagnosis? So, I mean, till now you were able to feel when you're doing a PV, she's gone to 5 centimeters, doctor able to feel, but suddenly loss of uterine contour, loss of feeling any fetal parts on trying to do a pervaginal examination. That's probably because the uterus has ruptured. There's a cervix which is 5 centimeters, you are able to feel with your pervaginal examination, but there's a large rent in the uterus and the baby is now in the abdominal cavity. This is the abdominal cavity, baby is somewhere here. So what you could feel, the head was coming in like that. What you could feel, that you're not able to feel because the baby is not here anymore. Baby is in fact in the abdominal cavity now. So that's because of a ruptured uterus. That's what they're trying to say here. Okay. False labor, no, 5 centimeter cannot be false labor. Abdominal pregnancy, the cervix will not dilate 5 centimeters in the first place. Okay, it's in the abdomen, it's not in the uterus. The cervix will not dilate in the first case. And abruptio placentae, loss of the presenting part, loss of feel of presenting part is not the presentation. Bleeding, tender bleeding is the presentation. So definitely these three are not the answers, and uterine rupture is the answer to this question. All right, fairly simple question. All right. So question number 28. Which alphabet shown is suggestive of ovulation? So O for ovulation, I mean they couldn't have made it any easier, and somewhere in the middle of the month, 1 and 28 they have shown, and somewhere here they have written O, and which of the alphabets is suggesting ovulation? So I think that O is suggestive of ovulation. It comes in the middle of the cycle around the 14th, 15th day. All right, so that's a very simple question. I'm not discussing this because this has been discussed many times in the app, and ovulation and the menstrual physiology, a good 2 hour long discussion has been done on the app. All right, so let's move on and see question number 29. Antibiotic of choice in UTI and pregnancy. Again a sitter, amoxicillin 500 milligrams thrice a day for 5 to 7 days is the treatment of choice. Okay, so again a simple question, I'm not dwelling on it. Do read about asymptomatic bacteriuria. All right, we've had a long discussion in this MCQ exam discussion of this particular set of questions. So I don't want to go into the discussion of asymptomatic bacteriuria, but whenever you have time, please go ahead and read about that. Okay. Then what will be the calorie requirement for a working pregnant woman? Now calorie requirement in the first trimester doesn't have to increase. In the second trimester you increase it a bit, and you increase it more in the third trimester. So the ISMR guidelines are a little different from the American guidelines. So the answer, I'll just derive it for you in the next screen here. So the ICMR says the a normal woman who is not pregnant, sedentary work so many calories, and moderate work this much, heavy work this much. So the moderate work, because she's a working woman, okay, I will not say sedentary. Staying at home and not doing much work is sedentary. Working woman will be moderate work. So moderate work is 2225 calories, and we add 300 for a pregnancy by WHO in the second trimester onwards. So moderate work 225 plus 300 is like 2525. So I will go with 2525, which is closest to C here. Alright, so the answer to question number 30 is C. Now, my Williams obstetrics, if you see the American recommendation, 0 for the first trimester, 340 for the second, and 452 for the third trimester. Now, these are findings, they are the, the calorie wise, even to the, the last fraction they are telling you that it should be 452 calories in the third trimester. So, that is what is the recommendation in the American system. So, in the second trimester it is 340. So, 225 plus 340, so it comes to 2565. So, 2525, 2565 both come by both the system, by the Indian system and the American system, it comes to around 2600 calories. And I am sure the PSM people, when they take a class for you for this, I am sure this will be part of their discussions. They will tell you more details, but the answer I am sure there also will be 2600. Okay. Let us move on and see question number 31. Identify the image, and this sent to me by a student again. You are seeing organism which is unicellular organism with the flagellum here. There is a flagellum here, there is a flagellum here. So, for me unicellular organisms with the flagellum, mostly I will think in terms of a trichomonas, isn't it, trichomoniasis. So, trichomonad is something which is trichomoniasis, something which is very irritating condition where there is severe pruritus because of these small motile flagellates moving within the vagina and causing irritation. So, there is a greenish yellow frothy discharge and severe itching, severe pruritus, a vagina which is so red that it is in it is as red as strawberries, they say, and it has got those small macules also. So, we call the strawberry vagina or a strawberry cervix. Either way, they can call strawberry vagina or strawberry cervix, both can be the questions. Alright, do not say ki strawberry vagina is in trichomoniasis, strawberry cervix we do not know. I mean, vagina and cervix are at one place. So, inflammation will happen to cervix and vagina both. Do not say strawberry vagina we know, strawberry cervix we do not know. It means the same, trichomoniasis is the answer there. Okay. So, yes, the answer is trichomoniasis, and actually I do not know what Listeria, Pseudomonas and Enterobacter looks like. So, I am not going to all that. I am sure the micro people will tell you better the differences between this, but this is a straightforward trichomoniasis and it is a gynae question. I will go ahead and tell you this, and of course, the treatment is to give metronidazole, and this you must treat the man and the woman both, because these trichomonads, these trophozoites are known to stay under the prepuce of the man. So, after intercourse, I mean, if you treat the woman, but the trichomonads are in the prepuce of the man, so he can reinfect the woman with intercourse. So, if you do not treat the man, then the treatment is incomplete. Alright. Now, there was this question on CA vulva and nobody could send me the question, and it was getting late. I thought I will send you the treatment of CA vulva. Somebody said there was a 3 centimeter lesion on the vulva and 3 centimeter lesion on the vulva and no lymph nodes. What is the management? So, I am just giving you all the stages management here. In your free time, do have a look. This is a slightly detailed treatment because CA vulva has been asked now. This is the 3rd or 4th time in the last 3 years this question has come. So, CA vulva we have taught you also, and we have told you the basic management, but I agree, this is that one question which was slightly more than what we have taught you. I have given you all the management, but in the question bank this detailed management is also there, but in the app I took it a little light for you. So, this is that one question which I will relate, that of all the questions which came, you can relate with the discussions which we had, but this was that one question which was having some bit more recall required. Okay. So, if you see that if there is a lesion which is less than 2 centimeter in size and less than 1 millimeter invasion, just a wide local incision is enough. Wide local excision is the management of CA vulva in such lesions. If it was 3 centimeters, I doubt if they would have asked you that, because without any lymph nodes and 3 centimeters, it comes into 1B. If they asked you 1B, then I will do a local excision, but a radical local excision. I will take out the tissue around it also, and depth of the tissue also removed will be more. Then I will do central lesion, I will do a bilateral lymphadenectomy for a central lesion. For a lateral lesion, I will do a unilateral lymphadenectomy. So, I think the syntax of the statement is a little problem here. So, I should have given some spacing here. For a central lesion, it is a bilateral lymphadenectomy. So, central lesion means something like this. So, vulva is something like this, and there is a lesion somewhere here. So, lymph nodes of this side and lymph nodes of this side, both I will remove. Okay. But if the lesion is lateral lesion somewhere here, there is a lateral lesion, then only these lymph nodes are removed. That's what I meant by that statement. Okay. So for a central lesion, bilateral lymphadenectomy. For a lateral lesion, unilateral lymphadenectomy is what is enough. All right. And the other stages also I've told you. I don't want you to have any detailed discussion here on C-Evolva. Please go up to the app and have a look, and this is what is the basic treatment. I've summarized it for you. Do have a look in your free time. But as I said, this exam was a little tough for all of you, and I know that you would have liked to have what was coming in all the exams earlier, but then times change, and people thought that you've been given more time than the others, and this was a good 4 months delayed exam. So you people would have read more, and since you had so much of discussions with us, I'm confident that most of you have done well. So the answers, what I have derived, that the answers, most of you were answering correct. Some of you may not know the right explanation to give me. Who cares? If you know the answer, you got your marks and you will pass. So go with the belief that the discussions which we had in PrepLadder were enough for you people, and those who have answered it correct, you will definitely pass. So don't despair with the severity of the exam, because the question ultimately was a straightforward, but they asked you in a roundabout way, because the answers were what you routinely answer, but they asked you in a clinical method to come to that same simple answer once more. All right. So I know tough days, but tough people come out of tough days always and do well in their lives. All right.
So we'll be now discussing some very important questions that came this year in the FMGE exam August 2020 based on that pattern. So basically these are recalled questions. They might not match with what the actual wordings were, but I have tried my best to collect whatever near to the exact questions that were there. But regardless of that, what is important for you to remember is, this time I'm sure all of you will agree that FMGE exams saw a radical change in the pattern. So there were more and more of clinical oriented questions, case scenarios where you have to apply your analytical skills to come to the diagnosis and answer the question. So the pattern now moved from mere one-liners to something which is more in depth. So you need to have your concepts really well. Nevertheless, these topics which were asked in the exam are very important, and you may expect similar questions or questions from similar topics in the next upcoming exams also. Okay, so let us discuss the questions that came this time one by one. From pediatrics, there were almost 20 plus questions that were there. So it becomes again a very scoring subject for you. All right. So let's begin. What should be the best initial method for feeding a baby born at 33 weeks gestation? Okay, with no perinatal complaints. So in our videos on neonatology, we have already discussed about the feeding of a preterm neonate. So let us mention that here before we move on to answer this question. So how do you decide the preferred mode of feeding of a preterm neonate? Okay, so it is based on the gestational age. All right, so we look at the gestational age, all right, in weeks, and based on that we decide the preferred mode of feeding, or preferred initial mode of feeding rather, because as the baby is going to increase in age, we can shift from one mode of feeding to another. So what we are mentioning here is the preferred initial mode of feeding. And you also need to know that there's a reason for whatever we do. So what is the reason for choosing that preferred initial mode of feeding? We'll also mention wherever possible, so that it is easy for you to connect things and remember. Okay. So if a baby is born at less than 28 weeks gestation, okay, so the gut or the GIT of baby is too immature to handle anything. All right, too immature to handle any food. So you cannot give anything in the intestine of that baby. So what we do is we give total parenteral nutrition or IV fluids only. Okay, so if it is like for 2-3 days only, we can give IV fluids, but if we think that IV fluid is going to be required for a long time, Then we also add on total parenteral nutrition. So IV fluid plus minus TPN. And what is TPN? Is total parenteral nutrition. Okay. Now in this total parenteral nutrition, what you do is you will give the amino acids, lipids, as well as carbohydrates, everything intravenously, and the micronutrients also. Okay. So nothing enterally as such. But remember, in these babies, we can give something known as minimal enteral nutrition. So that is basically very, very small amount of feeds which might just help the gut to mature a little bit. But that is in no way meeting the nutritional requirements of the child. So minimal enteral nutrition may be given, okay, but that is not the method of feeding. That is just help for helping the gut to mature. Or you may even allow non-nutritive sucking. That means you can put the baby on the breast. The baby may try to suckle, but no significant amount of feed is going to go in. Okay. So minimal enteral nutrition, or MEN, may be tried. But actually this is just to help the gut to mature, but you cannot give large amounts to meet the nutritional requirement of the baby through the GIT at this time. Okay. Now, for a baby born between 28 to 31 weeks gestation, 28 to 31 weeks gestation, what you do is, now the GIT has matured, but the rooting, sucking, swallowing has not yet developed very well. Okay, rooting reflex, remember, it comes at around 32 weeks of gestation. We mentioned when we discussed the primitive neonatal reflexes in the neonatology videos. All right, so the GIT is mature, but rooting, sucking, swallowing not developed very well. Okay, not developed very well. So what you do in these babies is you can put in a orogastric feeding tube and use that to give feeds. Okay, so OG or orogastric tube feeding can be done. Orogastric tube feeding, or it is also known as gavage feeding. Gavage feeding means you put in a feeding tube and gravity is assisting in feeding that. Okay, so gavage feeding also it is called. All right. Now what about babies born at gestational age between 32 to 34 weeks? Now between 32 to 34 weeks, we know the rooting reflex has already come, but the coordination between sucking and swallowing and breathing has not yet developed well. Because for a baby to breastfeed independently, the baby himself or herself has to decide when to suck, when to swallow, when to take a breath in between. So a well-defined or well-established coordination is required between all these activities by the baby. So the rooting reflex has developed, but the coordination between swallowing and breathing not very well developed yet. Okay, between swallowing and breathing not very well developed. Okay, so in this scenario, what you do, you can do katori spoon feeding, or it is also called PrepLadder feeding. Okay, so we can use katori spoon or PrepLadder feeding. You know what is PrepLadder? So PrepLadder is a cup-like thing. So PrepLadder is a cup-like thing like this with a nozzle to it. So like this. This is a device which is often used to feed the neonates. All right. And beyond 34 weeks, because now the coordination between swallowing and breathing has been well established or developed. So coordination between breathing and swallowing developed. So direct breastfeeding is usually possible. direct breastfeeding. Okay. So that is how we decide the preferred initial mode of feeding in a preterm neonate. So we said, now coming back to our question. So what is asked in this question is what should be the best initial feeding method for a baby born at 33 weeks gestation. 33 weeks means the baby is born between 32 to 34 weeks of gestation. So what we will use in these babies is either Katori spoon or Paladay feeding. So Paladay feeding is the best answer. Because while we are feeding a baby with Paladay or Katori spoon, we can decide when to give the feed, when to pause to let the baby breathe and so on. Okay. So IV fluids is not the correct answer. Breastfeeding usually done beyond 34 weeks of gestation. Orogastric tube feeding required for babies between 28 to 31 weeks of gestation. So the best answer to this question is Paladay feeding. Alright. Moving on to our next question. A neonate who was just born. Okay. So what you have here is a neonate who was just born, found to have a heart rate of 120 per minute. Okay. What else? There was weak and irregular respiratory efforts. So respiratory efforts were there, but they were weak and irregular. What else is mentioned? He had pink body with blue extremities. That means peripheral cyanosis or acrocyanosis was there. Partially flexed limbs were there, and he showed grimace on stimulation by catheter. So what is asked is what is the Apgar score of the baby? So again we have discussed Apgar score in great detail in the videos in neonatology, but let's just mention it here once again. So how do we calculate the Apgar score? So Apgar score has got 5 components. The name of those components you can remember by the name Apgar itself, making it so easy. So let us see how do we do that. So Apgar score. Okay. So we said that the names of the components in the Apgar score you can remember by the name Apgar itself. So let us see how. So A, P, G, A and R. Alright. So A is for appearance. So A is for appearance. Alright. P is for pulse rate or heart rate of the baby. So P is for pulse rate or heart rate. G is for grimace. Okay, grimace means basically when you stimulate the oropharynx of a baby by a catheter and see what is the response of the baby to it. Okay, so one of the responses to this is grimace. So here we mention it as grimace, but actually it is response to oropharyngeal stimulation by a catheter. That is what we look at in this point. Okay, then another A for activity. And R is for, remember it is respiratory effort and not respiratory rate. So R is for respiration or respiratory effort and not respiratory rate. Alright. Now each of these components, as we mentioned, can be given a score of 0, 1 or 2. Alright. So we said each of these components can be given a score of 0, 1 or 2. Okay. Now let us see how this scoring is done. So appearance, we give it a score of 0. If the baby is completely blue or completely pale, then we give it a score of 0. So completely blue or pale. We give it a score of 1 if the body is pink but extremities are blue. That means peripheral cyanosis is present. Okay. So body pink but extremities blue or peripheral cyanosis. Then we give it a score of 1. And if the baby is completely pink, okay, then we give it a score of 2. So completely pink, then we give it a score of 2. Alright. Now what about the pulse rate? So pulse rate, we give it a score of 0 when it is absent. So we are not able to perceive the pulse or feel the pulse properly. So pulse rate, we give it a score of 0 when it is absent. We give it a score of 1 if it is present but it is less than 100 per minute. Less than 100 per minute. And we give it a score of 2 if it is more than 100 per minute. Okay. So more than 100 per minute. Grimace, as we said, refers to response to stimulation by a catheter. Okay. So in the point grimace, we are actually checking response to stimulation by a catheter. Okay. Response to stimulation by a catheter. Okay. So we insert a catheter or a feeding tube in the oropharynx of the baby and see what is the response of the baby towards it. If there is no response to insertion of a catheter or a feeding tube in the oropharynx, that means the baby is very depressed. Depressed means not the psychiatry wala depression. That means there is some perinatal asphyxia or HIE maybe. Okay. So no response. We give it a score of 1 when if we are inserting the catheter in the oropharynx and the baby grimaces only. That means there is just some change in expression. Nothing more than that. So grimaces only. Then we give it a score of 1. But you know, if the baby is very active and alert, what is going to happen? If you're putting a catheter in the oropharynx or feeding tube of the baby, the gag reflex is going to get stimulated. So baby may start coughing or sneezing. Okay. So coughs or sneezes. Then we give it a score of 2. Now activity. If the baby is lying totally limp, okay. So normally, you know, the term babies have this flexed or cuddled up posture. But if the baby has an extended posture and is lying totally limp or flaccid, then we give it a score of 0. Okay. So extended posture and the baby is lying completely limp or flaccid. Limp or flaccid. Okay, that means as if no tone is there at all. So we give it a score of 0. We give it a score of 1 if the baby has partially flexed extremities, but limb movements are as such not occurring much. So partially flexed posture with minimal limb movements. Then we give it a score of 1. While we give it a score of 2 if the baby has a well flexed posture and normal movement of limbs. So well flexed posture with normal limb movements. Okay. Normal limb movements. Then we give it a score of 2. Alright. Now coming to respiratory effort, we give it a score of 0 if there are no respiratory efforts. Baby is not making any attempt to breathe. Okay, to breathe. So none. We give it a score of 1 if the respiratory efforts are there but they are slow and irregular. Slow and irregular. So it has come as a question previously. All of the following are components of APGAR score except. So the answer is usually respiratory rate. That is not a component of APGAR score. It is the respiration or respiratory effort which is a component of APGAR score. Okay. So none, then you give it a score of 0. Slow and irregular, you give it a score of 1. And there are normal or strong respiratory efforts, then you give it a score of 2. As you can see, the minimum possible score in APGAR score is 0. If we give a 0 score in all the components, then the total APGAR score is going to be 0. So the minimum possible score is 0. And what is the maximum possible score? If we give a score of 2 to each of the components, then it is 10. Right? And APGAR score is usually done immediately after birth at 1 minute and 5 minutes of life. APGAR score more than 7 usually taken as normal, while APGAR score less than 3 indicates severe asphyxia, severe birth asphyxia or perinatal depression. Okay. And Apgar score does not have a value as such in neonatal resuscitation. It is always calculated retrospectively. But yes, it has some prognostic value. Like we said, if it is less than 3, it indicates severe birth asphyxia. Okay. Now coming to this question. How much is the Apgar score in the given question? Let us see. So the question given to us was, this baby has a heart rate of 120 per minute, weak and irregular respiratory efforts. So let's see. Heart rate of 120 per minute is falling in which category? So heart rate 120 per minute means it is more than 100 per minute. So for this component, we will give a score of 2 for this baby. Right? Then we said that the respiratory efforts are there, but they are weak and irregular. So for weak and irregular respiratory efforts, we are going to give a score of 1. Okay. So a score of 1. Okay. What else? So what else is given in the question is, he has a pink body with blue extremities. That means peripheral cyanosis is there. So if peripheral cyanosis is there, body pink, extremities blue, then we give it a score of 1. Right? You can see 1. Alright. Now then we said that partially flexed limbs are there. So some flexion is there. Partially flexed limbs. So he falls in this category. Partially flexed limbs are there. So we give it a score of 1 again on this component. Okay. And it is mentioned that the baby showed grimace on stimulation by catheter. So grimace is there. That means just some change in facial expression. So for this again, we are going to give him a score of 1 for this component. So the total Apgar score for this baby is 1 plus 2, 3, 4, 5, 6. So 1 plus 2 plus 1 plus 1 plus 1. So that is 6. So the best answer to this question is 6. So let us see the options. So the option asks, what is the Apgar score for this baby? So it's not 5, it's not 8, it's not 7, it is 6 as we already saw. So this Apgar score we need to know in detail and we need to know how to calculate it. 2 other scores, at least the names of which you must remember. One is the Silverman score. So the Silverman score is the score used to assess respiratory distress. Okay, respiratory distress in a preterm neonate. Okay, while there is a score known as Downey score. It is a score used to assess respiratory distress in a term neonate. So these are some other important scores you need to be aware of. So moving ahead to our next question. So what we have here, the image of a female baby. Okay, we have an image of a female baby with a rash on face and perineal area. Okay, you can see that there is this rash is there on the face, around the cheeks, around the oral cavity. Okay, and on the extremities as well, and in the perigenital area, around the anal orifice also. Okay, what could be the underlying deficiency responsible for this rash? Copper, riboflavin, vitamin C, zinc. So this picture in the baby, the rash is present around the orifices mainly, and it presents during infancy. So it is suggestive of a disorder known as acrodermatitis enteropathica, which is basically due to zinc deficiency. So the best answer to this question is zinc, but let us discuss a little bit about acrodermatitis enteropathica and the clinical features due to zinc deficiency. Okay, so let us discuss a little bit about acrodermatitis enteropathica. The name itself is telling you, acro means the extremities. So extremities are involved in this rash. Okay, dermatitis, that means there is a skin involvement which is present. Okay, and enteropathica, that means there is some problem in the intestines that is leading to it. So what happens in this disorder is there is malabsorption of zinc. Zinc is not getting absorbed properly. Because of that, there are many dermatological manifestations. The rashes on extremities are there, and mainly there are periorificial rashes. That means around the openings or orifices, like around the oral cavity, around the genital area, around the anal area, and so on. So let us write down about acrodermatitis enteropathica. Okay. So it is basically an autosomal recessive disorder. Alright. And there is defect in a gene known as SLC39A4. So defect in SLC39A4 gene. Now this gene is responsible to code for a intestinal zinc specific transporter. So this gene encodes an intestinal zinc specific transporter. So because there is a defect in the SLC39A4 gene, there is inability to absorb adequate zinc from the intestine. Okay, so inability to absorb sufficient zinc from diet. To absorb sufficient zinc from diet. Okay. Now, clinical feature. Clinically, these individuals will usually present in the later part of infancy. After, complementary feeding has been started and breastfeeding is decreased. So, usually presents in later part of infancy after the complementary feeding has started. Alright. And the manifestations can involve various systems. So, you have cutaneous manifestations. That means involvement of the skin. So, cutaneous manifestations there can be vesicobullous or eczematous. So, eczematous, okay, just like the allergic or eczematous rash, or it can be vesicobullous, or it can be dry, scaly and psoriasiform lesion, like the lesions you get in psoriasis. You must have read in your dermatology. So, it can be dry, scaly, psoriasiform skin lesions. Okay, psoriasis like skin lesions. So, psoriasis like skin lesions. Okay, usually symmetrically distributed. Symmetrically distributed in acrodermatitis is the name, that means the extremities, perioral, perianal and genital areas. Okay, in acral, perioral and perineal areas, and may also be seen on cheeks, knees and elbows. Okay, cheeks, knees and elbows. There can also be hair involvement in the form of reddish tint of the hair can be present, or even alopecia can be present. Okay, so reddish tint of hair or alopecia may be seen. Alright. There can be some ocular manifestations also. So, there can be some eye involvement. So, ocular manifestations in the form of conjunctivitis, which can lead to photophobia. Okay. So, conjunctivitis can be there, photophobia. Alright. Blepharitis and even corneal dystrophy. So, corneal dystrophy and blepharitis. Okay. And other manifestations of zinc deficiency can be chronic diarrhea. So, there can be other manifestations like chronic diarrhea, stomatitis, glossitis. So, chronic diarrhea, oral ulcers, so stomatitis, glossitis, nail dystrophy. Okay, nail involvement can be there. growth restriction, developmental delay, irritability. So lots of multisystemic manifestations can be there. So growth restriction, developmental delay, irritability, and delayed wound healing. So, all the babies may not have all these manifestations. These are the manifestations seen in most severe cases. Sometimes they can be just growth restriction and, developmental delay. So, whole spectrum of manifestations can be seen in acrodermatitis enteropathica or zinc deficiency. And, impaired immune function is also there. Because of the impaired lymphocyte function, you can get recurrent infections. So, there is also impaired immunity. So, there is impaired lymphocyte function and free radical scavenging. Impaired lymphocyte function and free radical scavenging, leading to recurrent infections that can be bacterial or fungal like candida infection. So, there can be recurrent infections, right? On investigation, you can find serum zinc levels to be really low. Okay, they are not confirmatory, but they are suggestive of diagnosis. So, if you do investigation, so on investigation, you can find serum zinc level can be less than 50 microgram per dl. So, serum zinc level less than 50 microgram per dl. And you can also find a low alkaline phosphatase level because that enzyme also needs zinc. So if zinc is less, alkaline phosphatase level or activity will also be less. And the treatment, of course, is zinc supplementation. So zinc supplementation, so treatment for acrodermatitis enteropathica, let us write down here. So the treatment for acrodermatitis enteropathica is zinc supplementation. We usually give it orally. So oral zinc supplementation. Now the dose is different if it is an inherited disease or if it is an acquired disease. So if it is an inherited disease like acrodermatitis enteropathica, you need to give a higher dosage of zinc. So in inherited disease, we give almost 3 mg per kg per 24 hours and lifelong supplementation is usually required. And there is dramatic improvement on adding zinc. Once you give zinc therapy, these rashes and all disappear very quickly. So lifelong supplementation is required. While in case of acquired disease, a much lesser dose can take care of it, 0.5 to 1 mg per kg every 24 hours. And treat the underlying malnutrition or illness. Okay, that should be addressed. A much smaller dose is required for acquired disease, and of course the cause for underlying malnutrition should be addressed. Okay, so that is about acrodermatitis enteropathica, zinc deficiency and its treatment. Moving on to our next question. Here we have a child who has a large head, large tongue, and both the testicles are also larger in size. The child also has features of autistic spectrum disorder. What is the probable diagnosis? Is it Rett syndrome? So it doesn't look like Rett syndrome because Rett syndrome is more common in females, okay? And of course, then these features are not going to be there. Like Rett syndrome doesn't have a large head. It rather has microcephaly or small head. Okay. Fragile X syndrome is definitely a possibility where you can get all these features. Okay. Eisenmenger syndrome, we know it is a condition seen in congenital heart diseases where there is a reversal of shunt. Okay. Due to irreversible pulmonary vascular obstructive changes in diseases like ventricular septal defect, PDA, or even atrial septal defect, it may occur sometimes. Williams syndrome is another disorder where a microdeletion disorder where there is, a deletion in chromosome 7, microdeletion. And these individuals usually have hypercalcemia, supravalvular aortic stenosis, some facial dysmorphism like thick lips, full cheeks, and they have a friendly personality, but this large size of testis, large head, all that is usually not there in Williams syndrome. So our best bet for the diagnosis here is Fragile X syndrome. So let us discuss a little bit more about Fragile X syndrome here, okay, because you can get more questions from it as well. So in Fragile X syndrome, there is a mutation or a problem is in the FMR1 gene on X chromosome, okay. So what is affected is the FMR1 gene, okay, on the X chromosome. So in Fragile X syndrome, the problem is in the FMR1 gene on long arm of chromosome X, okay, long arm of chromosome X, which leads to the increase in the number of CGG repeats. So it is a trinucleotide repeat disorder, CGG. So there are 3 nucleotides you can see, okay. So increase in number of CGG repeats. Alright, so as we mentioned, it is a trinucleotide repeat disorder, okay, where the manifestations also depend upon how many numbers of the CGG repeats are there. Now, if these CGG repeats are less than 50 in number, so if the CGG repeats are less than 50 in number, then we take it as normal. So here CGG repeats are there, and if the number of CGG repeats is less than 50, that is taken to be normal. If the number of CGG repeats is between 50 to 200, that is taken to be pre-mutation, where the full-fledged picture of Fragile X syndrome may not be there, but there can be some other abnormalities that we'll be coming to. So it is called pre-mutation. While if the number of CGG repeats is more than 200, then we have the picture of Fragile X syndrome, okay, Fragile X syndrome. And larger the triple nucleotide repeat expansion, more significant is the intellectual disability, okay. So remember, larger the number of trinucleotide repeats, more is the intellectual disability, okay. If trinucleotide expansion is too large, even females may sometimes show the manifestation of this disease, though it is much more common in males, okay, much more commonly seen in males. All right. What else? Now, because there is a mutation in the FMR1 gene and there is increased number of the CGG repeats, there is silencing. So in Fragile X syndrome, there is silencing of the gene. Silencing of gene producing FMRP, Fragile X mental retardation protein, okay, that regulates the translation of multiple mRNAs and has a lot of functions, especially in the neurological system, okay, and it affects the synaptic functions. So coming to the clinical features that you usually get in Fragile X syndrome. So clinical features of Fragile X syndrome. So of course, as we already mentioned, it is more common in boys. Though if the girls have large number of trinucleotide repeats, sometimes they can also show intellectual disability. Okay. Now what else? These individuals usually have a long face. Okay. So there is long face. So the typical classical picture is long face, large cupped ears are there, okay, large ears, prominent square jaw can be there, okay, prominent square jaw. There can be high arched palate, okay, high arched palate. Now, megalencephaly or increase in the size of the brain leading to a large head may also be seen in some individuals. So, megalencephaly giving rise to a large head may be seen, okay, as mentioned in this question also, right? Now, there can be some other features, some neurobehavioral manifestations like there can be intellectual disability, which is a salient feature of this disorder. There can be autistic behavior, okay. There can be autistic behavior, or these individuals may have the ADHD phenotype, attention deficit hyperactivity disorder. So they can also have the ADHD phenotype. There can be anxiety, a lot of anxiety disorder may be associated, okay, anxiety. And even seizures may be seen in 1/5 of individuals. So seizures in 20%. Okay, and here ADHD is quite common, more common even than autistic spectrum disorder. Okay, there can also be some associated connective tissue abnormalities. Okay, but before that, one very important thing, macroorchidism or large size testis, especially in adolescents and adults, may not be very apparent in very young children. Okay, so macroorchidism or large size of testis may be seen. Macroorchidism. And we said because of the involvement of connective tissue, there can be hyperextensible finger joints. Hyperextensible finger joints. Flat foot. Okay. So there can be flat foot. And there can even be mitral valve prolapse and scoliosis. Mitral valve. So there can be mitral valve prolapse or scoliosis. Okay, but macroorchidis or large size testis, as we mentioned, that is more common in adolescents or adults. Okay, not very common in very young children. All right. So these are the typical clinical features. Even recurrent otitis media can be there. So these are the typical clinical features that you get in Fragile X syndrome. Now in those with pre-mutations also you can get some clinical features like we mentioned. So in those with pre-mutations, in males, we can get an adult onset neurodegenerative disorder that is called Fragile X associated tremor or ataxia syndrome. Fragile X associated tremor or ataxia syndrome. While in females, we can get premature ovarian failure. Premature ovarian failure can be there. So these are the typical clinical features that you get in Fragile X syndrome. Very, very important. Next question. A child with developmental delay is showing the following karyotype picture. You know what is a karyotype? So karyotype is a genetic investigation that we do, where what we do is we arrange all the chromosomes in the metaphase. We harvest them from peripheral blood usually. It can be done from other tissues also. From any nucleated cell you can do it basically. So what you do is you arrest these cells in the metaphase and then you look at the chromosomes. Okay, you stain the chromosomes and look at them and see if there are any abnormalities. But it just gives you a bird's eye picture. It does not give you an idea about submicroscopic deletions. But any gross changes in number or structure of chromosome, it will tell you. So here what you have been given is a karyotype. Now what you see here, you can see that there are pairs of chromosomes 1, 2, 3, 4, 5 like that. The chromosomes are there arranged in a particular sequence based on the chromosome number you can see. Okay, so all the chromosomes you can see there are 2 copies of each chromosomes except, now what do you see here? So what we see here is there are 3 copies of chromosome 21 here. Alright, all the other chromosomes you can see there are 2 copies, but there are 3 copies of chromosome 21. Okay, so that means there is trisomy 21. 3 copies of chromosome 21 or trisomy 21, then what is your diagnosis? It is definitely Down syndrome. And here you can see 2 copies of X chromosome are there. That means it is a girl. If one X and one Y would have been there, it would have been a boy, right? So the diagnosis here based on this karyotype picture is a girl with trisomy 21 or Down syndrome. Alright. So Down syndrome is the best answer here. Okay. In Turner syndrome, we all know what do you get in a karyotype. So in Turner syndrome, what you would have got is 45XO. So 1 X chromosome would have been less. 45XO is the karyotype in Turner syndrome. In Edwards syndrome, what you get? So Edward E for E, remember. So Edwards syndrome, you get trisomy 18. So instead of 2 copies of 18 number chromosome, there would have been 3 copies. Trisomy 18. Klinefelter syndrome, what you get is 1 extra X chromosome in a male. So instead of 46XY, it is going to become, total number of chromosomes would become 47 and it would have been XXY. But Down syndrome, very, very important. We have discussed in great detail in the videos on genetics. So Down syndrome is trisomy 21. Okay. Now, apart from trisomy, sometimes in the Down syndrome karyotype picture, you might even get some translocations, or sometimes mosaicism is there. That means some cell lines are normal, some may be carrying the trisomy 21. The mosaics usually have a less severe manifestation. And the most common cause or underlying pathology or which stage of cell cycle is affected is there is meiotic, maternal meiotic non-disjunction. So most commonly you get maternal meiotic non-disjunction. That means the separation of chromosomes towards the 2 poles is not taking place properly. So maternal meiotic non-disjunction is the most common cause in Down syndrome. Okay, because of which there is trisomy 21. And advanced maternal age is one of the risk factors for trisomy 21 or Down syndrome. Now, moving on to the next question. A child, as you can see, presents with redness of eyes, fever, backache, and generalized rash as seen below. So, you have a child with redness of eyes and fever, backache, and this generalized rash. So what you see here is an erythematous maculopapular rash which is confluent at places, merging with each other. Okay. So you have redness of eyes or conjunctivitis is there, fever is there, backache, that means generalized body ache and all can be there, and generalized rash which you have erythematous maculopapular rash which is confluent at places. But there are, as you can see, no vesicles or bullae or no crusting or no pustules. Okay. So this typical picture closely resembles that of measles. In dengue, you can sometimes get rash, but the rash in dengue is not like this. It is usually a generalized erythematous hue. Sometimes an erythematous maculopapular rash can be there. Or sometimes what you get is there is a generalized reddish hue of the skin and in between you can see islands of white areas. Okay. And redness of eyes is usually not associated and you will get other features like, hemoconcentration, thrombocytopenia, bleeding manifestations and so on. Chickenpox, this is not the typical rash. What you get is a pleomorphic skin rash, different skin rashes at the same time in chickenpox. Herpetic rash again would mainly comprise of vesicles, fluid-filled vesicles, which are not characteristically seen here. And they will usually not involve the body so much extensively. They will usually be localized to certain areas or to certain dermatomes. Okay. So this is typically what you get in measles in a child. A little bit about measles before we move ahead. So measles we know is caused by an RNA virus. The incubation period is usually 8 to 12 days. And what is important is measles becomes infective even before the onset of rash. So it is communicable from 3 days before to 4 to 6 days after the onset of rash. Okay. After onset of rash. And you get, fusion of the infected cells which give rise to giant multinucleated Warden-Kildee cells. You must have, discussed in pathology. What we would be more focusing upon is the clinical picture because case scenarios are very, very common. So initially you get a prodromal phase. So in the prodromal phase, you can get features like fever, conjunctivitis and coryza. So the child overall has a very wet look, secretions coming from everywhere. Okay. So fever, conjunctivitis and coryza. Okay. Then there are something known as Koplik spots which are said to be pathognomonic of measles. So there can be Koplik spots on the inner aspect of cheek, usually in the area or where the junction of first and second molars occur. But coplic spots can also be seen in conjunctiva or vaginal mucosa. Okay. And the rashes in measles typically starts from behind the ear and progresses downwards to involve the entire body. So rash usually begins from behind the ears and spreads downwards. And it fades away in the same progression as it appeared in 7 days or so. But it can leave a brownish desquamation for many days to come. The most common complication of measles, sometimes it's asked, so most common complication of measles is otitis media. Most common cause of death in a child with measles is pneumonia. So, measles impairs the cell-mediated immunity of the child and makes him very, very prone to infections. So, that's why vitamin A is given as a part of treatment of measles, so that the mucosa and all heals better. It will prevent the diarrhea, pneumonia, and, it will try to heal up the mucosa better. So, most common cause of death or mortality in measles is pneumonia. Alright, and a severe long-term dreaded complication of measles is, we know, SSPE, subacute sclerosing panencephalitis. So, severe long-term fatal complication of measles, sometimes asked, is, we know, SSPE, where you get myoclonus, neurodegenerative disorder. Okay, not much success in treatment. Subacute sclerosing panencephalitis. Alright, so that is about measles in children. Moving on to our next question. So what we have here, again a case scenario. So you have a child who is having different type of rashes like papules, vesicles and pustules involving the whole body. And these rashes are present all at the same time. So we said pleomorphic skin rashes or different types of skin rashes all present at the same time indicate chickenpox. That is a very characteristic clinical feature of chickenpox, okay, or varicella, right? An appearance of rash is associated with the onset of fever. What is the probable diagnosis? So measles we have already discussed, and this clinical picture is not compatible with measles. It is compatible with chickenpox. Scabies. So scabies, what you get are itchy skin lesions mainly in the region in between the fingers, in the perigenital area and so on. Rubella again is usually you will not get this vesicles, pustules and so on. You will get a measles-like rash along with post-auricular lymphadenopathy. So this is typically what you get in chickenpox. Okay. So let us discuss a little bit about chickenpox here. So chickenpox we know is caused by the varicella zoster virus, a DNA virus. Okay. So varicella zoster virus, the mode of infection can be either airborne or contact with infectious lesions. So mode of infection can be airborne or contact with infectious skin lesions. Okay. The period of infectivity is from 24 to 48 hours before the onset of rash till all the vesicles have crusted. So period of infectivity. So period of infectivity is from 24 to 48 hours before the rash till all vesicles have crusted. Alright. And the typical clinical picture which helps us clinch the diagnosis of the varicella zoster virus infection or chickenpox is pleomorphic skin rash. Okay. So pleomorphic skin rash. So different type of skin rashes present at the same time in an individual. So you have the pleomorphic skin rash. So presence of macules, papules, vesicles and sometimes even pustules all present at the same time. And the crops of new lesions appear with the onset of fever. There can be some complications of chickenpox complications can be there. Like there can be secondary bacterial infection of the lesions. There can be purpura fulminans. So secondary bacterial infection, purpura fulminans, There can be Ray's syndrome, okay, where there can be encephalopathy, seizures, and so on, and hepatic impairment. So Ray's syndrome can be there, and some CNS manifestations can be there as complications like meningoencephalitis, cerebellar ataxia, transverse myelitis. So cerebellar ataxia is a quite common complication of chickenpox. Then transverse myelitis, optic neuritis, and even stroke can occur. Okay, transverse myelitis, optic neuritis, and even stroke can occur. All right. So what is the organism responsible for this rash seen in an otherwise well child who also had oral ulcers? So what you can see here are some vesicles and pustules. Okay, you can see some vesicles and some pustules with a erythematous ring surrounding area of redness around the oral cavity and on the foot, on the soles as they are shown here. So this is what is known as hand-foot-mouth disease. Okay. So this is typically known as the hand-foot-mouth disease. Okay. So let us discuss a little bit about this hand-foot-mouth disease before we move on to answer this question. So this hand-foot-mouth disease is most commonly caused by Coxsackie virus A16. Okay. Most commonly caused by Coxsackie virus A16 strain and strains of enterovirus like enterovirus A71. It can also be caused by some other strains of Coxsackie virus. Okay. The typical clinical presentation, it is usually a very mild illness. Low grade fever may or may not be present. Okay, low grade fever may or may not be present. And on hands and feet, what you get are, so on hands and feet, what you get are maculopapular, vesicular, so either maculopapular and sometimes also vesicular and or pustular lesions. Okay, pustular lesions. And they can also occur on buttocks and the groin area as well, and they can be tender, okay, which are tender and usually 3 to 7 millimeters in size, can sometimes be oval in shape also, and may have a reddish border. Okay. Now what you see in the oral cavity, again you can see inflamed oropharynx and scattered painful vesicles. So inflamed oropharynx and scattered painful vesicles, scattered painful vesicles, okay, on posterior pharyngeal wall, gums, lips, cheeks, okay, on gums, lips, buccal mucosa. Again, they are around 4 to 8 millimeters in size, and they are shallow lesions with surrounding erythema. Shallow lesions with surrounding erythema. And they usually resolve spontaneously by within around 7 days. Okay. So that is about hand-foot-mouth disease. So coming back to our question, what is the organism responsible for this hand-foot-mouth disease? We already mentioned it's not pox virus. It is the Coxsackie virus A16, which is most commonly responsible. Other strains of Coxsackie and enterovirus may also cause it. It's not adenovirus, not Epstein-Barr virus. So this is the best answer to this question. Again, see, from a given case scenario, you should be first able to identify what the illness is, and then only you'll be able to answer this question. All right. Moving ahead to our next very straightforward question. All of the following are components of tetralogy of Fallot except. So let us first discuss what are the components of tetralogy of Fallot, and then we answer this question. Okay. So I'm sure all of you know, but just to reiterate the fact, we have discussed tetralogy of Fallot in great detail in the video in pediatric cardiology, and it is very, very important for you. The components of tetralogy of Fallot or TOF. So the name itself is telling you it is a tetralogy. Tetra means 4. So what are the 4 components of tetralogy of Fallot? So it is a large VSD, okay, or ventricular septal defect. There is pulmonary stenosis, or it is also called infundibular pulmonary stenosis. What else? There is overriding of aorta. So instead of coming from the left side, it comes to the midline and arises over both left and right ventricles. So overriding of aorta, and you get right ventricular hypertrophy. Okay. And remember, this tetralogy of Fallot is the most common congenital cyanotic heart disease seen in children. Most common congenital cyanotic heart disease seen in children. And on X-ray, you get a typical Coren-Sabbat or boot-shaped heart, which is often asked in MCQs. Coren-Sabbat or boot-shaped heart on chest X-ray, which is often asked in MCQs as an image-based question or otherwise as well. Okay. So all of the following are components of tetralogy of Fallot except overriding of aorta. Is it a component? Yes, we can see overriding of aorta is a component. Tricuspid stenosis? No. Right ventricular hypertrophy? Yes. Ventricular septal defect? Yes. So the best answer here is tricuspid stenosis. Okay, a very, very straightforward question. Moving on to our next question. What we have here is a 4-year-old boy who is brought to the emergency unit after he is pushed down while playing. That means he has sustained some trauma. After falling on his knees, he developed swelling. So there is some knee swelling and bruising of his left knee as well. The history revealed that his maternal uncle is also having similar presentation. So family history is there, and that too in the maternal uncle. That shows probable X-linked inheritance. Okay. What could be the probable mode of inheritance of this condition? So this falling after falling, developing a bruise and a swelling of the left knee or hemarthrosis. So that indicates the presence of a disorder known as hemophilia. So let us discuss a little bit about hemophilia before we move on to answer this question. So hemophilia, or it is also called hemophilia A, which is more common. It is basically due to deficiency of factor 8, coagulation factor 8. So deficiency of factor 8. Alright. And it has got X-linked recessive inheritance. So it is more commonly seen in males. X-linked recessive inheritance. Alright. So because there is a deficiency of factor 8, the intrinsic pathway of coagulation is mainly affected. And because the intrinsic pathway is affected, what you get is a prolonged APTT. Okay, prolonged activated partial thromboplastin time in presence of normal PT, prothrombin time, bleeding time, and normal platelet count as well. So what are the clinical features of hemophilia that you usually get? You get deep bleedings. So bleeding in joints is usually quite common. So clinical features, you can get a family history of similar illness, especially in the maternal uncles because it is X-linked inheritance. You can get bleeding manifestations. Bruising can be there. Okay, easily the child will develop bruises after trivial trauma, and there can be bleeding in the joints, which is very characteristic of hemophilia. So hemarthrosis can be there, which is most commonly seen in the ankle joint followed by the knee joint. The treatment is basically factor replacement. So you have to give factor 8 replacement. Factor 8 concentrates are available which can be used to replace. And if that is not available, alternatively in emergency situation, you can use fresh frozen plasma. Okay. So coming back to this question, this hemophilia is a typical case scenario that we identify here from the given history, and so that has an X-linked recessive inheritance, we know that. Moving ahead to our next question, what we have here is a 5-month-old baby who has a respiratory rate of 58 per minute and chest indrawing. The baby has not been able to feed for last 10 hours. What is the best management for this baby? So before discussing about the management of this baby, let us first see, based on the given clinical scenario, in which category is the baby falling as per the IMNCI guidelines. So we know IMNCI basically is, what is the full form of IMNCI? Integrated Management of Neonatal and Childhood Illnesses. So these are some algorithms which have been given by WHO so that can help even the peripheral health workers to manage some common childhood illnesses. So integrated management of neonatal and childhood illnesses. Okay. Now, as per the IMNCI guideline, whenever a baby presents with cough or breathing difficulty, so what you do is you have to look for some 3-4 things. What are they? So one is you have to assess whether fast breathing is present or not. Okay. So assessment of a child who presents with cough and cold, you have to see whether fast breathing or chest indrawing is present or not. All right. And you have to see any general danger signs are present or not. Any general danger signs are present or not. And nowadays in the latest IMNCI guideline, they also look at whether any wheeze or stridor is present or not. Okay. Now, before classifying the child into various categories, we need to know what is the meaning of fast breathing. So as per the IMNCI, they've given some cutoffs of fast breathing, and sometimes they come as direct MCQs as well. So you call it fast breathing in a child less than 2 months age if the respiratory rate is greater than equal to 60 per minute. In 2 to 12 months age, we call it fast breathing if the respiratory rate is greater than equal to 50 per minute. And in 1 to 5 years age, we call it fast breathing if the respiratory rate is greater than equal to 40 per minute. Alright. Now, based on whether these parameters are present or not, we need to classify the child and manage accordingly. So we saw what is the definition of fast breathing. Chest indrawing means the intercostal and subcostal retractions that are there. Okay, any general danger signs. So we also need to know what do you mean by general danger signs before classifying this child. So the examples of general danger signs are, general danger signs include persistent vomiting. Okay, if the child is going on vomiting, not able to take anything orally, so they are persistent vomiting. Okay, or if there is inability to feed, inability to drink or breastfeed especially. So inability to drink or breastfeed, there are convulsions or seizures. Okay, unconsciousness or lethargy. Unconsciousness, lethargy, or if there is stridor in a calm child. Okay, stridor in a calm child. Or some people even take severe malnutrition as one of the general danger signs. Okay. Now, having this knowledge, let us now classify the child into various categories. One more thing, remember here we mentioned whether any wheeze or stridor is there or not. So if wheeze is there, then you can give a trial of inhaled bronchodilators like salbutamol and see the result. If the fast breathing is improving with that, fine. Otherwise, you treat according to the category. So this checking for wheeze and giving a bronchodilator like salbutamol, inhaled bronchodilator, is also a latest addition in the new IMNCI guidelines. Okay. Apart from that, use of pulse oximeter has also been included in the latest IMNCI guidelines. So if available, pulse oximeter should also be used to check the saturation of the baby. Okay. Now, let us classify the baby into various categories according to IMNCI and see what the treatment is. So we will look at whether fast breathing and or chest indrawing is present or not. And we will see whether any general danger signs are present or not. General danger signs are present or not. And we will classify the baby according to the category he is falling in, and we will prescribe the management or treatment. Okay. So there are basically 3 categories. So 1, if there is no fast breathing, no chest indrawing, no general danger signs, then the child has no pneumonia, cough and cold only. No pneumonia, cough and cold only. So what you advise here is home-based supportive care. So some throat soothing agents, okay, and home-based supportive care only. Steam inhalation can be given, gentle cleaning of the nose. So no specific medical treatment required. Okay. Now, if there is either fast breathing or chest indrawing or both, but there are no general danger signs, then the child has pneumonia. What you do? So if pneumonia is there, you have to prescribe oral antibiotics. Usually the first line antibiotic that is prescribed is amoxicillin. So prescribe oral amoxicillin. Okay. What else will you do? If there is wheezing, give bronchodilator. So use bronchodilator if wheeze is there. Okay. Bronchodilator if wheeze is there. What else? You will, advise the mother that if any danger signs develop, the child is unable to feed, seizures are there, unconsciousness, lethargy. So explain the danger signs to mother and tell her when to return. Okay. Explain danger signs. Alright. And you advise for follow-up after 2 days. And if a pulse oximeter is available, check the saturation. If the SpO2, if the saturation is less than 90%, then you need to refer urgently. So this is again in a new addition in the latest guidelines, which was not there previously. Alright. So this point has been added and this point has been added in the latest guidelines. Now, if whatever fast breathing, maybe it is there or not there, but if general danger signs are present, then it is called severe pneumonia or very severe disease. So severe pneumonia or very severe disease have been merged into a single category now. So severe pneumonia or very severe disease. So what you do here is give first dose of injectable antibiotics. Usually ampicillin and gentamicin are used. First dose of ampi and genta you give and refer urgently to hospital. Okay, so that is how you manage these babies. Now, there is some color coding that has also been done in the IMNCI guidelines. So, anything that is written in the green background, that means the baby stays at home and nothing much is to be done for that baby. So, you can be rest assured things are okay. Anything that is written in the yellow background means that the baby needs specific medical care or advice. Okay, but hospitalization is not required. Anything that is written in the pink background, okay, in the pink background means that the baby has very severe disease and the baby needs to be referred urgently to hospital. Now let us see which category our baby in the question is falling into. So 5-month baby here has a respiratory rate of 58 per minute. So for 5 months, respiratory rate 58 per minute is fast breathing. So fast breathing is present for our baby. Okay. And chest indrawing is also present. So fast breathing and chest indrawing are present. And what else is present? Not being able to feed. So inability to feed, that is also there. So general danger sign is also present. So general danger sign is also there. So we classify this child as having severe pneumonia or very severe disease. And what is the treatment for that category? For severe pneumonia or very severe disease, we need to give first dose of antibiotics to the baby and refer. Okay. So prescribe oral antibiotics and follow up after 2 weeks. No, that is not the correct answer. Give first dose ampicillin and gentamicin and refer urgently to hospital. Yes, that is the best answer. Reassure mother that it is just cough and cold. No. Do nothing and refer to the baby to tertiary care center. No. We must first give first dose of antibiotics and do initial stabilization and then refer. So that is the give first dose ampicillin and gentamicin and refer urgently to the hospital is the best answer here, and we know why. Moving on to the next question. What we have here is a 1.5-year-old child who presents with one episode of wheeze and breathing difficulty. Chest x-ray is done and it shows bilateral hyperinflation. Which organism is most commonly responsible? So what the case scenario here tells us that this baby has what is known as acute bronchiolitis. So here again, it is important for us to first come to a diagnosis from the given case scenario. Only then we can proceed to answer this question. So what are the pointers that are helping us to diagnose the condition here? So in acute bronchiolitis, we typically see it in the age group of 6 months to 5 years. So 6 months to 3 years rather. So acute bronchiolitis, we typically see it in the age group of 6 months to 3 years. And what is there is, it is a viral illness which is caused by, most commonly by the respiratory syncytial virus. So what you have is a viral prodrome of low grade fever, cough, coryza is there, and there can be hyperinflation. Okay. So viral prodrome is there, and then there can be hyperinflated chest. So it can be visible on a chest x-ray, and if you examine the baby, you can find the anteroposterior diameter of the chest of the baby has increased. So you can get hyperinflated chest on a chest x-ray also, and on auscultation, you will get wheezing. Sometimes crepitations may also be there. Usually it is a mild condition, but sometimes some hypoxia requiring oxygen may also be there. Okay. The treatment is mainly supportive. Because it is a viral illness, there is no role of antibiotics. So treatment is mainly supportive. Okay. And you may use oxygen if required, and some saline inhalations and all may also help. Okay. So the organism most commonly responsible for acute bronchiolitis we know is respiratory syncytial virus. Okay. It is not streptopneumoniae or H. influenzae or Coxsackie virus. Moving on to our next question. What we have here is a 7-month-old boy who was brought with a history of 18 episodes of loose stools. So a lot of loose stools and 2 episodes of vomiting. The child is irritable but can drink orally. Very important for us to know whether the child can drink orally or not. What is the best way to manage this child? Now, because he has 18 episodes of loose stool and 2 episodes of vomiting, a lot of fluid loss has occurred. And the child is irritable also but can drink orally. So all these suggest a diagnosis of some dehydration. Now, what do you do for some dehydration in a child? So if there is some dehydration in a child with diarrhea, what we do is we give 75 ml per kg of fluids over 4 hours. If the baby is able to accept orally, then we give it as ORS or oral rehydration solution. If the baby is having persistent vomiting or not able to accept orally, okay, then we might have to give this fluid as IV fluids. And for IV fluids, we may use either ringer lactate in 5% dextrose or ringer lactate alone. Okay. So the best management in this scenario where the baby is able to accept orally is we will go ahead and give ORS to this baby. Okay. So let us see what are the options. So give IV fluids only? No, we would not want to do that. Give IV fluid for 4 hours followed by ORS? No. Give ORS only? Yes. Give plain water only? No. Because in the stool along with water or fluid, lot of electrolytes are also getting lost which need to be replenished. So we have to give this some dehydration correction. Along with, of course, we will give replacement of ongoing losses. And how do you give replacement of ongoing losses in the stool? So replacement of ongoing losses we give again in the form of ORS, which is given 5 to 10 ml per kg per loose stool. So that is the best management in this case. And apart from that, of course, we will start zinc therapy, and normal diet needs to be continued. We need not restrict milk or any other thing in acute diarrhea in children. Moving on, we have here again a case scenario. So you can see how much emphasis is there on case scenarios and in coming to a diagnosis before you're able to answer the question. So what we have here is a 5-year-old boy who presented with hematemesis. Hematemesis means bloody vomiting. So there will be coffee ground blood in the vomiting, reddish black or brownish vomitus will be there, and was found to have splenomegaly. So hematemesis and splenomegaly are two very, very important indicators towards a diagnosis of portal hypertension. So we are sure that this child, we are reasonably sure that this child has portal hypertension. But don't jump to go and mark the answer, because 2 or 3 options are correct. But what you have to choose then is the single best answer, which is best fitting to the given case scenario. So let us read through the question and see what other information is given, and then we come to the diagnosis. Okay, or the answer, correct answer. There was a past history of exchange transfusion in this child for neonatal jaundice. Now, for neonatal jaundice, if exchange transfusion has been done, then it is usually through umbilical vein catheterization. So, umbilical vein catheterization, if it was done, then it is a very strong risk factor for portal vein thrombosis. Okay, because we know umbilical vein goes and joins the portal vein. We have read in the fetal circulation, which we have discussed in the pediatric cardiology videos in great detail. So umbilical vein catheterization is a predisposing factor for portal vein thrombosis, which could be the cause of portal hypertension in this child. So the best answer out of the given options, let us see now. So what you have in the option here is Budd-Chiari syndrome, which is thrombosis of the hepatic veins. That doesn't seem to be the case here, because you do as such do not have any risk factors, any hypercoagulable state or anything for that. And prominent back veins, lot of abdominal distension, ascites and all can also be a part of Budd-Chiari syndrome. Portal hypertension, yes, it is. Liver cirrhosis, we do not get any features of hepatic decompensation here or any risk factor for liver cirrhosis. Portal vein thrombosis, yes, there's a past history of exchange transfusion in this child for neonatal jaundice. So out of the given options, portal vein thrombosis is the best answer to this question. Though if portal vein thrombosis would not have been there in the choices, then I would have gone ahead with portal hypertension as my answer. So always read all the 4 choices. Even if you think one of them is the correct choice, don't just jump to mark it before reading through the other choices. Okay, because sometimes it also happens we miss the except in the question. Something and except is written. So we see one option is correct, we mark that. If you read through all the options, you'll see that 3 options are correct and 1 is wrong. And then you will sometimes realize that the question had an except. So always read the question very, very carefully, and all the 4 options should be read at least once, even if you're super confident about the answer. Okay. Now, again, what we have here is a case scenario. A 6-year-old child weighing 12 kg is having a urine output of 0.4 ml per kg per hour. So normal urine output is usually greater than equal to 1 ml per kg per hour. So here what you have is a decreased urine output, okay, for last 14 hours. And what is asked is the KDIGO staging of acute kidney injury, okay. Now KDIGO stands for Kidney Disease Improving Global Outcomes. This is an international body which frames guidelines on kidney diseases and their management in adults as well as children. So KDIGO stands for Kidney Diseases Improving Global. So these are international guidelines which are followed all over the world. So you can see KDIGO. So let us see the KDIGO staging of acute kidney injury before we move on to answer this question. How do we do the KDIGO staging for acute kidney injury? So KDIGO staging for AKI or acute kidney injury. So it can be based either upon the serum creatinine value or based on the urine output of the child. Okay. So the stage, it is based on serum creatinine or the urine output. Alright. So you have 3 stages in the KDIGO staging for AKI. Okay. In the first stage, the serum creatinine, there is an increase of greater than equal to 0.3 milligram per dl from the baseline. So if the serum creatinine was say 0.6 and it becomes 0.9 or more, then again we call it AKI and first stage. Okay. So increase in serum creatinine by greater than equal to 0.3 milligram per dl. So 0.3 milligram per dl increase from baseline. Okay, or the serum creatinine becomes 1.5 to 1.9 times the baseline. That means an increase by 50 to 90%. 1.5 to 1.9 times the baseline. And if the urine output has been less than 0.5 ml per hour for 6 to 12 hours, then it is stage 1 acute kidney injury. We call it stage 2 acute kidney injury if the serum creatinine has become 2 to 2.9 times the baseline. That means serum creatinine has become doubled or more than that, but less than 3 times. So if the serum creatinine is 2 to 2.9 times the baseline, or the urine output has been less than 0.5 ml per kg per hour for more than 12 hours, greater than equal to 12 hours. And we call it stage 3 or the most severe stage of CKD If the serum creatinine is 3 to 3.9 times or greater than equal to 3 times, we can say, because it is the most severe stage. So greater than equal to 3 times the baseline, or the absolute value of serum creatinine is greater than equal to 4 mg per dl, serum creatinine greater than equal to 4 mg per dl, or there is any indication of renal replacement therapy like refractory hyperkalemia or fluid overload which is not responding to diuretics, indication of renal replacement therapy is there, or if we do the estimated GFR and we find it is less than 5 ml per minute per 1.73 meter square. If any of these are there, or the urine output is less than 0.3 ml per kg per hour for greater than equal to 24 hours, or there is anuria. Okay, that means complete cessation of urine output for greater than equal to 12 hours. For 12 hours, the baby has not passed any urine. Now, let us see in the given case scenario, where does our child fit? So, this is a 6-year-old child weighing 12 kgs having a urine output of 0.4 ml per kg per hour in the last 14 hours. That means urine output is less than 0.5 ml per kg per hour here, but not less than 0.3 ml per kg per hour. So, less than 0.5 ml per kg per hour for last 14 hours. So, urine output less than 0.5 ml per kg per hour for 14 hours. That means greater than equal to 12 hours. So, our child in the given case scenario is falling in the KDIGO stage 2 of AKI. So, the best answer here is stage 2. Okay. The next question. What we have here is a male infant. So, you can see again a case scenario. Okay, a male infant who was brought to emergency pediatric unit with abdominal distension. There was a history of recurrent urinary tract infections. That means there could be some obstruction somewhere in the urinary tract. On examination, he was again found to have urinary retention, and imaging showed bilateral hydronephrosis. If something is bilateral, that means the problem has to be at the level of bladder or in the urethral level, so that the bladder is distended, so that obstruction should be downstream to the bladder. So we know the urinary tract is like this. Okay, so there are the 2 kidneys. So just have the concept. Okay, so they are the ureters, all right, and then you have the bladder, and then you have the urethra. Now, if both the kidneys, bilateral hydronephrosis is there, both the kidneys are getting enlarged, okay, and you are getting a distended bladder also, that means there should be any obstruction downstream to the bladder. It has to be anywhere in the urethra or at the junction of bladder and urethra. Okay. So, bilateral hydronephrosis there. What is the probable diagnosis? Now, it cannot be a renal calculi, because if a renal calculi is say here or here, okay, it will not give rise to bilateral hydronephrosis and bladder distension also. PUJ obstruction again is not a possibility, because PUJ obstruction, say the obstruction is here. So what will happen? This area will dilate. But the opposite side may not be dilated if opposite side PUJ is not there. And if you are arguing that both sides PUJ obstruction is there, then also why should the bladder be distended? Bladder should not be distended. You could have just got bilateral hydronephrosis if bilateral PUJ obstruction would have been there. But posterior urethral valve is definitely a very strong possibility, and that to a male infant you have been given. So remember, posterior urethral valve or PUV is the most common cause of lower urinary tract obstruction. Lower urinary tract obstruction in a male neonate. Okay. Urethral stricture we are not going to suspect unless you have some history of instrumentation or trauma to the ureter or something else suggestive of a risk factor for urethral stricture. So, and that is not too common also. So from the given case scenario where you have a male infant with abdominal distension, with bladder distension, urinary retention, recurrent urinary tract infections, bilateral hydronephrosis, the diagnosis is undoubtedly clinically your first diagnosis will be posterior urethral valve, okay, where you can get this picture and you have to understand the concept behind it. Okay. Now, a child was brought to the emergency with generalized tonic-clonic seizures. Which drug should be given first to control his symptoms? Which drug should be given first to control his symptoms? So, whenever a child is brought with ongoing seizures to the medical facility, we consider it to be status epilepticus and manage accordingly. So, the first drug given to abort seizures in a child with ongoing seizures, it is a short-acting benzodiazepine only. So, usually what is preferred is, if you have injection lorazepam, you give that. If you don't have that, you can use injection midazolam. If you don't have that, you can use diazepam. Okay, and after that, once the seizures have aborted and you have ruled out some metabolic disorders, common ones like hypoglycemia or hypocalcemia, then you can load the child with anti-epileptics like injection phenytoin. So, and if the child was already on some anti-epileptic, then after aborting the seizure, you can reload with the same anti-epileptic if there was inadequate dosage or compliance issues or GI infections, vomiting, diarrhea, and so on. So the best answer here is valproate is not the first drug to be given to control the seizures. Diazepam, yes, it can be given, but let us look for whether midazolam, lorazepam is there in options. Phenytoin, no. Haloperidol, no. So the best answer out of the given options is diazepam. Ideally, so injectable drugs should be used to abort the seizures. Okay, so you have to use the IV injection. If that is not possible, then you can give it intrabuccal. You can give it, okay. Or even if that is not possible, sometimes if no vascular access is there, you may try intraosseous line. And diazepam has an advantage, it can be given rectally also. But though the absorption and all is going to be erratic and not very useful at the time of active seizures. Okay, so intravenous route is the preferred route. And preferred drugs are lorazepam, not available, then midazolam, not available, then diazepam. And then go ahead with the anti-epileptics. You can use phenytoin. If seizures are not controlling with that, repeat phenytoin, otherwise valproate, and so on. The next question, a 7-year-old child presents with short stature. So again, you have a case scenario where a 7-year-old child presents with short stature. So he's short. On biochemical examination, growth hormone levels are normal, but with very low levels of IGF-1. So, we should have a little bit idea about the growth hormone physiology here, how it acts to answer this question. And which of the following could be the possible defect in the child? The options are GHRH deficiency, GHRH receptor deficiency, deficiency, GH receptor deficiency or resistance. So, what happens in the normal growth hormone physiology? So, from the hypothalamus, there is secretion of the growth hormone releasing hormone, which acts on the growth hormone releasing hormone receptor and which helps in the secretion of growth hormone. So stimulates growth hormone secretion from pituitary, but it is a pulsatile secretion. So doing a single growth hormone level may not be very useful. What you have to do whenever you're suspecting growth hormone deficiency, you have to do growth hormone stimulation tests using agents like insulin, clonidine, arginine, or glucagon. Okay, so growth hormone secretion is stimulated from pituitary. It acts on growth hormone receptors and there is production of IGF-1, insulin like growth factor 1, synthesized from liver and ends of long bones, and that helps in the growth of the child. Okay. Now, the features of growth hormone deficiency, that is a proportionate short stature. So in growth hormone deficiency, what you get is a proportionate short stature. That means the upper segment is to lower segment ratio is normal, but the bone age is delayed. The maturity of bones or the fusion of epiphyses is delayed. So delayed bone age. So that is a typical feature you get. And you can get, if associated other hormones of pituitary are deficient, you can get other features like hypoglycemia, midline defects, obesity, change in voice, and so on. Now, the features of growth hormone deficiency can either be if there is a deficiency of GHRH. Okay, GHRH is not getting released in adequate amount. So, deficiency of GHRH can lead to growth hormone deficiency. Okay, so what you will get here is the growth hormone releasing hormone level will be low, growth hormone level will be low, and IGF-1 level will also be low. What else can happen? There can be a resistance at the level of growth hormone releasing hormone receptor. It is not able to act. So GHRH receptor resistance or mutation. Then what will happen in this case scenario? Just think logically. So growth hormone releasing hormone is there. Okay. So the level is normal or high. No problem with the growth hormone releasing hormone. But it is not able to act on its receptor. If it is not able to act on its receptor, growth hormone will not get released or synthesized. So the growth hormone level will be low and IGF-1 level will be low. Right? Now what happens in growth hormone deficiency? So in growth hormone deficiency per se, the growth hormone is not getting released. Okay. So there is growth hormone deficiency. So what will you get? Just think logically again. So GHRH, we are not bothered about the GHRH level any further because now we are coming to the growth hormone level. So the growth hormone level is going to be low and IGF-1 is also going to be low. Right? But what will happen if there is growth hormone receptor resistance? So if there is resistance to the action of growth hormone receptor. So if there is resistance to the action of growth hormone receptor. So growth hormone receptor resistance. So what is the problem here? So here growth hormone levels are not a problem. So growth hormone here level will be normal or high. But IGF-1 will be low. Right? Because no problem in the synthesis of growth hormone, but it is not able to act on its receptor. If it is not able to act on its receptor, IGF-1 will not be produced. So in our given clinical scenario, what we have here is growth hormone levels are normal, but with very low levels of IGF-1. So it is fitting in which scenario? So you can see growth hormone levels are normal or high, but IGF-1 low. So it is fitting with growth hormone receptor resistance. Or there is some mutation at the level of growth hormone receptors, okay, or the deficiency of growth hormone receptors. They have not developed properly. So the best answer in the given scenario is, it is not GHRH deficiency because then the growth hormone levels would also have been low, as we already discussed. It is again not GHRH receptor deficiency because then again growth hormone level and IGF-1 level would also have been low. Growth hormone deficiency, then growth hormone levels would have been low, but it is normal, it has mentioned here. So there is growth hormone receptor deficiency where the growth hormone levels can be normal or increased, but IGF-1 levels will be low. So very, very easy to answer if you understand it logically. And as we mentioned, growth hormone is a dynamic hormone which has pulsatile secretion. So in order to know the growth hormone levels correctly, one-time estimation of growth hormone level is not enough. What you have to do is provocative tests like growth hormone stimulation tests, and you use either insulin, clonidine, or arginine, or glucagon to do growth hormone stimulation tests. And a growth hormone, the peak growth hormone level less than 10 nanograms per ml is suggestive of growth hormone deficiency. Moving on to another question with a case scenario that we have here. So what we have here is a 3-week-old baby who was brought to the pediatric OPD with yellowish discoloration of skin. So a jaundice still present in a 3-week-old baby indicates delayed removal or delayed resolution of neonatal jaundice or prolonged physiological jaundice. And hypotonia is there. Tone of muscles is less. On examination, baby has large protruded tongue and umbilical hernia. So all this fit in a clinical diagnosis of congenital hypothyroidism. Congenital hypothyroidism, where what you can get is myxedematous facies or puffy looking facies. Myxedematous facies or puffy looking facies can be there. Okay. What else? There can be prolonged physiological jaundice. Mottled skin can be there because of cold intolerance. Okay, mottled skin can be there. There can be constipation, large tongue, hoarse cry can be there. umbilical hernia can be there. So all these are the clinical features, typical clinical features of congenital hypothyroidism. And if you don't treat them early, these babies are going to develop developmental delay, intellectual disability, and so on. And we know the most common cause of congenital hypothyroidism in children is thyroid dysgenesis. While in a child with goiter, most common cause of congenital hypothyroidism would be thyroid dyshormonogenesis. Okay. Now, if we are suspecting congenital hypothyroidism in the given case scenario, then of course we will not do a serum cortisol level, but serum TSH level or thyroid stimulating hormone level is a good screening test for thyroid hormone deficiency. Sepsis screening not required. We are not thinking of sepsis with the given case scenario clinical picture. Serum IGF-1 levels, again we are not thinking of growth hormone deficiency. And otherwise also serum IGF-1 level alone is not a very good indicator of growth hormone deficiency. So the best answer here is serum TSH level. So we'll do a thyroid stimulating hormone level, and if that is high, we'll again confirm it with a T4 level. We will see that the T4 level is low, okay, and then we have to start thyroid hormone supplementation as soon as possible. So as we mentioned, the most common cause of congenital hypothyroidism in a child is thyroid dysgenesis. That means the thyroid gland has not developed properly. Thyroid dysgenesis. But if the question is in a child with goiter, that means goiter is already there. That means structurally thyroid gland is present. So now it is more of a problem with hormone synthesis than a problem of thyroid gland synthesis. So in a child with goiter, if it is there, that means thyroid gland is there. Structurally it is there. So it would be thyroid dyshormonogenesis. Thyroid dyshormonogenesis. And ideally, newborn screening should be done after 48 hours of life. Anytime it can be done, okay? Preferably in the first week of life, to pick up even the asymptomatic cases of congenital hypothyroidism, because if the treatment for congenital hypothyroidism is not started timely, it can have lifelong consequences. So these are some very, very important questions that came in the recent FMGE exam. And as you can see, the paradigm shift now to the clinical scenarios, to apply your analytical skills, to build your concepts, to understand things wherever possible, so that these questions are not very tough. If you are aware of the typical case scenarios, if you are able to reach to the diagnosis, then the questions become very, very simple to answer. So whenever you're studying, just try to study in depth, because it will help you not only to pass your FMGE exam, but also when you come out and as doctors and you're serving the community, so you will be better able to pick up and make clinical diagnosis and offer the best treatment timely and as soon as possible. Okay, so keep working hard, try to recognize the case scenarios, try to correlate it with what are the deficiencies and what are the features that you are getting, try to synthesize them together, try to integrate things, and I'm sure that this exam, the next upcoming exam, will be as easy for you as you would have ever expected, or much better than your expectations. Okay,
now we are going to discuss surgery questions of FMGE August 2020. See the first question. A lactating female presented with complaints of pain in one breast. So there is pain in one breast. On examination, affected breast was tender and engorged. So see, there was pain, affected breast was tender and engorged. And this is seen in a lactating female. Baby refused to feed from the affected breast. What is the preferred treatment option? So first of all, what is the diagnosis? Lactating female, having pain, there is tenderness, and the breast is engorged. So most probably this is a case of what? Breast abscess. So this patient is having what? Breast abscess. Now generally what is the problem? This breast abscess is seen in lactating females, especially during first 5 weeks of lactation, and it is more common in preemies. Clear? What is the treatment of choice for breast abscess? For breast abscess, the treatment of choice is incision and drainage with antibiotics. There was one question which was asked in the NEET 2020, that what is the first line antibiotic given in breast abscess? See, first, what is the organism? Whenever there is faulty technique of breastfeeding, there are certain trauma caused by the fetus. Now, what is the etiology? See, because of faulty technique of breastfeeding, there is trauma caused by the baby, and there is organism Staph aureus in the skin which is responsible for the breast abscess. So the first line antibiotic for breast abscess is cloxacillin or dicloxacillin. So the antibiotic is what? Cloxacillin or dicloxacillin. Clear? This was the question which was asked in the NEET, and generally we give cloxacillin or dicloxacillin for 10 to 14 days. Clear? So the treatment of choice is incision and drainage with antibiotics, and which antibiotics is given? First line antibiotic is cloxacillin or dicloxacillin. Clear? So the correct answer is here D. So here you can see how the breast abscess looks like. Clear? And after incision and drainage you can see pus coming out, right? Now how we can easily rule out the options? First option is antibiotic only. So it's not only antibiotic, we have to go for drainage. Only NSAIDs, no. Only warm compresses, no. So correct answer for this question is D, that is incision and drainage with antibiotics. Now see this second question. In a patient with thyroid swelling, what the surgeon should advise before doing the thyroid surgery? Now see, whenever any patient is coming to us with any kind of thyroid nodule, what is the first investigation done? So in any patient with thyroid nodule, the first investigation done is, yes, it's thyroid function test. So the first investigation is thyroid function test. In thyroid function test, what is included? T3, T4 and TSH. So question is asked, out of this T3, T4 and TSH, which one is most sensitive? Yes, so obviously it is TSH. Because of ultra sensitivity of TSH, you can easily detect subclinical hypothyroidism as well as subclinical hyperthyroidism. So first investigation done in workup of a thyroid nodule or in solitary thyroid nodule, and that is thyroid function test. Specifically it's the TSH because of its ultra sensitivity. Okay. Second question, what is the investigation of choice for diagnosis of solitary thyroid nodule? So if question is asked investigation of choice for diagnosis of solitary thyroid nodule, so that is FNAC. So FNAC is investigation of choice, right? Now there are certain limitations of FNAC which is frequently asked in exam. So what are the limitations? First, FNAC cannot differentiate follicular adenoma from follicular carcinoma. Why? Because the diagnosis of follicular carcinoma is based on vascular invasion or capsular invasion, right? And this vascular invasion or capsular invasion is only seen on biopsy. What is the second limitation of FNAC? You cannot diagnose renal thyroiditis. Why? Because in renal thyroiditis there is excessive fibrosis. So for that also you need biopsy. And third, for diagnosis of thyroid lymphoma, the investigation of choice for diagnosis of thyroid lymphoma is also biopsy. So these are the limitations of FNAC. Otherwise, investigation of choice for diagnosis of solitary thyroid nodule is what? It's the FNAC. Clear? So in patient with thyroid swelling, what surgeon should advise before doing thyroid surgery? It's the thyroid function test, and specifically out of T3, T4, TSH, which one? TSH. So see this flowchart from Subiston. This is the workup of thyroid nodule patient. So here, if a patient is having thyroid nodule, after history and physical examination, what is the first investigation done? And the first investigation done is TSH. Clear? After that, if there is nodule, generally investigation of choice for diagnosis, and the investigation of choice for diagnosis is FNAC. Now see the statement written in Harrison, enhanced sensitivity and specificity of TSH assays greatly improved the laboratory assessment of thyroid function. Because TSH levels change dynamically in response to alteration of T4 and T3, a logical approach to thyroid testing is to first determine whether TSH is suppressed, normal or elevated. So correct answer for this question is A, that is thyroid function test. So this is an easy question, and this question was asked many times in most of the exams. It was asked in AIIMS also, it was asked in NEET also, and it was asked many times in FMG also. See, patient presented with presence of thyroid swelling. So there is thyroid swelling and weight loss. Okay, so there is thyroid swelling and weight loss. Physician found presence of cervical lymphadenopathy. Okay, so thyroid swelling, weight loss, cervical lymphadenopathy means enlargement of cervical lymph nodes. These points favor the presence of malignancy. Weight loss and lymphadenopathy, indirect evidence of malignancy. Decided to go for thyroid biopsy. Histopathology report shows the presence of cells with orphan NEI nuclei. Clear? Now, all these features are highly suggestive of what? Papillary carcinoma thyroid. You must be knowing that in papillary carcinoma thyroid, what's the most common route of spread is lymphatic. So there is cervical lymphadenopathy. Clear? And if we go for FNAC, on FNAC, what happens? There is optically clear nuclei, and you can see here these optically clear nuclei. These are also known as orphan NEI nuclei. Clear? So what is the correct answer? It is papillary carcinoma thyroid. So correct answer for this question is A. Now see this question. 35 years old women presented with complaints of palpitations, weight loss. So there is palpitations and weight loss. Sinus tachycardia is present and following lesion was noticed on the shin of the patient. What is the clinical diagnosis? See the options first. If we have to rule out whether this patient is having hypothyroidism or hyperthyroidism on the basis of clinical features, see, the patient is having palpitations, weight loss and sinus tachycardia. Be careful. In patients of hypothyroidism, there is bradycardia, there is weight gain. Clear? So the findings are suggestive of what? Hyperthyroidism. One thing. Second, see the presentation. If you see the color of the skin here, it's orange. And if you see this edematous limb, and this edema is mainly present over which aspect of the limb? Can you see? Shin, anterior aspect as well as lateral aspect, right? So the changes are present over the shin, mainly over the anterior aspect and lateral aspect. And what is the name of this condition? This is known as pretibial myxedema. This is pretibial myxedema. Clear? So pretibial myxedema, it is classically seen in the patients of Graves' disease, though it's not very common in the patients of Graves' disease. Clear? So what is the correct answer here? The correct answer is B, that is hyperthyroidism. So this pretibial myxedema is also known as what? Thyroid dermopathy. And generally this thyroid dermopathy is seen in less than 5% of patients. Clear? Now see what is the location of this pretibial myxedema? Over the anterior and lateral aspect of lower leg. That's why known as pretibial myxedema. Second, it is also present over the dorsum of foot. Now, if you see the exact appearance, it is non-inflamed. There is presence of indurated plaque with deep pink or purple color, and that's why it looks like orange skin appearance. Clear? So this pretibial myxedema is seen in patients of Graves' disease. So here the correct answer is B, that is hyperthyroidism. See this question. 35 years old, recently divorced male suffering from palpitations, headache and diaphoresis. Okay. So there is palpitations, headache and diaphoresis. Clear? And you must be knowing that all these are the components of triad of which particular disease? Pheochromocytoma. So triad of palpitations, headache, excessive sweating or diaphoresis suggest the diagnosis of what? Pheochromocytoma. Now you can see all these episodes are seen on recurrent basis. He has visited the psychiatrist multiple times, right? Be careful. Pheochromocytoma is a great masquerader, so patient might be having what? The psychiatric manifestations. What should be the next best step for management of this case? Since patient already visited psychiatrist and these symptoms are occurring on the recurrent basis, so what is the correct answer? He should visit psychologist instead of psychiatrist. Wrong. Check for catecholamine levels to rule out pheochromocytoma. Yes, because the diagnosis of pheochromocytoma can be suggested by catecholamines or by assessment of its byproducts either in the blood or in the urine. Check for hyperthyroidism. Generally, in hyperthyroidism, there can be palpitations, sweating, but headache is not a common manifestation and usually not seen. Increase the dose of anti-anxiety medications. So this is also incorrect. So correct answer for this question is B. Why? Because patient is having palpitations, headache and diaphoresis, and all these three are included in the triad of pheochromocytoma. So see what's written in Harrison. Episodes of palpitations, headache, profuse sweating are typical, and these manifestations constitute a classic triad of pheochromocytoma. Clear? So presence of all three manifestations with hypertension makes pheochromocytoma a likely diagnosis, right? Now how we can make the diagnosis of pheochromocytoma? By laboratory investigations, by documentation of catecholamine excess or its byproduct either in the blood or urine, right? So you can easily make the diagnosis, and for localization you need another investigation. Clear? Now in pheochromocytoma, if we are going to compare catecholamines and metanephrines, the metanephrines are having better sensitivity. Clear? So if the two options are mentioned and if we have to choose one, metanephrines or catecholamines, obviously we will go for what? Metanephrines. So here the correct answer for this question is B. Now see, this question is also related to the previous one. Patient presents with complaints of palpitations. Okay. On examination, her heart rate is 110 per minute. So patient is having palpitations. Okay. Patient is having tachycardia 110 per minute and respiratory rate of 10 per minute. She tells you that her mother has recently expired due to RCC. Clear? So now just correlate. If there is family history of RCC and this patient is having palpitations, this patient is having tachycardia, so what is the relation? Patient might be having what? Pheochromocytoma. And is there any relation between pheochromocytoma and RCC? Now see, pheochromocytoma is associated with important syndromes. And what are those important syndromes with which it is associated? The mnemonic is MVVS. So pheochromocytoma is associated with 4 important syndromes. MVVS is the mnemonic. M means this is men 2A 2B. Okay, multiple endocrine neoplasia 2A 2B. V, this is von Hippel-Lindau syndrome, VHL syndrome. Clear? This is von Recklinghausen syndrome. Von Recklinghausen syndrome, other name is neurofibromatosis 1, and this is Sturge-Weber syndrome. Clear? So it is men 2A 2B, von Hippel-Lindau syndrome, that is VHL syndrome, von Recklinghausen syndrome and Sturge-Weber syndrome. These are 4 important syndromes associated with pheochromocytoma. Now out of these 4, which one is associated with RCC also? And you must be knowing that it is VHL syndrome. So VHL syndrome is associated with RCC also. Clear? And there is family history also. Okay. So what? Most probably this patient is having VHL gene mutation which is located on chromosome number 3, and this is associated with pheochromocytoma as well as what? RCC. You must be knowing that patients of VHL syndromes have what? Hemangioblastoma, especially in the retina and CNS, and it is located in which part of brain? Cerebellum. There are multiple cysts in kidney, pancreas, epididymis, and these patients are having what? RCC, pheochromocytoma and pancreatic islet cell tumors. Clear? So the patient must be having pheochromocytoma because there is family history and there are symptoms. Just now we discussed how you can diagnose the pheochromocytoma. We can make the diagnosis with either detection of catecholamine excess in blood or urine or metanephrines. And if both options are mentioned, which one is preferred? Obviously, it's the fractionated metanephrines. Clear? Now see one by one the options. Serum hydroxyindole acetic acid. So this is HIAA, and you must be knowing this is used for which neuroendocrine tumor? It is used for carcinoid tumors. Okay, serum catecholamines and 24 hours fractionated metanephrines, these are used for what? Pheochromocytoma. And if you see VMA, vanillyl mandelic acid, this is used for neuroblastoma. Be careful, all these three are very important. 5-hydroxyindole acetic acid, this is for VMA is for neuroblastoma. Catecholamines and metanephrines, this is for pheo. Out of these two options, we have to choose the better one. And 24 hours fractionated metanephrines, these are having better sensitivity as compared to catecholamines. So here, correct answer for this question is D. Now see the table given in Harrison. So here see the plasma catecholamines, and here see the 24 hours urinary fractionated metanephrines. Clear? So which one is having better sensitivity? It's the fractionated metanephrines. So for this question, the correct answer is 24 hours fractionated metanephrines. Again, this is a repeat question. This question was asked many times in many exams. Okay. 45 years old male presented with abdominal pain and hepatomegaly. Right? Ultrasound image is given below. What is the most probable diagnosis? Now can you see, on the basis of this ultrasound image only, you can make the diagnosis that this is water lily sign, and this water lily sign is seen in hydatid cyst. Okay, this is floating membrane, undulating membrane, also known as water lily sign, also known as water snake sign. Right? Now let's rule out the options. If we are talking about this amoebic liver abscess, in amoebic liver abscess, what happens? There is abdominal pain, so it's there, but in abscess there is fever also. Clear? In amoebic liver abscess, most common symptom is abdominal pain, whereas in pyogenic liver abscess it's the fever. So fever is not there, fever is there in liver abscess. Clear? So these two options are ruled out. Simple hepatic cyst is generally asymptomatic. Clear? Until and unless some complication is going to occur. And if there is simple hepatic cyst, on ultrasound there is posterior acoustic in heart. Right? So this is also ruled out. So correct answer for this question is A, that is hydatid cyst. Now can you see these two clues are there? So let's discuss. In hydatid cyst, majority of patients are asymptomatic, but the most common symptom is what? Abdominal pain. And the most common sign is what? Hepatomegaly or enlarged liver. Clear? So most common symptom abdominal pain, most common sign hepatomegaly, and on this ultrasound there is water lily sign, also known as water snake sign. So what is the diagnosis? It's the A, that is hydatid cyst. Now see this question, which of the following is implicated in development of angiosarcoma of liver? This question was asked many times, right? For development of angiosarcoma of liver, there are three causative agents which are frequently asked in exam, and how to remember? Mnemonic is angio-VAT. So it's angio-VAT. V means vinyl chloride. It's the vinyl chloride. Okay. A means arsenic, and T means thorotrust. It's the thorotrust. Clear? So you can easily make out what is the correct answer. So the correct answer for this question is what? C, that is arsenic. Now see what's written in Robbins. So hepatic angiosarcoma is associated with carcinogenic exposures, including what? Arsenic, generally which is present in pesticides. Thorotrust was a radio contrast agent, nowadays it's not used, and polyvinyl chloride, a widely used plastic. Clear? So these are the three agents which are responsible for causation of what? Angiosarcoma liver. But nowadays what? we are very careful in using these substances. Thorough trust is nowadays not used. So nowadays this malignancy is very rare. Angiosarcoma of liver is very rare. Okay, so correct answer for this question is C, that is arsenic. A similar question, image based question, was asked in NEET 2019. Now see, the image of gallbladder specimen is given below. What is the most probable diagnosis? So what you can see here, you can see that this is the gallbladder specimen. Okay, and in this gallbladder specimen you can see that there is a growth, and this is a polypoidal growth which is exophytic. Clear? So this is exophytic growth which is polypoidal. You can see there is thickened wall also. So what is the diagnosis? This patient is having carcinoma gallbladder. So correct answer for this question is carcinoma gallbladder. In strawberry gallbladder, the gallbladder appears like strawberry. The other name of strawberry gallbladder is what? Cholesterolosis. Generally in the gallbladder polyp, what happens? Generally there is a well defined polyp which can be pedunculated or sessile, but not like this which is irregular, exophytic. Mixed gallbladder stone. So if there is mixed gallbladder stone, you can see the stone in the lumen, but there won't be any growth from the mucosa or from the fundus or from the gallbladder itself. So correct answer for this question is A. So in carcinoma gallbladder, there are two kinds of pattern. So two kind of patterns are seen. Infiltrating pattern is more common than exophytic. Okay, so if there is infiltrating pattern, so what happens? It is going to infiltrate the gallbladder wall, and after that it can involve what? Liver. Sometimes it is going to infiltrate the surrounding viscera, and it can cause what? Right? The less common is exophytic one, which was shown in the image, and it is having irregular cauliflower like mass. And if you see, question is asked, what is the most common site of carcinoma gallbladder? So in majority of cases, the growth is arising from fundus. In 60% cases, in 30% cases it is in the body, and in 10% cases it is in the neck. So see the appearance here, the correct answer is carcinoma gallbladder for this question. Now see this question. Again, it's an easy question and it is a repeat question. Specific tumor marker for carcinoma pancreas. Now let's discuss these markers one by one. If we are talking about any kind of adenocarcinoma, there is a non-specific tumor marker which is raised, and that is CEA. So CEA is a non-specific tumor marker for adenocarcinoma. If you are talking about neuron-specific enolase, this is raised in small cell lung cancer and neuroblastoma. This question is also asked frequently. Neuron specific enolase is raised in small cell lung cancer and neuroblastoma. And you must be knowing that alpha fetoprotein is raised in hepatocellular carcinoma, non-seminomatous germ cell tumor. What? Non-seminomatous germ cell tumor. Okay? And carcinoma lung. So in testicular tumors it is raised. Which types? Especially non-seminomatous germ cell tumors. Now coming to CA99. CA99 is a relatively specific tumor marker for biliary and pancreatic tract malignancies. Biliary and pancreatic tract malignancies means it is relatively specific tumor marker for carcinoma gallbladder, cholangiocarcinoma and carcinoma pancreas. So carcinoma gallbladder, cholangiocarcinoma and carcinoma pancreas. Clear? So correct answer for this question is obviously it is A. The specific tumor marker for carcinoma pancreas is CA99. So again, this is a repeat question. It was asked many times. It is asked in surgery, medicine, pathology. Which of the following is characteristic feature associated with Barrett's esophagus? So you must be knowing that in Barrett's esophagus, what's the problem? There is gastroesophageal reflux disease. So because of gastroesophageal reflux disease, there is columnar metaplasia. And in this columnar epithelium, there is columnar metaplasia. You must be knowing that the epithelium of esophagus is squamous and epithelium of stomach is columnar. So there is columnar metaplasia, one. Second, this columnar metaplasia is having goblet cells. That's why it is known as what? Intestinal metaplasia. So how we are going to make the diagnosis of Barrett's esophagus? If we are going to perform the endoscopy, first the endoscopic appearance. So there is tongue-like appearance, there is tongue-like mucosa which is having velvety appearance, which is suggestive of what? Columnar epithelium. And whenever we are going to take the biopsy, there should be presence of what? Goblet cell. So this is known as intestinal metaplasia with goblet cells. So correct answer for this question is C. Now see how it looks like, because sometimes image based questions are also asked. So here you can see there is pale squamous epithelium, clear, and here you can see the tongues of columnar epithelium. So this is velvety red. So this appearance on endoscopy, and on biopsy you can find what? The presence of goblet cells. So this is intestinal metaplasia with goblet cell, which is the characteristic feature of Barrett's esophagus. So correct answer for this question is C, intestinal metaplasia with goblet cells. So see the important statement written in Sebastian and Bailey about Barrett's. So histological alteration in Barrett's is known as intestinal metaplasia, and if you see on endoscopy, there is velvety red tongue of mucosa that extends cephalad from GE junction. And what kind of metaplasia? There is presence of mucus secreting goblet cells, and this is known as what? Intestinal metaplasia. So intestinal metaplasia with goblet cell is characteristic feature of Barrett's esophagus. Now again this is a repeat question. Here you can see barium swallow showing what? The bird beak appearance, or rat tail appearance, or pencil tip appearance. So this is the classical finding seen in patients of achalasia cardia. What is the problem in achalasia cardia? The patients of achalasia cardia are having what? Absence of failure of LES relaxation. So if there is absence of LES relaxation, whatever the food stuff patient is going to eat, whatever the liquid patient is going to take, generally most of these things are collected into the esophagus. Clear? And whenever we are going for barium swallow, this kind of appearance is seen. So there is bird beak, there is pencil tip or rat tail appearance. So bird beak, pencil tip or rat tail appearance. There is one question, and in certain books it's written that rat tail appearance is seen in carcinoma esophagus. It's not exactly rat tail appearance which is seen in carcinoma esophagus. It's the rat tail filling defect. Rat tail filling defect which is seen in carcinoma esophagus. So all these three findings are seen in achalasia cardia on barium swallow. So correct answer for this question is achalasia cardia. So this is the appearance. You can see rat tail appearance, bird beak appearance. Both of these are seen in achalasia cardia. See this question, it's a bit difficult. After Nissen's fundoplication for GERD, you must be knowing that in gastroesophageal reflux disease, we perform laparoscopic Nissen's fundoplication. Patient was there in his bed with stable vitals. What should be done next? There might be some problem in the language of question and options. So this is what I got from the students. And if we see this particular language and these options, so what is the best answer? First, what is Nissen's fundoplication? The patients who are having gastroesophageal reflux disease, the treatment of choice is laparoscopic Nissen's fundoplication, in which we plicate the fundus around esophagus. How it looks like? So this is the appearance. Here you can see I have plicated the fundus in front of esophagus, and circumferentially it is going to cover almost whole esophagus. So this is 360-degree fundoplication. Generally it is performed laparoscopically. Whenever we are performing this operation via laparoscopy, so during laparoscopic procedure what happens? Sometimes there is tear in the diaphragm, and whenever there is tear in diaphragm and pleura, what happens? Since we are going to insufflate carbon dioxide, which is the gas used for creating pneumoperitoneum, the gas enters into the pleura, and when gas enters into the pleura, patient will be having what? Pneumothorax. What is the good thing? That CO2 is absorbed. It's not air, so CO2 is absorbed. That's why no further intervention is required. Only during surgery, whatever the tear is there, we are going to repair that with the help of staples or with the help of stapler. Clear? In post-operative period, question is asked, one of the most common complication of Nissen's fundoplication, so that is pneumothorax. In post-operative period, if patient is having symptoms, okay, patient is having respiratory distress, we have to go for a check X-ray. And if on check X-ray patient is having pneumothorax and there is no improvement, we can insert a chest tube. But in majority of patient, what happens? If the patient remain asymptomatic, there is no complication, so this pneumothorax is going to resolve on its own. So ideally nothing is required if the patient is having no symptoms and patient is having stable vitals. So what is the correct answer? Insert drain and monitor? No. Insert chest tube? No. Monitor vitals? Yes. Now see what's written in subiston related to pneumothorax in Nissen's fundoplication. Pneumothorax is one of the most common intraoperative complication. Okay, so the pleural violation during surgery results in intrathoracic infusion of CO2. But what is the good thing? It is absorbed rapidly, and generally there is no underlying lung injury, so lung expand, right? Unless patient experiences shortness of breath or persistent oxygen therapy to maintain normal hemoglobin oxygen saturation, no further radiographs are obtained and generally no intervention is required. Now see, again this is a repeat question because this question was asked more than 100 times, and generally this kind of question is asked almost every year in one of the exam. 60 years old man, only language is different. 60 years old man has presented with chronic projectile vomiting with significant weight loss. Okay, so see, significant weight loss is there, age 60, and there is gastric outlet obstruction finding, chronic projectile vomiting. So we think what, that patient must be having carcinoma stomach, and the location is antrum, and this leads to what? Gastric outlet obstruction. Most common cause of gastric outlet obstruction is carcinoma stomach. Clear? Okay. Which of the following electrolyte abnormality is seen in this patient? It's very easy. See, whenever there is gastric outlet obstruction and patient is having multiple episodes of vomiting, what patient is going to vomit? Yes, the acid in stomach, HCl, and there is mucus secreted by stomach that contains potassium. So what happens? This patient will be having hypokalemia, hypochloremia and metabolic alkalosis because there is loss of protons, H+, right? Now body is going to sense this metabolic alkalosis, and when body is going to sense the metabolic alkalosis, what happens? In kidney, especially in collecting duct, there is sodium proton exchanger. So what? There is sodium proton exchanger. So since there is loss of protons in the vomiters, what this kidney is going to do? It is going to absorb H+ and it is going to excrete sodium. This is seen in the beginning. But what happens over a period of time, and if patient is having multiple episodes of vomiting, it's very severe. So what is the problem? Because of excretion of sodium in urine, the patient is having hyponatremia. Clear? And if sodium is going in the urine, it takes water also, so patient is dehydrated. Okay, so the problem in severe cases, patient is having hyponatremia and this patient is having dehydration. When body is going to sense severe hyponatremia and dehydration, now the kidney is preserving sodium and start excreting H+. And if kidneys start excreting H+ in the urine, this is what? Paradoxical aciduria. Why? Because patient is having alkalosis, metabolic alkalosis, but acid is being secreted in urine. Clear? So this is what? Paradoxical aciduria. Okay. Second, since sodium is absorbed in urine, also potassium is being excreted. So what is the problem? If you see, there is decreased potassium, so hypokalemia, decreased chloride, so there is hypochloremia, decreased H+, so there is metabolic alkalosis, decreased sodium, so there is hyponatremia, along with paradoxical aciduria. So what happens there is paradoxical aciduria. Clear? And the similar picture is also seen in the patients who are having hypertrophic pyloric stenosis. So generally this question is asked in this form, that what is the most characteristic electrolyte abnormality or dyselectrolytemia of hypertrophic pyloric stenosis, and that is what? Hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. This time they have added hyponatremia at the place of paradoxical aciduria. Clear? So what is the correct answer? Hypokalemia, hypochloremia, metabolic alkalosis with hyponatremia. So correct answer for this question is A. So this is the statement related to gastric outlet obstruction which is mentioned in the Bailey. Vomiting of hydrochloric acid results in hypochloremic alkalosis, one thing, and initially urine has low chloride and high bicarbonate content. So this bicarbonate is excreted along with sodium. So this patient becomes hyponatremic and dehydrated. Over a period of time, sodium retention follows and potassium and hydrogen are excreted. And this leads to characteristic dyselectrolytemia in patients of gastric outlet obstruction. What is the diagnosis based on the given image of barium enema? So you can see this is barium enema. Here you can see this is barium. And beyond this you can't see anything. Why? Can you see? It's something like this. So what is the problem? There is telescoping of one segment of bowel into another. Clear? So this is a case of what? Intussusception. And in intussusception on barium enema, there are two characteristic findings which are frequently asked. This is known as what? Claw sign, and there is second one that's known as coiled spring sign. Clear? So the correct answer for this question is intussusception, D. So this is claw sign, and there is another sign known as coiled spring sign. So you can see this is intussusception, telescoping of one segment of bowel into another, and this is how claw sign looks like, and this is coiled spring sign. You must be knowing that this coiled spring sign was asked in NEET. There was an image based question, and it was asked that this is seen in which condition. So claw sign and coiled spring sign, these are seen in intussusception. The various questions related to radiology which are asked about intussusception, have a look. So in cases of intussusception, if we go for plain X-ray, obviously you will find what? The findings of small bowel obstruction. Second, there is target sign and meniscus sign on plain X-ray. The classical findings on barium enema, coiled spring sign and claw sign. And if we go for ultrasound, there is target sign also known as bull sign, also known as target sign, bull sign, and there is another sign, pseudo kidney sign. Now question is asked, if we go for transverse scan, on transverse scan which sign is seen? So target sign and bull's eye sign, these are seen on transverse scan. And if you are going for longitudinal scan, yes, there is pseudo kidney sign. So these are important radiological appearances which are asked about intussusception. Now see this question, 35 years old patient with ulcerative colitis, okay, develops ulcer on the anterior compartment of leg. Comment on the diagnosis. Now see what is the problem here. This patient is having ulcer, okay, so there is ulceration. And if you see the color here, what's the color? Purple. So here, can you see the color? Yes, it's purple. And if you see the edges, undermined edges. Clear? So the clue, patient is having ulcerative colitis, and you know that pyoderma gangrenosum is seen in ulcerative colitis. The pyoderma gangrenosum, there is ulcer. The color of skin around ulcer is purple, so purple colored skin, and this ulcer is having undermined edges. Clear? So what is the correct answer for this question? Pyoderma gangrenosum. Lots of questions are asked related to extra-intestinal manifestations in inflammatory bowel disease. Means which manifestations are more common in Crohn's disease and which manifestations are more common in ulcerative colitis. So see, PG in UCMS. PG in UCMS means pyoderma gangrenosum is more common in ulcerative colitis. Clear? So pyoderma gangrenosum is more common in ulcerative colitis, PG in UCMS. Second, IPASU is more common in Crohn's disease. Okay, IPASU means E means erythema nodosum, P means peripheral arthritis, A means ankylosing spondylitis, S means stones. What kind of stones you must be knowing? That there is gallstone also and oxalate renal stones also. So what? Gallstones and oxalate renal stones. ठीक है? Okay. So gallstones and oxalate renal stones, and if there are stones in the kidney, there is fibrosis stricture formation. So what? Ureteral obstruction. Ureteral obstruction. Clear? So erythema nodosum, peripheral arthritis, ankylosing spondylitis, stones, ureteral obstruction. These are common in Crohn's disease, right? And pyoderma gangrenosum is more common in ulcerative colitis. So correct answer for this question is D, that is pyoderma gangrenosum. Now see what's written in Bailey related to pyoderma gangrenosum. First, it is characterized by cutaneous ulceration. What kind of edges? Purple undermined edges. And generally it is because of heightened immunological reactivity because of some other disease process like inflammatory bowel disease. We discussed that it is more common in ulcerative colitis as compared to Crohn's. Other situations, rheumatoid arthritis, non-Hodgkin's lymphoma, Wagner's granulomatosis. And generally, pyoderma gangrenosum respond to steroid surgery is rarely indicated for this condition. Now see this question. There was one image based question, something like this, in which there was a tumor in appendix and it was associated with raised chromogranin levels, right? So if you see here, you can see that this is yellow colored tumor, and if you see the mucosa is intact here. Can you see? And the peritoneum is also intact. It means it is localized tumor. So localized tumor in the appendix. Second, the appearance is yellowish and there is raised chromogranin levels. So all these findings are suggestive of what? Neuroendocrine tumors. Okay. So this is suggestive of a neuroendocrine tumor in appendix. And what is that most common neuroendocrine tumor in appendix? And that is carcinoid tumor. So that's carcinoid tumor, right? Now if you see the options, there is neuroendocrine tumor also which is mentioned in the options, and carcinoid tumor is also mentioned. So both of these are correct, right? So for this question, B and D, both options are correct. Now see what's written in Bailey related to carcinoid tumors or neuroendocrine tumors of appendix. The neoplasm feels moderately hard, okay, and on sectioning the appendix it can be seen as yellow tumor between intact mucosa and the peritoneum, right? And characteristic pattern, there is tumor cells are small, arranged in small nest within the muscle and have a characteristic pattern with positive chromogranin B. Clear? So characteristic pattern using immunohistochemical stain for chromogranin B, right? So by looking at all these, the correct answer for this question is neuroendocrine tumor or carcinoid tumor. So for this question, both B and D are correct. Again, this is an indirect repeat because similar questions were asked many times. See, which of the following is not the incision used for appendectomy, right? So what are the incisions which are used for appendectomy? If you see, this is the abdomen, this is the umbilicus, and this is the anterior superior iliac spine. If I'm going to join these, this is known as spino-umbilical line. Okay, on this spino-umbilical line there is a point known as McBurney's point. What is the location? At the junction of medial 2/3 and lateral 1/3. So this is McBurney's point. If I give incision centered at McBurney's point and perpendicular to spino-umbilical line, this is known as McBurney's incision. okay, also known as MacArthur incision, also known as gridiron incision, and all these are muscle splitting incision. Clear? There is one incision which is placed on a line joining midpoint of clavicle to the midpoint of inguinal ligament. Clear? So if there is a line joining midpoint of clavicle to midpoint of inguinal ligament, and we are going to place a transverse incision 2 centimeter below umbilicus, and that's known as Lange incision. Okay, so one is McBurney's, also known as MacArthur, also known as gridiron, and second is Lange. See, all these incisions are muscle splitting, but sometimes for better exposure of appendix, if you extend the incision laterally after cutting the conjoint tendon means internal oblique and transversus abdominis. Clear? So if you extend the incision laterally by cutting internal oblique and transversus abdominis, this is known as muscle cutting incision, and the name of this incision is what? Rutherford Morrison incision. Okay, so what you saw, we go for gridiron incision, Lange incision, both of these are muscle splitting incision, and there is Rutherford Morrison incision, which is muscle cutting incision. Coker's incision is generally used for open cholecystectomy. This is a subcostal incision. Clear? So these three are used for appendectomy. Coker's incision is not used for appendectomy. Clear? So see the important points related to incision. If you see this one, this is the Coker's incision, and generally this is for open cholecystectomy. This is for open cholecystectomy. For laparotomy, we go for this midline incision, that is 2. Now see, this is McBurney's incision, also known as MacArthur incision, also known as gridiron incision, and you see this transverse incision, this is known as Lange incision. Here you can see 8, that's Rutherford Morrison incision. Space was not there on right side, that's why it is being shown on left side. So this is a muscle cutting incision. Clear? So these are the important incisions. You can see 9th, this is used for cesarean section, so that is phalangeal incision. So these are the various incisions which are asked frequently in the exam, right? So for this question, the correct answer is A. Coker's incision is not used for appendectomy. See the question, fissure in ano, which of the following is not done? So see the basic pathophysiology of fissure. What is the problem? In fissure, it is divided into acute and chronic fissure, and what's the problem? Fissure is characterized by longitudinal split in the anoderm. The extent is from anal verge till dentate line, and what is the location? Posteriorly in the midline, and that is 6 o'clock position. So here you can see location is posteriorly in the midline, that is 6 o'clock position. Now see what is the pathophysiology. There are two problems in the patients who are having fissure. First, there is spasm of internal anal sphincter, okay, and second, these patients are having constipation, right? So the basic pathophysiology is there is constipation and there is spasm of internal anal sphincter. So whenever patient is going for defecation, the internal anal sphincter is not going to relax, and the hard fecal matter is going to pass, and this hard fecal matter causes the injury of pain sensitive anal canal. Simple. Now in the management, what we have to do? First, we have to give stool softeners, and we have to prescribe high fiber diet. 1. Second, you have to relax the spasm so that whatever the tear is there, yes, it is going to heal, because in spasm the vessels are having constriction, and that's why what happens, even a minor tear is there, it's not going to heal properly. Simple. So for relaxation of spasm, what we can give? Yes, we advise the relaxation technique like sitz bath. Second, we have to go for calcium channel blockers, so local application of 2% diltiazem gel or 0.2% nitroglycerin, or we can inject Botox botulinum toxin. The treatment of choice is lateral sphincterotomy, which is known as Notaras lateral sphincterotomy. Clear? What is the biggest problem in fissure? Since there is spasm of internal anal sphincter, and if you are going to perform a digital rectal examination, what happens? It's very painful. So digital rectal examination and proctoscopy, these are contraindicated in the fissure in ano. So fissure in ano, which of the following is not done? Sitz bath, yes, we advise for relaxation. Topical calcium channel blockers, yes, we advise 2% diltiazem gel local application. High fiber diet, yes. Proctoscopy is not recommended. Clear? So the correct answer for this question is what? C. So see the literature related to management of fissure in belly. Addition of fiber to diet. Why? Because it adds bulk to the stool, stool softeners, and adequate water intake. Okay. Sitz bath, warm baths, topical local anesthetic agents. Why? Because these are going to relieve the pain. And to relax the spasm, we give nitroglycerin or glyceryl trinitrate. How much? 0.2%. And 2% diltiazem gel. We also use what? Botox. But the treatment of choice is what? Notaras lateral sphincter artery. So this is an easy and frequently asked question. Deep inguinal ring or deep ring or internal inguinal ring is a defect in fascia transversalis. There is superficial inguinal ring, and this superficial inguinal ring is defect in external oblique aponeurosis, whereas deep ring is the defect in fascia transversalis. So correct answer for this question is D. Now see, this is a very common problem. Youngsters, especially the first year or second year students of college, who go to the gym and during first 5 weeks only they started lifting heavy weights, right, without proper training, and all these things are going to increase the risk of hernia. Why? Because whenever we are going to lift heavy weight, it is going to increase the intra-abdominal pressure, and because of that, what, the patients are very prone for hernia, especially if they are going to lift heavy weight. That's why if you are going to the gym, you have seen that people are using a belt. So this belt is going to protect or give protection against the disc prolapse, especially in the lumbosacral spine, and it is going to cover the myopectineal orifice, right? Now suppose a boy in a gym lifts the equipment and suddenly felt pain in the groin, right? So what happened to this boy? Obviously the patient developed hernia. He came to the hospital. On examination, swelling was felt near left testis. What should be the next step? Now see, whenever patient is going to develop hernia, what, the curative treatment is surgery. Surgery is the only curative treatment for the hernia. First principle. Second, emergency surgery is performed when there is complication. Clear? So we perform emergency surgery when there is complication. Okay. Third principle, the results of elective surgery. Results of elective surgery are better than emergency surgery. So I'm repeating. If a patient is having hernia, the curative treatment is what? Surgery. Emergency surgery is performed when patient is having complications, and results of elective surgery is better than emergency surgery. So this patient developed hernia, but there is no complication at present, right? So what, we have to go for the surgery, but what, we will go for elective surgery. So when the patient comes to the hospital, what we do, we advise analgesics. So we give NSAIDs and send the patient home, and we plan for elective surgery. Why not immediate exploration? Because there is no complication. FNAC and ultrasound, no role, because diagnosis of hernia, it's a clinical diagnosis, right? And coconut bandage to hold the swelling up. Generally, this coconut bandage is done after hernia surgery for the support. Okay, so this can be done, but the better answer is what? A. That is NSAIDs and send the patient home, and we prepare the patient for elective hernia surgery. So correct answer for this question is A. A patient with irreducible incisional hernia was brought to the emergency. Okay, what should be the next step? Now see, if it's only irreducible, first you should understand what is the definition. When the contents of hernia cannot be reduced, it is irreducible. When it cannot be reduced because of presence of fecal matter in the bowel, it is incarcerated. And if there is intestinal obstruction with preserved blood supply, it is obstructed. And if there is intestinal obstruction with impaired blood supply, it is known as strangulated. Clear? So this is just the irreducible hernia. So if patient comes to emergency with irreducible hernia, what surgeon is going to do? Initially we attempt what? Reduction. Okay, and in majority of cases we are able to reduce it. The good thing about incisional hernia, that the defect is very large. Incisional hernia means because of some surgery, what happened? In post-operative period, patient developed hernia because there was defect in the facial tissues. Okay. So the good thing about incisional hernia is that the defect is very large and the risk of strangulation is rare. Okay. So here it's irreducible. We will attempt what? Reduction. And after that, what we plan? The surgery. What kind of surgery is preferred? Obviously, elective surgery. Preferred over emergency surgery. Okay, same principle. So see, exploratory laparotomy. No, it's not done. Reduction followed by elective surgery. Yes. Reduction and observation. Observation. Why not observation? Because see, the curative treatment for this incisional hernia is only surgery. And if you are just going to observe the patient, what will happen? Over a period of time, the content of incisional hernia is going to increase. Okay? None of the above. So correct answer for this question is B, that we have to reduce it and followed by elective surgery. Generally for incisional hernia, what is the preferred treatment option? Laparoscopic surgery. Laparoscopic surgery is preferred over open. Why? Because if we are going for open surgery, there is extensive tissue dissection, and if you are going to perform extensive tissue dissection, there is further weakness of those tissues. So that's why we minimize dissection, and that's why we prefer laparoscopic surgery. In laparoscopic surgery, what is the treatment of choice for incisional hernia? It is IPOM, because it is having lowest rate of recurrence. The full form of IPOM is intraperitoneal onlay mesh repair. Full form, intraperitoneal onlay mesh repair. So for this we prefer IPOM. So correct answer for this question is B. Now another interesting question, but ITP was asked many times, and the question similar to this were also asked many times. 12 years old girl suffering from ITP, immune or idiopathic thrombocytopenic purpura, managed with steroids. Clear? But the thrombocytopenia recurred once steroids were stopped. So there was recurrence of thrombocytopenia. On physical examination, no petechiae or any physical evidence of bleeding. What should be the next line of management for this child? So now see, there is difference in the management of ITP in children and adults. What happens? In most of the children, means in 75% of children, the spontaneous resolution is seen in acute ITP. In acute ITP, spontaneous resolution is seen. So whenever patient is having ITP, generally we prescribe steroids. Clear? But if patient is having recurrence, or if it is chronic ITP, then only we go forward splenectomy. Splenectomy is done whenever there are 2 or more relapses, but be careful if the patient is having chronic ITP. In majority of cases, if the patient is having acute ITP, and whenever patient is having thrombocytopenia, we can prescribe steroids, but what? Spontaneous resolution occurs in majority of patients. Okay, so see the options. If you see first, continue steroids as long as they are effective for up to 3 months. No. Why? Because the patient will start developing steroid related complications, and especially in females, what happens? Yes, there is hypertrichosis, cosmetic problems. Splenectomy in cases of 2 or more relapses. This statement is correct, but the clinical scenario which is given here, in relation to this clinical scenario, this option is not appropriate. Statement is correct, but the option is not appropriate in relation to this context. Wait and watch, as self-resolution will occur in most of the cases of acute ITP in children. This is correct. Clear? Plasmapheresis not required at this stage. So correct answer for this question is C. See the literature. Course of disease differs in children and adults. In ITP, disease regresses spontaneously in 75% of pediatric cases following the initial attack. So whenever there is initial attack, short course of corticosteroids in both adult and children followed by recovery is generally followed by recovery. Be careful, prolonged steroid therapy should not be continued if it is not going to produce the remission. And splenectomy is recommended if the patient has 2 relapses on steroid therapy or if the patient platelet count is low. But be careful where ITP persisted for more than 6 to 9 months. So generally splenectomy is not recommended in acute ITP. It is recommended in chronic ITP. Okay? And see what's written in Harrison. Splenectomy has been used for the treatment of patients who relapse after glucocorticoids are tapered, in which case in chronic ITP. Clear? So what should be the correct answer? So the most appropriate answer for this question would be wait and watch, as self-resolution will occur in most cases of acute ITP in children. That is C. See this question, which of the following is false related to renal stones? Okay. Most common type of stone is triple phosphate. This is false. What is the most common type of stone? It is calcium oxalate. Clear? So calcium oxalate is the most common type of stone. So this is false. Stone can be removed via ureter. Yes, if the stone is there in the pelvis, by ureteroscopy you can retrieve the stone. So this is correct. Most of the renal stone can be removed by ESWL. Yes, in 85% cases, the renal stones can be removed by ESWL. We are going to break the stones and stone fragments will be excreted in the urine via ureter. Stone less than 5 mm can be managed conservatively. Yes, this is an indication for conservative management. So these 3 options are correct. This option is wrong or false. So correct answer for this question is A. See this question, image based question, and this question was asked many times in NEET, FMGE, AIMS. What is the diagnosis based on the given image of IVP? Okay, so what you can notice here, you can notice that what the patient is having adder head or cobra head appearance bilaterally. Okay, and second thing what you can notice, that this patient is having hydroureteronephrosis. So this patient is having bilateral ureterocele, and in bilateral ureterocele there is adder head or cobra head appearance. Clear? So what is the correct answer for this question? A. Patient is having ureterocele, and because of ureterocele what happens? There is obstruction, and because of this obstruction patient is having what? Hydroureteronephrosis. So correct answer for this question is A. This question was asked in NEET, but the language of question was different. The same image was given and the question was asked, what is the diagnosis? Okay, so in this case what you can notice that there are 2 ureters. Can you see? This is the upper pole ureter, clear, and this is what the lower pole ureter. So there are 2 separate ureters. So this is duplication of ureter. What kind of incomplete duplication or complete duplication? So this is complete duplication. And what happens? There is bladder. Okay, so this upper pole ureter, can you see this one? Yes, it is going to drain distally and medially in comparison to lower pole ureter. Now see, suppose this lower pole ureter is going to drain where? Into the dome of bladder, right? So this upper pole ureter will be caudal and medial. What is the name of this rule? This is known as Wiegert-Mayer's rule in relation to duplication of ureter, right? Now where exactly this upper pole ureter is going to drain? So here you can see this is the normal system, and here there is duplication of ureter. On right side you can notice that there is partial duplication, and this ureter is known as bifid ureter. Why? Because both ureters are going to join together and then they are going to drain into the bladder. Clear? Now see this one. On left side, this is the upper pole ureter, and you can notice that this upper pole ureter is going to drain, yes, caudal and medial in comparison to lower pole ureter. And generally this upper pole ureter, what, there is ureterocele also. There is ureterocele. Clear? Now see, this upper pole ureter is having ectopic ureteric orifice. So the ureter orifice is abnormal. So this is ectopic ureteric orifice. In males, it is going to open into posterior urethra, and the most common site is prostatic urethra. And in females, it is going to open into anterior urethra. Okay, so generally this upper pole ureter is going to open into urethra. Clear? So what is the correct answer for this question? It is D, urethra. And suppose the question is asked that what is the opening of this lower pole ureter, and if the question is asked related to opening of this lower pole ureter, then the correct answer would be what? Dome of bladder. Clear? Sometimes trigone also. Okay, but the question was asked related to upper pole, that's why the correct answer is what? D. See this question. After alcohol consumption, patient went to bathroom. It means what? The patient bladder is full. So after taking alcohol, the patient bladder is full and patient went to bathroom, slipped in the bathroom. Clear? So there is history of fall and patient is having full bladder. So see, patient is having full bladder. 1. There is history of fall in bathroom. Clear? After that, patient developed pain in suprapubic region. So what is the problem generally? See this anatomy, it's easy to understand. Generally, the bladder is extraperitoneal, located in pelvis, but when bladder becomes full or distended, it becomes intra-abdominal. Whenever there is external blow or kick to the full bladder, or there is fall with full bladder, what happens? There is rupture of the bladder. And bladder rupture, what kind of bladder rupture? Intraperitoneal bladder rupture. So whatever the urine is there in the bladder, it goes into peritoneal cavity. What are the signs and symptoms? See the clinical features. The patient will be having suprapubic pain, difficulty in passing urine because there is no pressure generated in the bladder, and whatever the urine is coming out, it is mixed with blood, so there is hematuria. Simultaneously, since urine is in the peritoneal cavity, the patient will be having peritonitis. But in patients, it is seen that if the urine is sterile, immediately patient is not going to develop what? Peritonitis. Clear? Now see the question again. On examination, abdominal distension was present without suprapubic bulge. Heart rate and blood pressure was normal. It means patient was not having peritonitis, otherwise patient would be having tachycardia. What is the most probable diagnosis? Now, this kind of history suggests the bladder rupture. If we are talking about extraperitoneal bladder rupture, the bladder is collapsed and it is located in the pelvis. Pelvic fracture leads to extraperitoneal bladder rupture. But in cases of extraperitoneal bladder rupture, abdominal distension is not seen. Clear? So it's not acute urinary retention. Membranous urethral injury. In membranous urethral injury, there is blood at the meatus. Abdominal distension is not there. So extraperitoneal, in this case also abdominal distension is not there. So correct answer for this question is what? A. So let's see what's written in Bailey. Bladder rupture can be intraperitoneal or extraperitoneal. Most commonly it is extraperitoneal in 80% cases. For extraperitoneal bladder rupture, what is the most common cause? Pelvic fracture. And what is the most common cause of pelvic fracture? It's the road traffic accident. Now see, intraperitoneal rupture is usually secondary to blow or fall on a distended bladder. Clear? And if you see, intraperitoneal rupture is associated with sudden severe pain in hypogastrium or suprapubic region and accompanied by syncope. Shock subsides and abdomen distends. So what? In the question, abdominal distension was mentioned. There is no desire to micturate. Okay, and if patient is trying to pass urine, some amount of blood is coming with urine, hematuria. Peritonitis does not follow immediately if the urine is sterile. Varying degrees of rigidity are present on examination. Got it? So if you see the question again, see the findings: abdominal distension, full bladder means after alcohol consumption, fall in bathroom, pain in suprapubic region. Clear? So all these are suggestive of what? Intraperitoneal bladder rupture. Again, this question was asked 3 to 4 times in AIMS and there was direct question. What was the question? That which of the following is recently FDA approved agent for metastatic carcinoma prostate? In this question, this kind of language is framed. Now see the language. 60 years old patient presented to OPD with low backache. Okay. His PSA levels are 100 nanogram per ml. See, generally PSA is 4 nanogram, less than 4 nanogram per ml. And whenever the value is more than 20 nanogram per ml, it is diagnostic of carcinoma prostate. Clear? Here, so there is low backache, high PSA, age is 60. It means this patient is having carcinoma prostate and backache is because of metastasis to the lumbar vertebra. So this is a case of metastatic carcinoma prostate. Clear? And generally in metastatic carcinoma prostate we give hormone therapy because hormone therapy is having lesser side effects. Here we go for androgen deprivation or ablation. In this case we can go for LH-RH agonist also and we can go for bilateral orchidectomy also. Clear? So what are the LH-RH agonists which are used? We use goserelin and leuprolide. Okay, now see. So which of the following drug is indicated for the treatment? Somatostatin no, terlipressin, testosterone no. Testosterone itself is having stimulatory effect on the malignant cells in CA prostate. So the correct answer is what? B, that is goserelin. Goserelin and leuprolide, both of these are LH-RH agonist and these are used in metastatic carcinoma prostate. See the literature. Metastatic prostate cancer is treated by androgen ablation or androgen deprivation. Okay, orchiectomy causes response in 80% of patients, but some patients are not giving consent for orchidectomy. And if patient is not giving consent, in those cases what? We have to go for testicular androgen suppression, and this is with the help of LH-RH agonist, and the drugs which are used are leuprolide and goserelin. Clear? So correct answer for this question is B, that is goserelin. Now see this question. Male infant who was brought with urinary retention. So male infant, urinary retention, have bilateral hydronephrosis. There was history of recurrent urinary tract infections. What is the probable diagnosis? Now see, what is the problem here? See, this is bladder, this is urethra, this is kidney, this is ureter. Okay. The problem is that this patient is having urinary retention and there is bilateral hydroureteronephrosis or bilateral hydronephrosis. Okay, it means the site of obstruction will be distal to the bladder, right? Now the patient is having posterior urethral valve. So this valve is present in the posterior urethra and the location is just distal or at verumontanum, and strictly this posterior urethral valve is seen in male urethra, so it's exclusively seen in males. Okay, so urethral abnormality is seen in males, right? So because of this valve, this is unidirectional, what happens, there is back pressure changes, and because of these back pressure changes there is distended bladder and bilateral hydroureteronephrosis. Now see, if there is delay in the diagnosis, a patient is brought late, what these patients are having? UTI, urinary tract infection. Clear? So what is the probable diagnosis? It is posterior urethral valve. You can rule out other options. How? See, in PUJ obstruction there is no urinary retention. Clear? Second, generally PUJ obstruction is unilateral, so bilateral hydronephrosis is a rare finding. In horseshoe kidney, urinary retention is not seen. And in retrocavaliurator is unilateral, it is more common on right side. So it is seen on right side. That's why here also bilateral hydronephrosis is not seen and urinary retention is not seen in retrocavaliurator. So correct answer for this question is B. See the statement written in the belly related to posterior urethral valve. So see, the diagnosis is most commonly made antenatally with ultrasound. And what is the finding? The mother is going to have what? Oligohydramnios, which demonstrate bilateral hydronephrosis above a distended bladder. So in fetus, there is distended bladder and bilateral hydroureteronephrosis. If diagnosis is not made antenatally, then babies typically present with urinary infection in the neonatal period or with uremia and renal failure. Clear? So, for this question, the correct answer is B, that is posterior urethral valve. So, male infant, urinary retention, bilateral hydronephrosis, and recurrent urinary tract infection is seen in posterior urethral valves. See this question, newborn male baby. In newborn male baby, mother found empty scrotum. So scrotum is empty, it means there is abnormally located testes. On examination, the left testis is in inguinal region. So the left testis is in inguinal region and the right testis is in perineum. Clear? So it is very easy to understand. See, if there is abnormal location of testis, if the testis is located abnormally, if it is within normal path of descent, you must be knowing the descent of testis, or it is away from normal path. Okay, so if abnormally located testis is in the normal path of descent, then it is known as undescended testis, and if it is away from normal path of descent, then it is known as ectopic testis. Clear? So if you see, on the left side the testis is in inguinal region and usually testis comes in inguinal region, so it's the normal path of descent. So obviously on the left side it is undescended testis. Generally perineum is not the path of descent. Okay, so it's not the normal path of descent, so this is away from normal path and this is ectopic, right? So left testis is undescended and right testis is ectopic. So here you can see left testis is undescended, right testis is ectopic. So correct answer for this question is B. So read the statement. Testis cannot be palpated in inguinal canal but can be milked from there into superficial pouch, that is palpable undescended testis, or into the scrotum with good length of cord, that's normal. And if you see here, what is ectopic testis? Ectopic testis lies outside its normal line of descent and often in perineum. Clear? So for this question, obviously the left testis is undescended and right testis is ectopic, so correct answer is B. Now see this question, on post-operative day 2 of mastectomy, for the left breast cancer there was mastectomy. On post-operative day 2, routine X-ray of patient was performed. Patient is not complaining of any respiratory distress, so there is no respiratory distress. Patient is comfortable in hospital bed. Bilateral equal air entry is heard, right? So no respiratory distress, bilateral equal air entry. What is the next step of management? So usually in these cases nothing active should be done. Wait and watch and give supplemental oxygen if required. Why? Here you can see this patient is having what? Pneumothorax. So on chest x-ray you can see that this patient is having pneumothorax involving less than 25%. Okay, so here we have to go for only wait and watch strategy and supplemental oxygen if required. Needle thoracotomy urgently, no, because patient is not symptomatic, there is no respiratory distress. No thoracostomy, no intubation. So these should not be done. We have to go for wait and watch strategy. So if you see the management of pneumothorax, generally this patient developed pneumothorax after surgery, so this is secondary because of some condition. Okay, and if it's more than 2 centimeter or patient is breathless, then we can go for insertion of chest tube. If it is 1 to 2 centimeter, we can go for aspiration, and if it is less than that, then high flow oxygen is given. But if you read this statement, in some patients with large pneumothorax but minimal symptoms, in some patients with large pneumothorax but with minimal symptoms, conservative management may be appropriate. So, the scenario which is given here, patient is asymptomatic, right? Bilateral equal air entry is there. So, wait and watch strategy is preferred. So, here, correct answer for this question is A. See this question, 60 years old woman, known case of lung cancer, having shortness of breath. Okay. On examination, neck veins are engorged or distended, showing gross elevation of JVP. Heart sounds are muffled or distant. Breath sounds appear reduced on left side infrascapular region. Chest X-ray, you can see here that there is enlarged globular shaped heart. So this is enlarged globular shaped heart. Clear? So all these findings are suggestive of what? Pericardial tamponade. Clear? And you must be knowing that there is a triad. Bake's triad. What are the components of Bake's triad? The mnemonic is MDH. MDH means asli masale such. So M means muffled heart sound. So here there is muffled heart sound. Distended neck veins. Distended neck veins. And there is hypotension. Clear? And on X-ray, there is enlarged globular shaped heart. All these are the findings suggestive of pericardial tamponade. Now see what is the predisposing factors. These patients are having pericarditis, or these patients are having fluid collection because of malignancy or because of trauma. Clear? So the correct answer for this question is A. So see the cardiac tamponade. The most common causes of tamponade are idiopathic pericarditis. Clear? And pericarditis secondary to neoplastic disease. In this question, patient was having CA lung, bleeding, tuberculosis, or leakage from aortic dissection, cardiac operation, trauma, or treatment with anticoagulants. And it is characterized by Bake's triad. Clear? Muffled heart sound, distended neck veins, and hypotension. So all these are the findings which are suggestive of pericardial tamponade. So for this question, correct answer is A. So it's an easy question and a repeat question. You can easily solve this question by principle of exclusion. Identify the condition shown in image. First, basal cell carcinoma. It's not basal cell carcinoma. Why? Because the basal cell carcinoma appearance, what? There is central depression and pearly white nodules in the periphery. And what happens? There is central depression, and sometimes what happens? There is necrosis. That's why it is known as rodent ulcer, because there is local destruction of tissues. Okay. Squamous cell carcinoma, the most common presentation of squamous cell carcinoma is what? Yes, ulceration. So here you can see what? You can just see the hyperpigmented lesions, but you can't see any ulceration. Nevus, in nevus, what happens? The color pattern is regular, right? So what is the, here you can see the appearance. It is characterized by A, B, C, D, E. So there is asymmetry, border, irregularity, color variation, and E means evolution. So you can see somewhere there is brown color, somewhere there is dark black color. So this is a case of malignant melanoma. Now one question, which type of malignant melanoma? So in sun exposed regions, especially in the head and neck and in elderly, which type is seen? It is the lentigo-malina. Is the lentigo-malina melanoma. Clear? So correct answer for this question is C, that is lentigo-malina melanoma. If you remember, this question was asked in AIMS as well as NEET. A, B, C, D, E is associated with malignant melanoma. So what is this A, B, C, D, E? So in malignant melanoma, there is A, B, C, D, E. So there is asymmetry, border irregularity, color variation, change in diameter, how much? More than 6 mm, and E means evolution or change in size, shape, color, or another trait. See this question, cutaneous horn, can you see here? As shown in the image is associated with which of the following skin cancer? See, actinic keratosis and cutaneous horn, both of these are associated with squamous cell carcinoma. Clear? So this cutaneous horn is associated with squamous cell carcinoma. What is actinic keratosis and what is cutaneous horn? Have a look. So when actinic keratosis has keratinous surface with a height greater than its base diameter, height greater than its base diameter, it is known as keratin horn or cutaneous horn, and generally 10% patients have squamous cell carcinoma. So for squamous cell carcinoma, actinic keratosis is a risk factor as well as cutaneous or keratin horn. So correct answer for this question is B, that is squamous cell carcinoma. Now see this question, most common delayed symptom of head and neck radiation, and the most common delayed symptom of head and neck radiation is what? Xerostomia. What are the other important complication of head and neck radiation or radiotherapy to head and neck? So the most common is xerostomia. Other complications are mucositis. There is temporary or permanent dysgeusia. Dysgeusia means altered taste, and this is important and frequently asked in exam. What? Osteoradionecrosis. Generally, this osteoradionecrosis is seen in the patients who already have what? Caries tooth, and that comes in the radiation field. And what is the cause? There is decreased production of saliva and damage to microvasculature of mandible and maxilla. Right? So how we are going to manage this osteoradionecrosis? With prophylactic dental care. And suppose a patient is going to develop osteoradionecrosis, in that case we have to give what? Hyperbaric oxygen treatment for 4 to 6 weeks, either alone or with surgical intervention. So these are important questions related to complications of radiotherapy in head and neck region. So the correct answer for this question is A. See this question, which of the following statement is correct about ranula? Okay, so in relation to sublingual gland, there is mucus extravasation or retention cyst, that is ranula, but more commonly it is extravasation cyst, and it is brilliantly translucent swelling. How you can diagnose it? Yes, clinically. So diagnosis is clinical, right? And what is the treatment? Treatment is, if it is causing some problem with chewing and swallowing, then we have to go for marsupialization, and after marsupialization, even if there is recurrence, then we go for excision. So first option, it's mainly a retention cyst. No, it's extravasation cyst. See, certain books say that it is mainly a retention cyst, which is wrong. In Bailey, it is clearly mentioned that mainly it is extravasation cyst. It is brilliantly translucent, this is correct, related to sublingual gland, not submandibular gland, and it is diagnosed clinically. It is diagnosed clinically. So correct answer for this question is B. Now see what's written about ranula in the Bailey. So the term ranula is applied to mucus extravasation cyst that arises from sublingual gland. And what kind of swelling? Characteristic translucent swelling. And what kind of appearance? Having appearance of frog's belly. Clear? So correct answer for this question is B. So this is very good question. Prophylactic CNS radiation is given for which of the following cancer? So what is the logic? Why we have to give prophylactic CNS radiation? Because the malignancies in which there is high risk of metastasis to brain, in those we give prophylactic CNS radiation. Okay. So question, suppose a patient is having brain tumor in the form of metastasis. So patient is having metastatic brain tumor. What is the most common primary? It is CA lung, carcinoma lung, followed by CA breast. Okay. So the most common primary for brain metastasis is CA lung followed by CA breast. Question: what is the most common site of metastasis in carcinoma lung? So in carcinoma lung, the most common site of metastasis is brain. In carcinoma lung, which type is very prone to metastasize to brain is the small cell lung cancer. So typically it's the small cell lung cancer in which we go for prophylactic CNS radiation. Why? Because brain is the most common site of metastasis and this malignancy is the most common primary for brain metastasis. Clear? So the correct answer for this question is A. And now read the statement written in Harrison. Prophylactic cranial irradiation. So prophylactic cranial irradiation should be considered in all patients with either limited disease, SCLC, small cell lung cancer, or extensive disease, SCLC, who have responded well to initial therapy. Clear? So correct answer for this question is A, that is carcinoma lung. So you observe the pattern of questions. In majority of questions there were 2-3 clues which are pointers for the diagnosis. Okay, so we have to look for those pointers, right? See here the pointer: elderly, fell in bathroom in early morning hours, typical history, rush to the casualty, GCS is 9/15, urgent NCCT was performed. Okay, now on CT, what you can see here concavo-convex appearance. Okay, and this is seen in what? This is seen in STH, subdural hematoma. What is the appearance in EDH? Here is the lenticular or biconvex. So lenticular or biconvex, and this is seen in EDH. Generally EDH is seen after trivial trauma, but STH is more common in elderly and it is associated with poor prognosis. Clear? So here elderly patient, low GCS 9/15, and on CT concavo-convex appearance. All these points towards subdural hemorrhage. Now see this question. Patient presented with development of seizures. Okay. CT guided biopsy was done. So if the patient is having seizures and we are going to perform the biopsy, you have to think that most probably patient is having brain tumor, right? Generally the diagnosis of brain tumor is made by MRI. Sometimes biopsy is done, sometimes. One of the example where biopsy is done is primary CNS lymphoma. By the way, here biopsy was done. Histopathology report shows the presence of samoma bodies. Which of the following is, can you see? Clear? So this is samoma bodies. So what is the diagnosis? In brain tumors, in which particular tumor samoma bodies are seen? It's the meningioma. Samoma bodies are very important, frequently asked in exam. What are the tumors where samoma bodies are seen? The mnemonic is PSM. Clear? P means papillary carcinoma thyroid and P means papillary variant of RCC. S means serous cystadenoma ovary. Serous cystadenoma ovary, and M means meningioma. Meningioma. Clear? So here the patient is having brain tumor with samoma bodies and the correct answer for this question is A, that's meningioma. Now see this question. In train accident, 74 were dead, 64 severely injured, 20 moderately injured, 32 mildly injured. What is the color coding in triage? Highest to lowest category. Okay, so triage is important topic. Red indicates most critically injured patient. So this is first priority. That's red, most critically injured. After red, second is yellow. Yellow is less critically injured. Third priority is what? Green. Green means there is no life or limb threatening injuries. Okay, so no life or limb threatening injuries. And what about black? Black means if the patient is dead or moribund. So if the patient is dead or moribund, clear? So what's the order? It's red, yellow, green, black. So correct answer is D. Now see this question. 30 years old car driver was involved in an accident, brought to emergency room with complaints of breathlessness, right? On physical examinations, pulse rate 110 per minute, BP 90/60. It means this patient is unstable. Okay, at the time of presentation, vitals are unstable. Unstable vitals means whenever the pulse rate is more than 100 per minute and the systolic blood pressure is less than 100 mmHg. Clear? So pulse rate more than 100 per minute, systolic blood pressure less than 100 mmHg. Temperature 37 degrees centigrade. Extensive bruising is noticed on the right side of chest. So there is extensive bruising. Clear? An urgent bedside chest x-ray was performed. What is the best management for this patient or this case? Now see the x-ray. On x-ray you can see that there is contusion, though it's not very clear. Evidence of contusion, simultaneously multiple rib fracture at multiple places. Clear? So what is the definition of flail chest? When two or more than two ribs are fractured, two or more than two consecutive ribs are fractured at two or more than two places. So that is flail chest. Usually in flail chest, how we are going to manage? Oxygen supplementation, physiotherapy and analgesia. But if we suspect that patient is having respiratory failure, in that case the treatment of choice is intermittent positive pressure ventilation. Clear? So here, what is the preferred treatment? Thoracotomy? No, we will not take this patient for thoracotomy. Patient is unstable. Thoracostomy, it can be one option, but patient is having flail chest, fluid restriction. So we have to choose between thoracostomy and elective intubation and intermittent positive pressure ventilation. So the preferred treatment or treatment of choice in patients of flail chest having respiratory failure is what? Intermittent positive pressure ventilation. So correct answer for this question is C. A 40 years old man is brought to emergency with loss of consciousness following road traffic accident. GCS is low, that's 8/15, and patient is having, be careful, this is a pointer, decerebrate rigidity. Now see, if a head injury patient is brought to emergency and the patient is having coma or decerebrate rigidity, generally we have to suspect what? Diffuse axonal injuries. What's the problem? Generally this diffuse axonal injuries are missed on NCCT, and the investigation of choice for diagnosis is MRI. So if in the question MRI is given at the place of CT, you have to think. If in the question patient is having coma or decerebrate rigidity, you have to think about this, right? Now MRI was performed and image is given below. Can you see? Evidence of microhemorrhages. Which of the following is the diagnosis? It's not subarachnoid hemorrhage. It's not subdural hemorrhage. We discussed subdural hemorrhage. So what is the correct answer? It's the diffuse axonal injuries. D. So you can see traumatic axonal injuries is one of the most common injuries after traumatic brain injuries. Okay. What happens actually in traumatic axonal injuries? There is disruption, shearing of axons at the time of impact. Clear? And because of this, what happens? There are microhemorrhages, and these microhemorrhages are sometimes not detected by NCCT. That's why what we need MRI. So what is the difference between traumatic axonal injury and diffuse axonal injury? So whenever this axonal injury is diffuse, means there are more than equal to 4 areas of traumatic axonal injuries. Clear? And when it's widespread, it is proposed to explain, can you see? Coma or vegetative state after traumatic brain injury. Clear? So when CT is negative, we have to go for MRI, and on MRI you will notice that there is hemosiderin deposits reflective of microhemorrhages in addition to axonal damage on diffusion sequences. Clear? So the questions which are asked, the clinical scenario which we discussed, that patient will be in the state of coma or vegetative state, or patient will be having rigidity, CT findings are not suggestive. On MRI, you will notice multiple microhemorrhages. Clear? So, here this patient is having diffuse axonal injury and correct answer is D. This question was asked in AIMS as well as in NEET. Clear? Mandatory exploration is required in the injuries of which zones of retroperitoneum? Now, can you see this? Zone 1. This is which zone of retroperitoneum? Can you see it is present centrally? So, this is central. Now, can you see this zone 2? It is present laterally. So, this is lateral. Okay. And this is what? Can you see this area is pelvis? So, this is pelvic. And sometimes there is a zone 4. This zone 4 was asked in AIMS. This is zone 4. This is portal or retrohepatic region. Okay. Out of these 4 zones, can you see in central region you can see what? IVC and aorta and its proximal branches. So, in this central region. So, whenever there is hematoma, yes, exploration is mandatory in zone 1. Right? But if, so now see, when the hematoma is in zone 2, it can be managed by angioembolization because it is related to kidney. If hematoma is there in zone 3, yes, it's very difficult to control bleeding if we are going to open the hematoma. So if the question is asked out of zone 1, 2, 3, exploration is mandatory in which particular zone? It's the zone 1 and that's central. So see the zones and the structures located. Zone 1 is central and the extent is from esophageal hiatus to the sacral promontory, right? There is supramesocolic zone 1 and inframesocolic. In supramesocolic zone 1, there is suprarenal aorta, IVC, celiac axis, proximal superior mesenteric artery and vein, and proximal renal arteries and vein. And in inframesocolic zone, there is infrarenal aorta and IVC. Now see, this is important. Central hematoma should always be explored with proximal and distal vascular control. If you see this zone 2 which is lateral, extent is from lateral diaphragm to iliac crest, and here distal renal arteries and veins are included. Now see, these lateral hematomas are usually renal in origin and we can manage these hematomas by angioembolization. So generally it is managed conservatively, means exploration is not mandatory. And if you see this zone 3 which is pelvic, it is confined to retroperitoneal space of pelvic bowl. And see the picture. In this zone 3 you notice what? Iliac artery and iliac vein is included. So here iliac artery and iliac vein is included, and it's very difficult to control the pelvic hematoma if you are going to open this. So generally it is controlled with packing and angioembolization. So exploration is mandatory in which hematoma? Zone 1 hematoma. So correct answer for this question is A. See this question, 4 hours before visiting casualty patient hit his leg. Okay. On examination, there was pain on passive stretching. So what? Pain on passive stretching. This is highly suggestive of what? Compartment syndrome. Okay. Pain on passive stretching. Distal pulses were palpable. Be careful. Palpable pulses don't rule out compartment syndrome. So if there is presence of palpable pulse, it doesn't rule out compartment syndrome. So what is the most probable diagnosis here? What are the pointers? There is trauma and there is pain on passive stretching. Pain on passive stretching. Clear? So the correct answer is what? Compartment syndrome. Okay. There is no risk factor for DVT, Burgess disease patient, nothing is mentioned whether the patient is smoker or not, and there is short history of 4 hours only. Necrotizing fasciitis doesn't occur within this short history of 4 hours, and obviously if there is necrotizing fasciitis, there should be evidence of necrosis. So correct answer for this question is A. So what is the classical clinical picture of compartment syndrome? Yes, severe pain out of proportion with clinical findings that worsens with time despite appropriate analgesia. And on examination, tense compartment with passive flexion and extension of muscle causing pain. And be careful, this important statement is there. presence of palpable pulses does not rule out compartment syndrome. Clear? So correct answer for this question is A, compartment syndrome. Here also it's a image based question and it was asked many times. You can easily crack the question. Ulcer with overhanging or undermined edges. Okay, this is highly suggestive of tuberculosis. In the neck region as shown in the image is seen in. Now see, generally in tubercular lymphadenitis, what? The deep cervical lymph nodes, generally deep upper cervical lymph nodes are involved. And whenever there is formation of cold abscess, generally it ruptures and what happens? There is formation of sinus or ulcer. And generally the sinuses are having undermined edges or ulcer is having undermined edges. So correct answer for this question is A, that is tubercular lymph node. Clear? So this question was asked in AIMS, this was asked in NEET, and this time it was asked in FMG. Nurse spilled blood on the floor. What can be used to disinfect it? So for blood spillage, we use 1% sodium hypochlorite solution. Clear? So correct answer is D. So whenever there is blood or body fluid spillage, so in cases of blood or body fluid spillage on the floor, we use what? Sodium hypochlorite. Okay. Now why we use sodium hypochlorite? See the profile. So if you see the comparison between formaldehyde, glutaraldehyde, sodium hypochlorite and phenol, right? See, all these are effective against bacteria, right? But for viruses, sodium hypochlorite is effective along with formaldehyde and glutaraldehyde. But see here, for organic matter, susceptible to organic matter, it's only sodium hypochlorite. Clear? So whenever there is spillage of blood or any kind of body fluid, we have to use sodium hypochlorite as a disinfectant. Nowadays lots of questions are asked related to disinfection and sterilization. So see the list. So you can see steam 121 degrees centigrade for 15 minutes is used for surgical instruments. Ethylene oxide is used for heart-lung machine, respirators, dental labs. Hot air oven for glass syringe, test tubes, flask, cutting instruments. Gamma rays irradiation, this is for industrial packaging. Para-acetic acid for flexible endoscope, this was asked in NEET. Isopropyl alcohol for clinical thermometer, this was also asked. And beta propiolactone followed by formaldehyde, this is for fumigation of OT labs wards. This was asked many times. 2% glutaraldehyde. Okay, and this is for endoscopes like cystoscope, bronchoscope. Autoclaving is used for culture media, suture materials except catgut, because for catgut what we are using, catgut is natural suture, natural absorbable suture, we use isopropyl alcohol. And see sodium hypochlorite, this is for blood and body fluid spillage in operation theatre. Clear? Now again this is a repeat question, this was asked in NEET previously. Which of the following organism is responsible for causing erysipelas? Okay, so how you, it's already mentioned, so you can easily make out the diagnosis. Erysipelas appearance, sharply demarcated erythematous and edematous, generally involving face, especially which part? Cheek, and it is caused by streptococcus. So most commonly caused by streptococcus. So correct answer for this question is A, streptococcus. Okay, so this is all about surgery related questions of FMG. Let me tell you, the question was lengthy but it was not very difficult, and if you have practiced the paper, yes, you can easily crack the questions, but the paper was lengthy. So there are students who were not able to clear this exam. Let me tell you, don't lose your hope. Yes, now the standard of FMG is a bit high. It is very similar to NEET pattern of questions, so you should raise your level also. So try practicing questions for each subject. There should be a single source of study. So read less, revise more. So padho utna, chahiye jitna. This is the strategy we follow in PrepLadder.
Hi guys, this is Dr. Marwa. Hope you're doing great. I was getting a lot of queries from my foreign medical graduate students regarding answers of internal medicine MCQs in the recently conducted exam. So, well, here I am right before you, and I'll be discussing answers to these questions in a very quick and a precise format. Some of the images which are present here may not be an exact replica of what came in the exam. Doesn't matter. I think the concept behind each of those four choices is what that actually matters. So let's get started. As I always say, knowledge is power. So let's knock some sense into this discussion. Starting with the very first question, he has talked about a 30-year-old chap with valvular heart disease and is having fever for last 2 weeks. Now, please appreciate the fact that if you ever read the statement valvular heart disease fever, you are always going to think in terms of infective endocarditis. And then he has given some examination findings in this patient, which you can notice are very characteristic rod spots. And then you can also notice Janeway lesions on the palms. Now, what is happening is that in the previous FMG exam, they used to keep questions simple. They used to simply ask you about Duke's criteria, but here he's actually given you two images of the findings of infective endocarditis, and then he has gone a step further. What is asked you here is what will be the abdominal examination finding of this particular patient. So you very well know the fact, and I'll just show a snapshot from the medicine app. You can see that in the FMG section in infective endocarditis component, I've highlighted the fact that there would be vegetations or millions and trillions of bacteria growing on the surface of the valve. So all of these bacteria or a large number of these bacteria will be embolizing out of the heart towards the spleen, and you would be having a splenic abscess. And there you have it. If you have a splenic abscess, what will it cause? An enlarged spleen in the patient, and that will contribute to development of splenomegaly. So please remember the answer to this question, which is the infective endocarditis patient, would be a simple abdominal examination finding. And why this is happening is because millions and trillions of bacteria are being pumped by the heart into the systemic circulation. So you would have a splenic abscess, and there you have it. A splenic abscess would contribute to a splenomegaly in the patient. The answer to this question is option number C. Moving ahead, moving to the next question, which was regarding a flatline ECG. A 70-year-old man collapsed in his house, was rushed to the hospital. We are having a ECG in which you can see a agonal rhythm. There can be few QRS complexes, but then it's actually a flat line. And once you have a flat line, we are basically talking about asystole in a patient. And the question was rather, what will be the best intervention for this child? Now, this can happen to anybody, or this can happen in front of you at an international airport. You're standing at the queue and an elderly gentleman in the flight collapses. What would you do? You would obviously give CPR, but here we basically asked what is the basic management of this jab. So you need to restart the heart, you need to kickstart the heart. And what do you give to kickstart the heart? You give adrenaline. So pretty straightforward. The answer to this question is injection of adrenaline 1 milligram IV. Please remember, defibrillation is contraindicated. DC shock is contraindicated. No, we don't give a DC shock in flatline ECG. Though in television serials they show like this only, no, that they're giving DC shock in a flatline ECG. But this life, I mean, actual life is not a television serial. So even in Grey's Anatomy, they will tell you that DC shock is being given to a person with flatline ECG because that's a television serial. In actual reality, we don't give DC shock in a flatline ECG. You need to kickstart the heart, get the heart back to circulating or doing its job again. So you need to stimulate the SA node, and what's going to stimulate the SA node is adrenaline. So you give a 1 milligram shot, that would be diluted, and along with that, the CPR activity would anyway continue. So answer to this question is adrenaline for flatline ECG. And this is a snapshot from the app where I have shown or I have discussed regarding shockable and non-shockable rhythms. Emergency medicine, yeah, at least 2 lectures for FMG section I would like you to study. That is basic life support and advanced cardiac life support. And they teach you, back at your medical college abroad, they teach you about basic life support and advanced cardiac life support. It's only that, the instruction may not be that good. So I would just like you to spend some time and listen to BLS and ACLS protocol, and you bang on spot for solving these straightforward questions. And you can see a snapshot from the app where I have discussed regarding a flatline ECG. I've talked about adrenaline being given in a flatline ECG in a person that is asystole, and then the function of adrenaline is to convert the flatline ECG into ventricular fibrillation. So answer to our question of flatline ECG is adrenaline. We move to the third one. This is a woman who is 60 years of age, and she's presented with weakness in the right arm for 4 hours duration. The weakness has then gradually become lesser, and she's a known case of hypertension. So there is a risk factor, no? There's a risk factor. Hypertension can contribute to CNS events. Hypertension can contribute to cardiac events because hypertension is a silent killer. You can also see that the body mass index of this lady is elevated. So there are two atherosclerotic risk factors in a lady who had a development of sudden onset weakness and then resolved on its own. So this is definitely not stroke. You see, in stroke, the symptoms are not gonna ever resolve. So you can rule that out. Transverse myelitis, how can you rule it out? It's going to present with paralysis of the legs. That's going to be paraplegia. So it's definitely ruled out. So you left with two. Either it's a compressive neuropathy. You know, sometimes you might sleep over your arm. And when you sleep over your arm, you might feel numbness in your arm. But the point is, when it comes to compressive neuropathy, the moment the compressive neuropathy is relieved, you usually tend to get improvement. Or at the same time, I can put it like this: somebody has a disc prolapse, and then there could be numbness in the arm. So obviously, if a person is having pain or weakness in the arm, I need to think of a local cause that could be disc prolapse. But the way the question is given, the straightforward answer to this question is TIA, a transient ischemic attack. In fact, here you can see image of Dhirubhai Ambani with the richest man in India, with Bill Clinton and his two sons, no, Mukesh and Anil Ambani. Dhirubhai Ambani, he died of stroke. No, he had one in 1986. He survived it due to good medical care. And then in 2002, he was maybe neglecting his health. He unfortunately died because of stroke. So as they say, money cannot buy health. But then transient ischemic attack is a precursor to development of stroke. So the clinical history that came in the exam was basically in favor of a TIA. Moving to the next question. This talked about a 35-year-old chap. He is recently divorced. There's a stress factor. Is suffering from palpitations, headache, and diaphoretic episodes on recurrent basis. He has visited a psychiatrist multiple times. Now, the bottom line is you can pick up here three things, right? That's the mnemonic that I've discussed in the app. That is PHD, palpitations, headache, diaphoretic episodes. They point towards possibility of a pheochromocytoma. You see, guys, a lot of time, and I've discussed this in the app section, you can see that lots of time pheochromocytoma can mimic anxiety neurosis. So a lot of these patients of pheochromocytoma may actually be on anti-anxiety medications and they will not be having any improvement. And that is what precisely the question was. This was a chap who's definitely having a stress. That's he got divorced recently, but then his symptoms are going beyond the standard anxiety component because he has visited a psychiatrist, he has taken treatment, but there is no improvement. So in these circumstances, what would you do for this chap? You would straight away go in for checking out the catecholamine levels to rule out a pheochromocytoma in the patient. You see, the detailed examination, the detailed discussion of these MCQs would be in the main section in the app. Here I'm just trying to give you the answers so that at least you can calculate your final scores. So answer to this question would be based on pheochromocytoma, which is a great masquerader. I mean, this disease can mimic anxiety neurosis. It's lots of time even qualified doctors may make a mistake and may misdiagnose pheochromocytoma as anxiety, and then suddenly boom, this guy has a brain hemorrhage because of the hypertensive crisis. So it's a nasty disease and should be picked up by checking for catecholamines in the urine or metanephrine in the urine. Moving to the next question, this was, I think, a straightforward one. You can see one doctor keeping a hand in the middle and another doctor trying to check for the free fluid in the abdomen. You see, this patient is basically having ascites, and what are we talking about here? So you can easily rule out two options, that is Puddle sign and Hingorani sign, because Puddle sign is for minimal ascites and Hingorani sign is in OBGY for a person having ovarian tumor. So you left between a fluid thrill and shifting dullness. For shifting dullness, you obviously need to shift the patient. No? I mean, you need to turn the patient to one side. So here there is no turning of the patient. So what are you checking for? You're checking for what I've highlighted in the app section. You can see here I'm discussing massive ascites. In massive ascites, there will always be a fluid thrill. The abdominal veins of the superficial veins on the abdomen will be very much visible. So the bottom line is that in massive ascites, you can see the gross abdominal distension in this person would be having a fluid thrill present, and this heralds a bad prognosis because this can contribute to abdominal compartment syndrome. This image-based question, the answer is fluid thrill. Moving to the next one. I have kept snapshots from the app so that you can basically go back to those lectures and listen to those parts. I think that would make you feel more comfortable with why I'm saying that this is an answer to a particular question. Moving to the next one, this is an elderly gentleman with hypertension. So there was another one talking about a hypertensive chap. The BP is fairly high. We are talking about a possible hypertensive emergency. Yes, this man fell in the bathroom. Which of the following statements is correct about this patient? One is start antiplatelet drugs. You see, if somebody will fall down in the bathroom, there's a high possibility of him having a brain hemorrhage. And if a person is having a brain hemorrhage, you will not give antiplatelet drugs. Why? Because they will worsen the bleeding. Platelets are given. Well, platelets are not the treatment for brain hemorrhage. No? reduce the BP to 120 or lesser. This is going to cause worsening of the patient. Why? Because in this case, if you lower the BP to less than 120, the cerebral perfusion pressure will dramatically fall. That will cause a brain infarction, that will contribute to rather killing this person. First, he presented with brain hemorrhage and you are causing a brain infarction, the guy will deteriorate. So what are you going to do? You are definitely going to treat this person's raised ICT by using a ventriculostomy. You might have to go in for a decompressive hemicraniectomy. So definitely you can rule out the three options, and the correct answer is Putamen is the most common site. I have highlighted this in the app. You can see here when I'm discussing a hypertension topic in FMG section of the app, you can notice the fact that in hypertension part, the bleed occurs in the putamen. So that's where the mortality component comes in, because putamen would be adjacent to the lateral ventricle or the third ventricle, and therefore once the bleed will expand, it will press on the ventricles, it will cause a raised ICT in the person, it will cause posturing in the patient, decorticate, decerebrate, and then, well, you have a coma and the person dies. So brain hemorrhage causes posturing and finally a mortality. The next one was slightly a difficult one. This talked about a 70-year-old man with recurrent episodes of exertional syncope. One, the moment you read about an old man and you think that there is a chest pain occurring, you have to think in terms of possible blockages in the coronary artery of the person. But people who are having blockages in the coronary artery, they usually present to you not with exertional syncope, they usually present to you with chest pain. But in this guy, there are two things given. There's a chest pain, there's an exertional syncope. So what you should keep in your mind is also a valvular lesion. In fact, in geriatric age group, the commonest valvular lesion is aortic stenosis. Now, he has himself told you that this is a case of valvular aortic stenosis and is giving you a radiological finding of this person. So the bottom line is, guys, he's asking you what would you get in a person having valvular aortic stenosis. The first thought process of mine would be aortic stenosis will cause enlargement of the heart. There would be left ventricular hypertrophy. And if you look at this X-ray and then if you look at the options, there was no left ventricular hypertrophy asked. So let's solve it. Option A says dilated aortic root. Now this is what you read with aortic regurgitation. You know, dilated aortic root will cause blood to leak back in the heart, aortic regurgitation. Widening of the aortic knob, this is again a feature. Both A and B are related to each other in a sense that if you are having widening of the aortic knob, only then you would be having a aortic regurgitation. You're left between C and D, that is a widening of the vascular pedicle and the post-stenotic dilatation of the aorta. Now, widening of the vascular pedicle is a feature that you encounter with patients having cardiac tamponade. There is a separate MCQ in cardiac tamponade in the subsequent part of the discussion. You can keep listening to that. The bottom line is in aortic stenosis patients, in a lateral view as well as a AP view, even if you don't know how to read X-ray, doesn't matter. If there's a stenotic lesion, there would be some dilatation also, no? Wherever there's a narrowing, there can be dilatation also. So this is a post-stenotic dilatation of the aorta. And if you look at this X-ray, I'll just come back to the previous image. The bottom line is, you see the right heart border. I've always emphasized this. Right heart border is composed of right atria, superior vena cava, inferior vena cava. You can see in the snapshot in the app describing the heart borders. And in this X-ray, this was slightly a difficult one, very frankly speaking, but you can definitely notice that there is a bulge, and I'll come back to the original image. You can see that there is definitely I would say a prominence in this part which is above the standard location. This bulge which is present is the dilatation of the aorta right after the stenotic valve. So this is where the stenotic valve would be somewhere. This is going to be the left ventricle, which is going to be ejecting blood into the aorta. So since the aortic orifice is narrowed in this case, you are having a post-stenotic dilatation. So the answer to this one would be choice number D. These are the snapshots of the heart borders. Please go through that in the app section, valvular lesions. And even if you don't go through valvular lesions, go through the murmurs part. That would give you a definitive insight. Moving to the next one, he talks about the elderly chronic alcoholic patient. Now, alcoholics, whenever he gives you alcoholic patient, what is he going to ask you? He's either going to ask you cardiac issues, very wet, very CNS issues, Wernicke's encephalopathy, Korsakoff psychosis, or delirium tremens, or he's going to talk about nutritional deficiencies. So the moment I read this question, my thought process should be crystal clear. Either it's a cardiac issue, is it a CNS issue, is it a nutritional issue? And look at the findings. He's talking about bleeding gums. He's talking about petechia in a patient. So you know the fact that all clotting factors are produced in the liver. Because all clotting factors are produced in the liver, therefore bleeding can occur like this. But when you look at the options, you can notice the fact that there is no mention of standard prothrombin time. You know, normally when we discuss liver, we always study prothrombin time is always elevated in chronic liver disease. So in this question, if you look at the options, I'm ruling out option B, factor 8 SA, because that is for hemophilia, no? Factor 8 assay is ruled out because it is for hemophilia. RBC transcriptase activity is useful for the identification of wet beriberi or thiamine deficiency, and this chap is not having bleeding gums due to thiamine deficiency. So two options are ruled out. You're left with two: thrombin time, plasma ascorbate levels. The bottom line is, guys, nutritional deficiencies of vitamin C can definitely occur in alcoholics because we have thiamine deficiency. They could be cardiac lesions, CNS lesions. If it's a vitamin C deficiency, it can contribute to manifestations like these. So what are you gonna do? You're gonna take the blood sample, spin it, and then you can take the ascorbate levels. So the answer to this would be plasma ascorbate levels. The bottom line is you can have nutritional deficiencies in alcoholic patient, and instead of asking about thiamine, which he has asked so many times, he has this time decided to ask regarding vitamin C deficiency. Moving to the next one, he talks about, this was slightly a difficult one. I think the surgeon will also talk about it, but let me do my part. He talks about a patient with palpitations. Okay, the heart rate is on the higher side, respiratory rate is fine. So there's definitely some evidence of sympathomimetic stimulation given in the question. Now, what are the conditions that you know about sympathomimetic stimulation? Pheochromocytoma, it could be thyrotoxicosis, and he tells you that his mother has recently expired due to renal cell cancer. Now, the moment you read this word, his mother has died because of renal cell cancer, all of you are aware of the fact that renal cell cancer is related to von Hippel-Lindau syndrome. No? Van Hippel-Lindau syndrome is the one related to chromosome 3, and this can have a genetic basis. So the bottom line is that in this person, there is a possibility of a familial tendency for cancers. You see, the mother has died because of renal cell cancer, and the son of this person, or the daughter of this person, is presented with features of sympathomimetic stimulation. So, well, this is slightly a difficult one. Where did I discuss this in the app? I discussed this in the integrated session. You see, right before the exam, we came out with integrated session between me and Dr. Sparsh, and you can see here, me and Dr. Sparsh, when we have discussed pheochromocytoma. You can see all these syndromes that we have discussed: men, type 2A, type 2B, and von Hippel-Lindau. And von Hippel-Lindau syndrome is one which is associated with renal cell carcinoma as well as pheochromocytoma. So because the mother has died because of renal cell cancer, well, I need to evaluate the son for possibility of pheochromocytoma. So, well, what is the test for pheochromocytoma? So it's a two-step question. I'll put it three steps. First, you need to know the syndrome, VHL. Two, you need to know what is present here. Two things: pheo as well as renal cell cancer, and can occur in different generations. And now you need to solve, how do you identify a pheochromocytoma? So what is the best test, guys? No, it is not catecholamines. It is rather end products of catecholamine metabolism. It is not vinyl mandelic acid. I mean, a lot of chaps answer vinyl mandelic acid, guys. I have explained this so many times. Vinyl mandelic acid is not to be answered for pheochromocytoma. Don't fall in that blunder that your seniors have also done. Vinyl mandelic acid is for neuroblastoma, man. The correct answer for this one is delta. That is going to be a fractionated metanephrine levels. Go to the pheochromocytoma section, listen to it. Listen to it at 2x. And I am telling you why. Because pheochromocytoma is going to stay with you for rest of your life. Any entrance exam you're giving. You're sitting for FMG, you're sitting for PG entrance exam, you sit for USMLE. Any exam you sit, pheo is always asked. So please listen to that at 2x today. Just do justice to your time. Just spend few minutes, and I'm very sure that listening to this data for pheochromocytoma would be very useful. And I agree that this was a difficult question, and we have discussed this in the integrated session. You can see renal cell carcinoma and VHL being discussed. Moving on. Comment on the serological report of this hepatitis B positive patient. You see, the problem is that most of us know how to diagnose acute hepatitis and chronic hepatitis B, and in acute and chronic hepatitis B surface antigen is positive. The key in this question was hepatitis B surface antigen is negative now, because you see, in both acute and chronic hepatitis B, surface antigen is always positive. So you can easily rule out the options, guys. I'll repeat that again. Surface antigen positivity is found in acute hepatitis B. हाईली इन्फेक्शियस पेशेंट, लोली इन्फेक्शियस पेशेंट सभी में पॉजिटिव होता है. क्रॉनिक हेपेटाइटिस बी में भी सरफेस एंटीजन पॉजिटिव होता है. तो इसका आंसर ABC तो होना ही नहीं था. You know, lot of guys got confused क्योंकि सर वो कह रहे हैं कि जी इसमें सिक्योरिटी सिस्टम, which is the security system, antibody is the surface antigen, and IgG antibody core antigen positive. So people were thinking chronic hepatitis B, but the bottom line is that there are two things positive in this guy. That is the security system antibody to surface antigen, IgG class of antibody. This is not acute hepatitis B. This is not chronic hepatitis B. This indicates a previous infection. The surface antigen has been cleared off. The correct answer to this is delta. If you go through the treasures of PrepLadder, you see, I would suggest you if you are for a medical graduate student and you are preparing for your December exam, the treasures part in our app, I would like you to go through them, and this is the table. And for interpretation of this table, what you guys are gonna say, सर इतना बड़ा टेबल कौन पढ़ेगा? तो भाई मैंने एक्सप्लेनेशन दिया है यार, आप देखो ऐप में जाओ, हेपेटाइटिस बी में आई हैव एक्सप्लेन्ड एक्यूट क्या होता है, क्रॉनिक क्या होता है, रिकवरी फेज क्या होता है, आई हैव डिस्कस्ड दोज एस्पेक्ट्स. So all you need to do is, if you get this table right, no, you have to work out exclusion, because you see, he is trying to see your exclusion skills. The bottom line is fast reading of the question. If you do a fast reading in the first go, guys, your eyes have to be on the screen for all that duration. It's all about mental toughness. It is all about mental strength. I mean, if you can focus on the screen for that long, I can assure you the fact that you can come out with anything, guys. I mean, anybody who can go through a screening exam, you can clear any exam in the world. I mean, you should be proud of it, no? I mean, he's giving a difficult exam. Yes, man, I cleared it right in the first go. That's the attitude that I want you to have. Now for this question, guys, I'm gonna get a lot of queries, and I would have students saying कि sir ये image नहीं था. I agree, sir, कोई बात नहीं, image नहीं था. But still, there are 4 options, na? Those options are clear: rheumatoid arthritis, psoriatic, osteoarthritis, scleroderma. Your objective should be that you should know how to differentiate between them, because exam में नहीं कर पाए ना. A lot of you were not able to do it. So let's solve this. I have this guy with me who told me that this was regarding a female patient. There's pain in the joints, there's a rash on the dorsum of the hand. Yeah, a bit of redness in the joints can be noticed, and there is extensive skin induration and skin tightening. Now he said, what is the diagnosis? Now rheumatoid arthritis per se, guys, in rheumatoid arthritis, whenever he will give you an image-based MCQ, you would be definitely able to see rheumatoid nodules. Were there rheumatoid nodules in the exam? Most people said no, sir, there were no rheumatoid nodules. And you can see, this is a particular deformities in the hand. You can see, in fact, I'll just show you another image so that you can be more comfortable. If you go through the app section, I have discussed regarding swan neck deformity. You compare the swan neck deformity with boutonniere deformity versus mallet finger. आप देखो तीनों देखने में they might look the same. So you should have the capacity to differentiate. No, I mean, this is easy. Swan neck deformity, nobody is gonna mess around. But then boutonniere deformity, definitely there can be issues. And boutonniere deformity versus swan neck can be confused very much with mallet finger. Mallet finger is what Dhoni developed once, when wicket keepers or footballers are the ones who develop it. So well, I don't think so that if they give you an image like this, you should ever mess up. And the advantage, you can still see a rheumatoid nodule. So was there a rheumatoid nodule present? Most people said no, sir, we could not see any nodules. So I'm ruling that out. Psoriatic arthritis can be a possibility, because psoriatic arthritis will cause involvement of DIP, and then you would be seeing pitting of the nails. So I'll show you an image now of a person having psoriatic arthritis, where you can notice, I'll just zoom it in, you can notice the pitting of the nails, no? So if you're having a pitting, you are having a bit of rash, because psoriasis will also be having a rash, and you can have deformities in the distal interphalangeal joint. Yes, it can be psoriatic arthritis also. But coming back to the original discussion, in the actual question that came, it mentioned a young female. So you're ruling out osteoarthritis because osteoarthritis occurs in old age. You're ruling out rheumatoid arthritis because there are no rheumatoid nodules, no swan neck, no boutonniere deformity. I'm open to discussion on this one. Then is psoriatic arthritis, where I just showed you an image. There should be psoriatic lesion. There should be pitting of the nails. None present. The key word in this MCQ, which I think a lot of you missed, was extensive skin induration and skin tightening. And that's a very characteristic feature of scleroderma. Because in these patients, there's going to be a fibrosis below the skin. So there would be a contracture, and that contracture will contribute to manifestations of scleroderma in the patient. So, well, you would do investigations, no? For scleroderma, we do a topoisomerase antibody, we do anti-centromere antibody. Those are subsequent things. But obviously, this question is subject to debate. I agree to that, and I personally feel that if it's extensive skin induration present with skin tightening, then this should be the answer that should be given. Moving to the next one, he talks about a 40-year-old chap who comes to the OPD with excessive sleepiness and lethargy. On physical examination, clinical features which are shown here are depicted. There is no free food in the abdomen, and liver or spleen are not palpable. Now, when I read this, the first time most guys say, sir, I mean, itna sara big MCQ with 4 lines, it takes the mental balance off. No, guys, you need to keep the focus on. So let's do a quick read again. A 40-year-old chap has come with excessive sleepiness and lethargy, so there is definitely something related to his sensorium. So is it a CNS question? Unlikely, because he is showing jaundice. The moment I read and I correlate a person having jaundice and sleepiness, He could be having a hepatic encephalopathy. So the moment you read the first line of the question and you cast a glance at the image, it gives you an idea something related to liver is there. And at the same time, he mentioned regarding alcohol consumption in a person right in the end. So there you join the dots. A alcoholic chap feeling lethargic for most part of the day because he has damaged his liver. He's having jaundice because his liver damage has decompensated. So what is the presentation, guys? It's a decompensated jaundice. It is a decompensated alcoholic cirrhosis. And what is the second image showing? You can notice, in fact, I have highlighted this in the app. You can see through the discussion. I've highlighted there is clubbing, and that's the image. No, that's the clubbing manifestation. You can see the parrot beak appearance of the nails which is present. At the same time, you can also notice a very particular contracture in the ring finger. This contracture in the ring finger is called as Dupuytren's contracture. You can see that I've discussed these manifestations of cirrhosis in the liver component. So you get compensated cirrhosis, you get decompensated cirrhosis, but the moment jaundice starts coming, the moment you start having varices, you start having caput medusae, it means that the person has gone into decompensation. So this is a straightforward case of alcoholic cirrhosis. For the remaining options, I'll be discussing in the main app a more detailed discussion of this question. Moving to the next one. This lady has presented with complaints of palpitations and weight loss. On examination, there's a sinus tachycardia. The moment you read about palpitations, weight loss, sinus tachycardia, you know that either this is pheochromocytoma or it is thyrotoxicosis. These are the only two things which have to be put in differential diagnosis. Both of them can be having these manifest. Now, pheochromocytoma has already come 2 times in your exam. 2 questions we have already solved. Unlikely the third one will also be pheochromocytoma, and then he's giving a skin lesion. No? On the shin of the person, what is the lesion, man? You can see in the rapid revision part, I have highlighted lesions on the shin. In fact, if you just go through this one slide of RR, I can assure you the fact that in the GI section, 2 questions can be solved here. One question will come later. This is the exact or possible image that came of a lesion on the shin of an ulcerative colitis patient. That would be a lesion by the name of pyoderma gangrenosum. In the same slide, I have also discussed another lesion on the shin of a diabetic patient. This is necrobiosis lipidoica diabeticorum. Now that's a longish name. I mean, if you read it for the first time, it will obviously give you jitters. I know that. But necrobiosis lipidoica diabeticorum, that's seen in shin of a diabetic patient. And in thyroid disease patient, you can see in Graves' disease patient, you could be having is a orange discoloration of the skin, that is peritoneal myxedema. So the snapshot is from rapid revision here, and you can see that's the lesion that he gave you. The correct answer to this question is beta, hyperthyroidism. And even if you don't focus on the image, the clinical features are in favor of hyperthyroidism only. The answer to this question is beta. Moving to the next one. This is post-op day 2, so the surgeon will discuss it. Let me do my part. A routine X-ray was performed. Now the patient is not complaining of any respiratory distress, is comfortable. Bilateral equal air entry is heard. You see, lots of time you might be in a post-op round, you are finding the patient is very, very comfortable, but auscultation findings are also coming out to be normal, but the x-ray is showing a nasty finding. You can see a black area where there are no vascular shadows. So this guy is definitely having a small pneumothorax. Now, why did he have a small pneumothorax? That could be a complication that could be occurring because of maybe anesthesia related complications when he was being ventilated artificially following a general anesthesia. So if a person is having a small pneumothorax and there is no distress, what would you do? You would just monitor the patient. So the correct answer would be a wait and watch and a supplemental oxygen. Why would you not put a wide bore needle? Why would you not put in a chest tube? I've explained this in the section in the app. You can see I have described that if it is less than 25% lung collapse, you would just give supplemental oxygen. If it's a 25 to 50% collapse, needle aspiration. And if it's a 50% or more, then you would obviously go in for or central cyanosis, either of the two. Then you will straight away go in for a chest tube. You would be putting an intercostal drainage tube in the patient. That is a chest tube that would be put in the fifth intercostal space in the anterior axillary or mid axillary line in the triangle of safety. So for pneumothorax, guys, we are talking about a person having spontaneous pneumothorax. Spontaneous pneumothorax, the management depends upon the percentage of lung collapse. If it's a small pneumothorax not causing significant manifestations in a person, it is supplemental treatment only. But yes, if the same person is deteriorating, the pneumothorax component has increased in size, there's cyanosis, you will have to put in a chest tube. Answer to this question is alpha. We move to the next one. This person is having chest pain at rest for last 6 hours. ECG was performed and is showing features of myocardial ischemia. I think this was one of the easiest ones. Even the pathologist would have discussed it. I mean, guy with chest pain for 6 hours, myocardial ischemia, biomarkers are showing these derangements. So we are definitely discussing a MIE, and you very well know the fact that myocyte necrosis will cause LDH1 values to increase. So I think this was a relatively easy one, and even the pathologist would talk about this one. Moving to the next one, a 50-year-old man, he presents with recurrent episodes of chest pain on exercise. Now, the moment you read chest pain on exercise, that you have to think in terms of chronic stable angina. On routine BP monitoring, his blood pressure is found to be elevated, so the risk factor is hypertension. So he's basically combined the two. What is the best drug for management of this chap? That is a chap with hypertension with chronic stable angina. You see, I've highlighted in the app section that for any patient with chronic stable angina with hypertension, the drug of choice is beta blockers. In earlier times in the exam, they simply used to ask, what is the drug of choice for chronic stable angina? And this time, instead of asking you drug of choice, they rather give you a clinical history of a chap with chronic stable angina with a risk factor of hypertension. And if you combine the two, the bottom line is, guys, if a chap is having chronic stable angina hypertension, it's always going to be beta blockers. In fact, pharmacologist has discussed one MCQ on congestive heart failure also. So I just want to highlight the fact that when you are having a combination of, in fact, I'll write it like this. Listen to my words very carefully. Even if you are come here just by chance listening to this video, I want you to pay attention. In a patient of chronic stable angina with hypertension, in a congestive heart failure patient with hypertension, in both of the scenarios, the mortality reducing drug that you would be using would be as follows. If he specifically talks about which drug will reduce mortality in chronic stable angina, your primary answer is beta blockers, that is metoprolol. And if he talks about which drug will significantly reduce mortality in congestive heart failure patient, then please appreciate that in congestive heart failure patient, if it is heart failure with preserved ejection fraction, go through the CHF lecture, and I've talked about aldosterone antagonist and ARNI. ARNI would be aldosterone receptor antagonist, and then would be nephrolysin inhibitors. So please go through these segments in the relevant part of the app, and I'm sure you would be getting a lot of questions on this topic even in your future exams. AA stands for aldosterone antagonist like spironolactone or eplerenol. Moving on. Coming to the next question, he talks about a 30-year-old man with complaints of fever and breathlessness for 3 days. On examination, the right mammary area, bronchial breathing is heard with normal air entry bilaterally. Please appreciate the fact that in pneumonia patient, air entry is normal. I mean, a lot of guys were saying, sir, answer cannot be pneumonia because air entry is normal. My point is, guys, pneumonia has a normal air entry. You see, pneumonia basically means pus in the airways. So, pus is rather in the alveoli. Pneumonia has pus in the alveoli, so air can still enter into the airway. So air entry is normal. It is bronchial breathing, which is auscultatory finding of pneumonia. Well, this patient's question has been asked earlier also. You can see a very classical Silhouette sign, no? The cardiac border, the heart is also wide, lung is also wide. So this is definitely a right middle lobe pneumonia. We'll do a more detailed discussion of ruling out other options in the main section of the app, but please go through this MCQ. There are two differentials of this. One could be hydropneumothorax, and most people were confused of hydropneumothorax because this was relatively a straight line. But why is it not a hydropneumothorax? Because if it's a concomitant hydropneumothorax, there should be blunting of the CP angle. No, here CP angle can definitely be seen. There is no blunting of the CP angle on either sides. Whereas when it comes to hydropneumothorax, you would have blunting of the CP angle. So because in this question, one, hydropneumothorax auscultatory findings would be different from one given in the question. The auscultatory findings are telling you it is pneumonia. Even if you don't know the auscultatory findings, okay. If you look at this X-ray, you cannot answer it a hydropneumothorax because water, when it will go down, air will rise. The water, when it will go down, it will cause blunting of the CP angle. Man, the CP angle will be obliterated. There would be complete whiteness, but in this case, CP angle is still visualized. But this definitely indicates a right middle lobe pneumonia in the person. The next question talks about impression from a chest X-ray. So students told me that they could see an image of a device. From this device, you can see wires. I'll just trace out the wires. One is going to the atria, okay, and the second wire is going into the ventricles of the patient. So there are two wires from an electronic device. So what is it doing? It is controlling the heart rate. So what is it? It is the pacemaker, right? So this is a pacemaker, or it could be a ICD, that is an implantable cardioverter defibrillator. But the bottom line is this device, which would be deployed in the left side of the chest, where there would be a visible scar in the chest of the person, is mainly for treatment of bradyarrhythmias. Moving to the next question, he talks about prophylactic CNS radiation is given for which of the following cancers. Now this question is slightly a difficult one. This is from the exam section part where I've discussed the exact question. I agree, this is a difficult one. You see, guys, prophylactic cranioradiation is given two times. One is in children and second time in adults. And when do you give prophylactic cranioradiation in children? For blood cancer, ALL. Acute lymphoblastic leukemia has tendency to go to the brain. It shows metastasis, it shows CNS leukemia. So to treat the CNS leukemia component, you need to give radiation. So remember, if this question is repeated again and it gives you a pediatric case where you need to go in for prophylactic CNS radiation, you do it for blood cancer. But in case it's gonna be adult, then it is small cell lung cancer. So please remember the fact, prophylactic cranioradiation is given for small cell cancer. The exact question has been replicated. You can go through. This was a difficult one. In fact, this question was discussed in the JIPMER exam. So I agree. I mean, this is not done. I mean, MCI should not be putting up questions like these. But then one or two like these should not affect your equilibrium. You see, most guys got busted by those longer questions, whereas those longer questions were always having a key point, and these relatively smaller ones are the ones which are I am personally scared of the smaller ones. The longer ones I'm still able to solve, maybe because I have a habit of seeing multiple findings in a question from a very young age. Like the way I was trained as a doctor, we had to go through those long case based scenarios. So that's the need of the hour. Okay, moving to the next one. An elderly gentleman fell in the bathroom in early morning hours and was rushed to the casualty. And then he's talking about a low GCS and a CT head. Now, most guys were very worried about the CT head finding. Definitely, there's a midline shift present. You can see that the CNS bleed is contributing to displacement of the ventricles of the patient. But guys, even if this is black and this is white, why this is black and white? Because the patient is having rather, I would say, a hyper density initially, but then some part of the blood would be reabsorbed also. You see in this image, which I would say is not very particular, it can contribute to a difficulty in diagnosis. But then look at this aspect which I've highlighted in the app. Whenever you read about elderly person falling in the bathroom, what are you going to think about? You're always going to think about subdural hemorrhage. To solve this question on the basis of, let me say, radiological interpretation might be difficult for you, but I can assure you the fact that if you ever read this person, elderly person, obese person, Parkinsonism patient, Alzheimer disease person falling in the bathroom, the impact of the head hitting the ground will contribute to subdural hemorrhage in a patient. It will contribute to a concavo-convex hyperdensity. That's the kind of a concavo-convex hyperdensity which is present in this particular case. But I just want to highlight the fact that even if you can't pick it up, or even if the image was not exactly like this, guys, there was a midline shift. That much I know. No, my T&D batch guys are very brilliant chaps. They told me regarding this fact, sir, midline shift था और बंदा गिर गया बाथरूम में, तो डायग्नोसिस क्या होगा? सबड्यूरल हैमरेज होगा. तो सर जी, इस क्वेश्चन को सॉल्व करने के लिए ना फर्स्ट लाइन से ही क्रैक हो जाता है क्वेश्चन. So a lot of these questions are having pointers. That is what I'm trying to tell you. Those pointers are the ones which are to be cracked. Moving to the next one. Now even the surgeon will talk about it, but let me just solve it for you. This talks about a young woman who on cold temperature or emotional stresses having these episodes. You can see the finger colors changing from white to blue to red. In the previous years in the exam, they simply used to ask, what does it indicate? It indicates Raynaud's phenomenon. This time also he put up a question, but rather than simply giving an image and saying comment on the diagnosis, he put up a 4-liner history, which is useless. The moment I read it, I know it's a Raynaud's phenomenon. Now, is it primary, is it secondary? The bottom line is that when it comes to primary, it is idiopathic. If it is secondary, that means there should be some connective tissue disorder. He has written here, no, there is no underlying illness, there is no comorbidity in the patient. If there is no underlying illness, there is no comorbidity in the person, it cannot be a secondary, it would be a primary Raynaud's phenomenon. So answer to this question is alpha. Harlequin sign is, guys, what you see with the pediatrics, and Ainhum is a feature in Balian love. No, in fact, Ainhum is a gangrene of the toes that is seen in Negroes, right? So this is anyway not gangrene, this is Raynaud's phenomenon. So the answer to this question is alpha. Coming to the flow volume curve, I know a lot of you were very perplexed by this question. You can go through the medicine section of the app. You can go to pulmonology and see me discussing flow volume curves. I've discussed flow volume curves for obstructive lung disorder, restrictive lung disorder, intraparenchymal. I've talked about extrathoracic, intrathoracic obstruction. And bottom line was simple, sir. I'll just quickly draw before you. Just keep your eyes on the board. 5 seconds. जो फ्लो वॉल्यूम कर्व होता है उसमें द इंस्पिरेशन पार्ट इज inferior, expiration part is above. Ask this guy to breathe in, then ask this guy to breathe out. Now what happens in asthma or COPD is breathing in is okay, but asthma is a disease of expiration na? So this expiratory part will be concave, this part will be scalloped, this would be a concavity because of prolonged expiration seen in obstructive airway disorder. So what you can see here is a very classical flow volume curve for COPD. When it comes to restrictive lung disorder, अगली बार दे देगा, अगली बार restrictive lung disorder देगा. मैं ड्रॉ करके दिखाता हूँ restrictive lung disorder कैसे दिखेगा, इसको just follow करना. Restrictive lung disorder, the curve will start a little towards, let me say this is left, this is right. So this will start slightly on the left, you know, the lung volumes will be reduced, and then you will notice a beanie cap appearance. This part will be very pointed. In patients having interstitial lung disease, there is a shift of the curve. We will always give you a baseline curve. जो dotted वाला है वो baseline curve है. So if you get a curve shift, if the curve is given, this is normal. If it gives you a curve which is slightly towards, shifted towards left, it has a very pointed beanie cap appearance. As compared to normal, which is more curved, it will have a proper pointed beanie curve appearance in interstitial lung disease. You want to listen to this, more details of this, you can go to the main section in the app where I've discussed flow volume curve. But this, I think, was a piece of cake, guys. You can very well see COPD, why it's the answer, because there's a scalloping, there's a concavity present. Moving to the next question. This was a lady presenting for a routine antenatal checkup. Which blood gas abnormalities expected to be present? I mean, you see, guys, a lot of guys were very worried. Sir, they are mixing medicine with OBGY. Man, this is no mixing. This is straightforward data. You all know that in pregnancy, the oxygen demand of the mother will go up. So what will happen? She will hyperventilate. Respiratory rate would be higher. If there is a respiratory rate higher, what will it cause? Carbon dioxide washout. And if there is a carbon dioxide washout, what will happen? Less production of protons. You know this reaction right from your biology days. Not even I'm talking about medical school days. You know this reaction. No? Carbon dioxide, water, carbonic acid, protons, and bicarbonate. So see what happens. Just look at this. No, carbon dioxide is becoming lesser, so protons will also be lesser. So there would be a alkalosis. A lady having hyperventilation and having less protons, because physiological finding of pregnancy is hyperventilation. So this would be respiratory alkalosis developing in a patient. This is discussed in the ABG section. You can go through the electrolytes component, or I would suggest you to go through 2 lectures in the PGME section. 2 must know lectures. If you're sitting for December 2020 FMGE exam, 2 lectures to be listened from the PGME section are ABG simplified. I have made it very simple, very crisp, and very to the point. There are 2 lectures on arterial blood gas analysis. You would understand very basic data for it, and I've just put a snapshot from there. I've described respiratory alkalosis, respiratory acidosis, metabolic alkalosis, and metabolic acidosis. Bottom line is hyperventilation causes carbon dioxide washout. Less carbon dioxide causes less protons, so respiratory alkalosis. In status asthmaticus, there's a buildup of carbon dioxide, so there's a respiratory acidosis, and there are various permutation combinations which can be remembered. Like if in the same MCQ in 2020 December he says pregnant lady with hyperemesis gravidarum, she's puking all the time, then there would be metabolic alkalosis. So just go through these abnormalities. I mean, they are, I would say, bread and butter for any physician, and that is why they put it up in the exam. The next question is slightly integrated in a sense that it is with physiology. No, he's talking about rabies virus. The dog bit him on the arm, but the virus will spread retrogradely to the spinal cord and then obviously to the brain. So rabies virus is spreading to central nervous system, it is spreading to the peripheral nervous system, or even tetanus, the toxin goes to, I would say, the peripheral nervous system, causing rigidity. So he's rather asking you that which molecular motor is used. So all if you're aware of retrograde molecular motor and antigrade molecular motor, no, in the axons the antigrade is kinesin and the retrograde is dynein. So the answer to this is right before you, but this was, I think, instead of just saying retrograde axonal transport as a physiologist would have taught you, they decided to ask it in this particular fashion. Moving to the next question, he talks about this car driver. He's involved in an accident, he's brought to the ER with breathlessness. On physical examination, he's having tachycardia with a low BP. That's the cause of concern. Maybe he's bleeding inside. Body temperature is fine, but extensive bruising is noticed on the chest, and a bedside X-ray was performed, and you can definitely see the fractures. So you very well know that you're dealing with a case of flail chest. So in earlier years in MCA exam, he simply used to ask you what is the best management of flail chest, which is positive pressure ventilation. But in this time, he decided to give you a clinical history. That's it. But the moment you read about a car crash, the moment you read about injuries to the chest, the moment you see multiple fractures, you know what are you gonna do? This guy will have hypoventilation. Hypoventilation will cause carbon dioxide accumulation in the body. Carbon dioxide accumulation will cause respiratory acidosis, and acidosis can kill this man. So if you want to keep this guy alive, you need to kick out this carbon dioxide. How would you kick out this carbon dioxide? Intubate this chap and then put him on positive pressure ventilation. So the answer to this question is choice number C. Coming to the next question, he talks about this lady with lung cancer having shortness of breath. Now, lung cancer patients can be having pleural effusions, and that can contribute to shortness of breath. On examination, her neck veins are engorged, showing gross elevation of JVP. The moment you read that, you know that the cause is not a pleural effusion. Though I have not commented on the X-ray at the moment he's talking about JVP, you know the fact that he's talking about a cardiac cause of breathlessness in this person. So lung cancer patient having breathlessness, but the problem is not stemming from the lung per se. It's not the cancer which is per se causing a problem. The cancer has caused something to the heart. Now let's read on. He talks about distant heart sounds. Now, where do you read distant heart sounds? You read about distant heart sounds in Beck's triad. And Beck's triad is always going to be a feature of cardiac tamponade. The breath sounds appear reduced on the left side. I mean, that was the point that caused confusion in the minds of students, because if breath sounds are reduced, it could be pleural effusion also. But my point is that there are two features which are talking about cardiac involvement, rather three. What are the three cardiac pointers towards, or rather pointers towards cardiac involvement in this case? Elevated jugular venous pressure, distant heart sounds, and a significantly increased cardiothoracic ratio, because what's happening in this case is fluid outside the heart. You can see that I've described cardiac tamponade with a similar kind of an example. There's fluid accumulation around the heart. This guy of lung cancer is basically having a malignant pericardial effusion. He can be having a pleural effusion also, no doubt about it, but a malignant pericardial effusion is going to contribute to crushing of the heart. You can see the pressure on the heart will contribute to the development of Beck's triad. And the moment you read about these aspects of muffled heart sounds, elevated JVP, hypotension, and Beck's triad, you are very well bang on spot discussing or knowing the fact that why in this person deterioration is occurring. The correct answer to this question is cardiac tamponade. Congestive heart failure is there is no risk factors for heart failure, so I'm ruling that out. Bilateral pleural effusion, I can see the CP angle, so I'm ruling that out. SVC syndrome, yes, that could be a possibility, but that in SVC syndrome there must be a mass pressing on the heart. SVC syndrome is more common with lung cancer, right? I think that's a different MCQ that you know. Small cell lung cancer causes a superior vena cava syndrome. Even that will cause a elevated JVP in the person. But at this point of time, the main keyword in this question is, and that is what most of my students gave a feedback, heart sounds are distant. The moment you read that, you know about the fact that this is going to be rather a cardiac tamponade, which is pressing on the heart from outside. It's going to crush the heart. It's going to exsanguinate the heart. And therefore, the manifestations of low blood pressure would develop, and this can contribute to death also. The type of shock developing in this patient is called as obstructive shock. You can see the snapshots from the app here for the same. Moving to the next one, our elderly patient with malignancy has developed hematuria, which is with a dipstick, and urine sample is showing a 4+ proteinuria. Which of the following is a possible diagnosis of the patient? The bottom line is it's an elderly patient, and there is a definitive malignancy, and there is features of nephrotic range proteinuria. So let's join the dots together. A old man with nephrotic syndrome, and is a known case of malignancy also. So which nephrotic syndrome is associated with malignancy? The correct answer for that would be MGN, membranous glomerulopathy. You can see a snapshot from the app where I've highlighted that membranous glomerulopathy is associated with solid organ tumors, or could be associated with lymphoma, or could be associated with leukemias. In fact, the statement that I've highlighted in membranous glomerulopathy in the nephrotic syndrome part of the lecture is that nephrotic syndrome seen with cancer, nephrotic syndrome seen in old age is MGM. So instead of simply asking you what is the commonest variety of nephrotic syndrome in old age, he decided to give you an old man with a known solid organ tumor and then say that there is a hematuria and a proteinuria. And yes, in patients who are having MGN, it's a mixed picture. It's a mixed picture. You can have a nephrotic and a nephritic. Both presentations could be simultaneously present in a patient. So the question was simply, I would say, deliberately made a clinical in a sense that they put in 2-3 lines. Otherwise, they could have simply put old man nephrotic, what is the cause? Instead of that, they put it in a descriptive fashion. But I think the question was straightforward. The next question talks about this chap who's brought to the ER with loss of consciousness following a road traffic accident. Maybe the surgeon would also like to talk about it. The GCS is low, person is in coma, MRI head is involved. Now, which is the diagnosis? Subarachnoid hemorrhage. You see, subarachnoid hemorrhage will be showing presence of blood in the sylvian fissure. Where is the sylvian fissure? Sylvian fissure is here. This would be separating the parietal from the temporal lobe. Now, you cannot see any whiteness in the sylvian fissure of this person. I repeat again. Where do you see subarachnoid hemorrhage? You are supposed to see it in the sylvian fissure most of the time. Or you can see blood in this area. That would be the fissure separating the, or this would be a anteriorly present fissure that would be separating the two frontal lobes. So in this question, subarachnoid hemorrhage is ruled out. There is no subdural hemorrhage. You can't see any convexity. You're left with cerebral amyloid angiopathy and diffuse axonal injury. Anytime you are having an MRI head with no gross findings visible, but the person is still in coma, road traffic accident, head injury, and no visible bleeding. Head injury patient in coma. The bottom line is there is a road traffic accident. The person is in coma and the MRI of the person looks apparently normal. I mean, that's the point. Though some people pointed at some white spots which could be incidental calcifications, but MRI that is not showing any gross bleed. It's not EDH, it is not SDH, it is not subarachnoid hemorrhage. That would be diffuse axonal injury. And cerebral amyloid angiopathy, yaar, ye to is a cause of brain hemorrhage, na? Cerebral amyloid angiopathy old man mein milta hai. I mean, how would he put up a question of cerebral amyloid angiopathy? He'll talk about an elderly patient, non-diabetic, non-hypertensive. Like a person was brought into a casualty today, is an old man. His son is saying, sir, my father is non-diabetic, non-hypertensive, but he still had a brain hemorrhage. What is the cause? The cause is, in old age, the brain blood vessels become weak. Why? Because there is amyloid deposition, protein deposition in the blood vessels that makes it weak. That is cerebral amyloid angiopathy. So CAA, cerebral amyloid angiopathy, is the one that is encountered in old patients who are having no risk factors like diabetes and hypertension and still are having a brain hemorrhage. The correct answer to this would be a diffuse axonal injury. Moving to a question that talks about HV interval in a very peculiar tracing. I mean, the image that is given here can definitely cause jitters, but this is from first year, guys. This is from Genong. This is actually not a question of internal medicine. It's because of integrated. That is why I've discussed it here. But I want to highlight before you that his bundle electrocardiogram was the one that was given. And in his bundle electrocardiogram, there are just 3 points to be remembered. What is to be remembered? PA, AH, and then HV intervals. So let's do a quick recap. I mean, PA, AH, and HV intervals, what do they indicate? We are doing here a quick discussion, so I'll just focus on HV interval. HV interval indicates, H stands for bundle of phase, so it talks about conduction from bundle of phase to the subsequent bundle branches. I'll put it like this. The impulse will start from SN node, travel to the AV node. It does not go through the AV node, no, it goes across the two sides of the AV node, and then you have is a septal activation. So what I'm saying is, guys, the moment the impulse hits the bundle of phase and then goes to the left fascicle and then goes to the right fascicle, first to left and left to right, this is responsible for the HV interval. The impulse, I'll just put markings here. The septal activation occurring and the impulse going to the fascicle is responsible for the HV interval. That is the question. So in the given tracing, the HV interval basically denotes, so it's antegrade conduction from bundle of phase to Purkinje, and antegrade conduction from bundle of phase to bundle branches. You see this second option, which is a close between C and D. Why D is not the answer is because the spread of impulses to the Purkinje fiber is responsible for the QRS complexes. But at the moment the current has not reached the epicardial part of the muscle. It is rather just starting from the bundle of phase and moving to the left and the right fascicle. So that basically indicates a HV interval. The correct answer to this option is C, and delta or option number D would indicate a rather RS complex. You can go through this through Genong. The physiologist will also talk about it, but if you just have an orientation for PAAH and HV, I think you're bang on spot to solve questions on his bundle electrocardiogram. The next question has an anatomy/medicine overlap. 60-year-old chap, homonymous hemianopia with macular sparing. The keyword is macular sparing. Now, the moment you read that, you know the answer, right? This would be occipital cortex. So the bottom line of this discussion is to tell you why I mean, you can just go through the scores so that you can get a better idea regarding how well did you fare in the exam. Moving to the next one, a 60-year-old man is presented with chronic projectile vomiting and significant weight loss. The moment you read that projectile vomiting, you know you're dealing with metabolic alkalosis. We have discussed this in the routine app section. Metabolic alkalosis, how it develops in a person. There is hyperaldosteronism, and hyperaldosteronism will cause urinary loss of potassium and hydrogen. And if you have a urinary loss of potassium and hydrogen, that will cause a metabolic alkalosis definitely, because hydrogen is getting kicked out of the body. The point in this patient was, I'll go back to the options, everybody could pick up hypokalemic, hypochloremic, no issues. But because he's having fluid loss from the body, because this chap is having rather dehydration developing in his body, so there has to be a third electrolyte imbalance, that is sodium is also lesser. So there are three hypos in this chap, that is going to be hypokalemia, hypochloremia, and a hyponatremia developing. And there's a fourth hypo also, which a lot of you did mention, some of you did not mention, so I did not include it. But if you go through the section in the app, I have explained metabolic alkalosis is associated with hypocalcemia. Now how that happens is beyond the scope of this particular video. You need to go to the main video for that. But do remember the fact that metabolic alkalosis के साथ चार hypos होते हैं. कौन कौन से चार hypos होते हैं? पोटेशियम लेस होता है, क्लोराइड लेस होता है, सोडियम लेस होता है और कैल्शियम भी लेस होता है. और इसमें तो यार उसने प्यूकिंग किया ना, तो ही इज लूजिंग फ्लूइड्स फ्रॉम द बॉडी. एंड वेल, व्हाट फ्लूइड वुड यू गिव फॉर दिस चैप? व्हाट इज द फ्लूइड ऑफ चॉइस फॉर मेटाबॉलिक अल्कलोसिस गाइस? Yes. Next time he can give you a question like this. He can describe a chap who's having all these electrolyte imbalances like this, and he might say what fluid will be given for correction. So the fluid for correction for metabolic alkalosis is normal saline. For metabolic acidosis, you know, is ringer lactate. But the bottom line is there are four hypos which are associated with metabolic alkalosis. So please go through this, guys. Electrolyte वाला जो part है ना, इसको चाहे आप PGME से कर लो. And for those of you who are asking me, should I read FMG, should I read PGME? My answer is first go through FMG part. You know, you start a car from first gear, go to second, go to third gear. You straight away can't start the car in third gear. So सीधा PGME करोगे फायदा नहीं होगा. But you start from the FMG segment, do some topics from PGME segment. What topic to be done for PGME segment? Electrolytes. 2 घंटे का lecture है. I assure you the fact, go through the first lecture of kidney section in PGME. पर पहले आपको kidney पढ़ना है FMG से, so that you get the basics right. उसके बाद में step 2 है, go through the electrolyte section in the PGME part. You know, आप एक बार कर लोगे 50 hours of FMG part and then about 125 hours of PGME part. मैं सारा तो करने के लिए बोल भी नहीं रहा हूँ, but do the FMG part thoroughly and then do selective topics from the PGME part. I think you are bang on spot, man. Nothing will stop you. The correct answer to this question is alpha. We move to the next one. This is the image I was talking about. A person of ulcerative colitis is having an ulcer on the leg. You see, they always ask you about extra intestinal manifestations of inflammatory bowel disease. Whenever it's gonna be inflammatory bowel disease and there is gonna be ulcer developing, it's gonna talk about pyoderma gangrenosum. You can go through the app section of inflammatory bowel disease, and I have described these manifestations. In fact, two images which I can say directly related to the images that are shown even in the rapid revision part is peritibial myxedema came and pyoderma gangrenosum came. Moving ahead, the surgeon would also like to talk about this question, but I'll do my part. The person is a tourist guide on Mount Everest. You know, there was a discussion in the app on a question from, you know, summit of Mount Everest, though this was a question related to blood gases. But then even this contributes to the fact that why a person is sick, because the higher you go up on Mount Everest, oxygen is lesser, no, and it's biting cold. So there can be two possibilities. One, the guy will always be having respiratory alkalosis, he would be having hypoxia, and because of cold there would be frostbite. I mean, the moment you read about a question about a soldier posted on Siachen glacier or a summit of Mount Everest, what are you thinking about? You are thinking about four things. That is the thought process I want you to always have: respiratory alkalosis, hypoxia, frostbite, high altitude pulmonary edema, and high altitude cerebral edema. I mean, those are the complications that are seen at high altitude. In this question, he described this chap who's a tourist guide on Mount Everest, and when he came down, there were multiple blisters on his foot, so he's developed a frostbite. He's described these blisters are excruciatingly painful. There are erythematous changes. It is tender to touch, obviously. He says which is not going to be useful. So oxygen will definitely improve his mental status. It will improve the oxygenation of the tissues. I mean, after all, I need a better blood supply because there's a definitive vasoconstriction here. So if I give oxygen to this chap, it will definitely improve the local tissue perfusion. So yes, oxygen would be given. Aspirin, well, I want to cut down the inflammation part. I want to cut down the pain component part. So if I am at a peripheral hospital and I don't have, let me say, tramadol, I don't have access to 4-twin-phenergan, I don't have access to opioids for killing the pain, at least I can give aspirin that will cut down the inflammation component and the pain component. Pentoxifylline, guys, what it does, it reduces the viscosity of blood. And when I was discussing this in the Zoom meeting with my prep students, a lot of those guys were saying ki sir, viscosity reduction is done by aspirin. No, aspirin, man, is antiplatelet drug. It is not a agent that reduces viscosity. वो तो, to tell a patient, we say like this, that aspirin blood को पतला करता है. एस्पिरिन ब्लड को पतला नहीं करता है, वो तो एंटी प्लेटलेट ड्रग है. ब्लड को पतला कौन करता है? व्हाट ड्रग रिड्यूसेस विस्कोसिटी ऑफ ब्लड? दैट इज पेंटॉक्सीफाइलिन. सो व्हाट इज द एडवांटेज? इफ यू रिड्यूस द विस्कोसिटी ऑफ ब्लड, व्हाट विल हैपन? द परफ्यूजन टू द डिस्टल टिश्यूज विल improve. And if the perfusion to the tissues will improve, therefore the chances of gangrene this guy will reduce. But there is no role of anti-clotting drugs like warfarin in this chap. So the correct answer to this question is C. We move to the next one. A person presented with back pain, maybe the age of the person was given. I got a feedback that this was again a geriatric age group person with back pain. Now old man presents with back pain ना, तो क्या सोचना क्या है? Disc prolapse. उसके बाद क्या सोचना है? Metastasis from any cancer. And if it's a male, the metastasis will usually be from a prostate cancer, and if it's a female, the metastasis will usually be from breast cancer. And if these are not in the options, then the next cause to be thought of severe backache in any person of geriatric age group is multiple myeloma. You go through the MCI questions of previous years, whenever he is talking about this statement, no, old man with back pain, old man with back pain, it's always gonna be 4 differential diagnoses. Either it could be disc prolapse due to faulty sitting habits, either it's a metastasis or it's a multiple myeloma. And then you can see punched out lesions. So he's telling you it's multiple myeloma because the punched out lesions, and he's saying what test would be done in this chap. So I can show you a snapshot from the app when I have discussed multiple myeloma. The highlight screening test is electrophoresis. We can either do a serum or a urinary electrophoresis in the patient that will show a monoclonal component or a M spike. The correct answer to this question is delta. And do remember the differentials for low backache in old age. Moving to the next question, he talks about this AIDS positive chap. I mean, repeated question of MCI, AIDS positive truck driver with cryptococcal meningitis. Earlier, he was just saying AIDS positive person with fever, headache, nuchal rigidity, differential diagnosis. Number 1 is cryptococcal meningitis. This time, he himself told it is cryptococcal meningitis. What is the rapid test? Now, bottom line is, guys, a lot of you answered India Inc. You see, India Inc. It's a negative stain. It's not staining the organism. It is staining the capsule, right? Or it is staining the organism per se is not highlighted. No, even dust particles can look like cryptococcal neoformans. So India Inc. is one, not a rapid test. Second, it is dependent on the skill of the microbiologist. Mess up. You see, if I put it like this, what is rapid test for COVID? We need to go for antigen test, no, or antibody based test. Because PCR will take a long time, a report will take time to come. So antigen or antibody test has to be a rapid test. So I'm ruling out India Inc. from the discussion now. I'm ruling out blood culture and CSF culture, that is ruled out. In the actual lecture मैंने आपको क्या बताया? CSF ELISA for cryptococcal antigen ना. So अब उसने CSF ELISA नहीं दिया ऑप्शन में, तो क्या फर्क पड़ता है? तो ब्लड में कर लेंगे ना, lateral flow assay for cryptococcal antigen. But the bottom line is, जो भी rapid test होता है, I mean the bottom line is for any rapid test it has to be antigen or antibody based test. So you just have to look for this option, that is it mentioning antigen? Yes. The best test for diagnosis of cryptococcal meningitis, if you ask me, and is given in the textbook, is CSF ELISA for cryptococcal antigen. It is written as CRAG, CRAG, CR बड़ा AG छोटा, cryptococcal CRAG antigen. तो बॉटम लाइन यही है कि इसको एलाइजा से कर लो, इसको लेटेस्ट एग्लूटिनेशन से कर लो, या इसको लैटरल फ्लो एसो से कर लो. वो जो मेथड्स है वो माइक्रोबायोलॉजिस्ट से आप पढ़ सकते हो कि भाई अलग अलग डिफरेंसेस क्या है. फॉर मी एज अ क्लिनिशियन, द एंटीजन टेस्ट और एंटीबॉडी टेस्ट इज अ रैपिड टेस्ट. So that would help me in diagnosis of this chap. And anyway, I mean, cryptococcal meningitis extensively asked. We'll treat this chap with amphoby. The next question talks about this chap who works in a glass factory, a pathology with medicine. Guy works in a glass factory, so I am talking about silicosis, right? And this guy is having progressive shortness of breath. He's predisposed to development of which of the following? So thank God he did not make this question longer and start giving you features of TB. But I think all of you are aware of this fact that silicotics have a predisposition to development of tuberculosis. Silicotics would be having interstitial lung disease, and then the possibility of TB is increased in these patients because the security system is busy fighting that silica dust. The next question talks about this girl who has developed acute ITP, is managed with steroids. You very well know that in acute ITP we have to give steroids. There is a recurrence of low platelet count once the steroids were stopped, and that's a very common finding because this is an autoimmune disorder. The moment you stop the steroids, there might be a small dip. Now you need to know, are there any visible findings of recurrence of bleeding? Is she having gum bleeds? Is she having petechiae? The question mentioned that in current physical examination, there is no petechiae or any physical evidence of bleeding. That tells you the fact that platelet count is low but is not life-threatening. Guys, life-threatening platelet count. Life-threatening platelet count is when the values go to less than 10,000. In this question, there is no mention of any platelet count given, but there is no visible bleeding, no. The question says, what is the next line of treatment? Lot of guys answered splenectomy. No, guys, splenectomy is answered when there is a low platelet count with evidence of bleeding. But in this case, acute ITP in children has a good prognosis. There is a self-resolution in most of the cases. This is just a natural course history. If you listen to the ITP discussion, the bottom line is that in acute ITP in children, you will always have a good prognosis. Adults might be having still remissions. For patients of chronic ITP, we go in for splenectomy. For chronic ITP, we go in for splenectomy, but in acute ITP, if a person is having low platelet counts with no evidence of bleeding, there is no need to worry, especially in children, because if the platelet count is, let me say, 80,000, let me make it lower, 40,000, 20,000, still, I'm not worried. Why? Because life-threatening CNS bleeds are usually seen below less than 10,000. So in this case, we will not continue with steroids because anyway, we have discontinued steroids in the patient. So A is ruled out. Splenectomy is treatment for chronic ITP. As I said, this is a case of acute ITP. So this would be answered as wait and a watch with self-resolution as occurs in most cases of acute ITP. And well, if you can go through the Hindi section of ITP part, there I have described the role of raw immunoglobulin. You know, I've talked about intravenous immunoglobulin, then I've talked about raw immunoglobulin, because traditionally we read about raw immunoglobulin for a lady who has who's Rh negative. You know, in OBGY you read about raw immunoglobulin. So for more details of ITP, go to the English section and listen to the ITP part. And usually when they ask you questions in hematology nowadays, one blood cancer, ALL is asked, or AML or CML or CLL, I mean blood cancer, and then in platelets they'll love to ask about ITP because that's the usual presentation that is seen. Coming to the next question, this is pediatrics / medicine. What is the primary defect in vitamin D resistant rickets? So we are talking about FHVRR are here familial hypophosphatemic vitamin D resistant rickets. There is a defective gene here which is called as FEX gene. Now the problem with this FEX gene is that it causes a rather overactivity of this molecule, that is FGF23, and FGF23 what it causes is phosphate wasting. और फॉस्फेट वेस्टिंग से क्या होगा, जो बोन है, बोन की जो स्ट्रेंथ है ना वो कैल्शियम अलोन पर डिपेंडेंट नहीं होती है. बोन की जो स्ट्रेंथ होती है वो कैल्शियम हाइड्रोक्सी एपेटाइट और मल्टीपल अदर सॉल्ट्स पर डिपेंडेंट होती है. सो इट्स नॉट ओनली कैल्शियम दैट गिव्स बोन स्ट्रेंथ, इट इज मल्टीपल अदर सॉल्ट्स दैट गिव बोन स्ट्रेंथ. और फॉस्फेट वेस्टिंग हो जाती है तो कैल्शियम हाइड्रोक्सी एपेटाइट की फॉर्मेशन लेसर हो जाती है. आई विल मेक इट सिंपलर. What I'm basically telling you is that in resistant rickets, there's a defective gene that you all know. There is overexpression of a hormone which is antagonist of PTH. Right? PTH क्या करता है? PTH and FGF23, they have slightly different actions from each other. In simple words, I can put it like this, that the major action of FGF23 is phosphate being kicked out. And when phosphate is kicked out, then calcium hydroxy apatite is relatively lesser and the bone becomes relatively weaker, and that is where the deformities would come, like let me say knock knees would come up in the patient, or there could be bow legs occurring in the patient. So the bottom line is, in resistant rickets there is defective FEX gene that contributes to phosphate wasting from the proximal renal tubules. Coming to alcoholics, they love to ask about alcoholics in MCA exam. This is one again such a demonstration. 30-year-old alcoholic, he had a drink 48 hours ago. He has currently developed anger rage attacks, so he's becoming violent. He's unable to identify faces of family members, and he can see inanimate objects. Inanimate objects mean non-living. He can see a rock, he can see chair, he can see any object which is non-existent. He's been brought to your ER. What is your diagnosis? Now the bottom line is he stopped drinking 2 days ago, and alcohol withdrawal will contribute usually to delirium tremens. The correct answer to this is alpha, though the psychiatrist may be also giving inputs regarding it. But the bottom line is, why is it not alcoholic hallucinosis? Is because alcoholic hallucinosis will mainly be having auditory hallucinations, and additional features which are given like violence, rage attacks are usually not given in alcoholic hallucinosis. In Korsakoff psychosis, we have confabulation. He becomes a pathological liar. There is no confabulation, no antegrade amnesia given here. In Wernicke's encephalopathy, you anyway know the mnemonic GOA, that is global confusion of thalmoplegia and areflexia. So because none of those features are given in the question, our answer is DT. And for this chap, what would you do? You would be loading this guy with IV lorazepam. You would be giving IV thiamine to this person, and that would definitely help in a quick recovery of this chap if you are managing him properly. The answer to this question is alpha. Moving to the next one. This is a person who's having loose stools 18 times with reduced urine frequency. What will be the correct finding of the person? You see, if a person is having loose stools with reduced urine frequency, it means that the person can go into pre-renal variety of acute kidney injury. Now, the moment you go into pre-renal variety of acute kidney injury, the body will try to conserve fluid and there would be a concentration of urine. If you look at option A, urinary sodium more than 40, this is a feature of salt wasting. You know, if sodium is more in the urine, it means salt wasting. Salt wasting is a feature of damage to the tubular part of the kidney. When you have tubular part of damage to the kidney, it means renal type of renal injury. I repeat that statement again. Option number A is ruled out. Why? Because of the fact that urinary sodium more than 40 is a feature of renal variety of renal failure, like glomerulonephritis. But this chap is having pre-renal variety because blood supply to kidney is lesser. Option number B is kidney biopsy showing glomerular damage. We don't do a kidney biopsy in an acute kidney injury patient. There is no rule of kidney biopsy in a chap with the AKI. Post-renal is ruled out because post-renal is seen with conditions like benign prostatic hyperplasia, or let me say vesicoureteric reflux, or I can say bladder outlet obstruction. So post-renal azotemia is ruled out because this dehydration component is actually a feature of the pre-renal AKI. In fact, I can show you an image here from the app which will make it more clear. I have highlighted hypovolemia as a trigger for pre-renal AKI, and second, I have done a test to demonstrate whether it is pre-renal or renal, and what is the test on urinary sodium. If tubules are damaged, salt will not be absorbed. No. If tubules are damaged, salt will not be absorbed. So high urinary salt will be present. That is why urinary sodium will be increased or more than 40, whereas urinary sodium would be reduced in pre-renal variety because the body will try to get back all the salt to conserve the volume. So whenever it's a pre-renal variety, you have a decreased urinary sodium. When you have a renal variety, you have a high urinary sodium, which rules out option number A, which a lot of you were confused. I would suggest you to go through acute kidney injury topic, AKI. Just go through the stages because there was a pediatric question that I'll discuss subsequently on acute kidney injury in this exam. So two questions on AKI came. One is regarding the variety, and second was regarding the staging. So I'll discuss about the staging part subsequently, but I want you to know regarding the etiology of acute kidney injury and how it manifests in the person. The correct answer to this question would be choice number C. That would be hyperosmolar urine. Coming to the next question, this talks about a 50-year-old lady with hypertension admitted with breathlessness in supine position. So he's talking about orthopnea, and simultaneously this person is having palpitations. So we are definitely thinking in terms of a pulmonary edema component of heart failure in this person. There are congested neck veins, there is a hepatomegaly, and then you can see a pitting edema present. So that's a straightforward one. They simply wanted you to pick up features of congestive heart failure. And CHF examination wise is pretty straightforward as I've discussed in the app. Treatment part, yeah, I definitely wanted to study, and I've highlighted that for management of patients of heart failure with preserved ejection fraction, and that was a question this time. Which drug will reduce mortality? It will be aldosterone antagonists. The second drug that will reduce mortality would be ARNI. And if he talks about heart failure with reduced ejection fraction, even then the first answer would be ARNI in the patient. So do remember about this. And then the agent that lowers mortality, like MI patient has been discharged and he has been diagnosed with hypertension, so even then the agent that will reduce mortality will be beta blocker, that would be metoprolol in the patient. So do remember these drugs that I've highlighted, and I think this question was relatively a easier one. The next question has an overlap with pediatrics. Let's try to solve it. This boy has presented with multiple episodes of vomiting of blood. On examination, vitals are stable. That's good news. So you don't need to go for any volume resuscitation. Splenomegaly is noticed. So this tells you the fact that this person is definitely having a feature, something in the range of portal hypertension. Why I'm saying portal hypertension is because in a question which is talking about vomiting of blood and splenomegaly, the link is portal hypertension, because only then the esophageal veins will get congested. You see portal vein pressure, 5 to 10 millimeters. Why will it increase if there is a portal hypertension? Only then the manifestations of vomiting of blood can occur, because there would be portosystemic collaterals and the esophageal veins will also become congested and they'll pop off and boom, they burst and the person starts vomiting blood. Now the mother is giving a very interesting history. She says at birth the baby had jaundice and exchange transfusion was done. And how do you do exchange transfusion? Exchange transfusion is done via the umbilical vein catheterization, and umbilical vein joins which vein? Portal vein. So what I'm saying is, because this baby, when this child, 5-year-old boy, when this child was a newborn baby, then because he underwent a exchange transfusion and umbilical vein catheterization, so it can result in a thrombus formation, and the thrombus formation gradually will obstruct the portal vein. So this patient is actually having a portal vein thrombosis. There's a collateral circulation which is ensuring blood supply to the heart, but ultimately this presentation is that of portal vein thrombosis, which has resulted in portal hypertension. Now Budd-Chiari syndrome always presents with the painful hepatomegaly. Budd-Chiari has been discussed in the liver section in the app, you can go through that. Sinusoidal fibrosis is alcoholic fibrosis. Now child would not be obviously consuming alcohol, so you can rule that out. Non-cirrhotic portal fibrosis is our diagnosis of exclusion. This is the rarest cause of portal hypertension. If you go through the discussion, I mean, if a person is non-alcoholic or viral markers are negative, the rare cause of portal hypertension is NCPF. The correct answer to this question is portal vein fibrosis. Causes of portal hypertension have to be studied, and you can go through the cirrhosis and its complication lecture and portal hypertension discussion to understand this better. The key of this MCQ was that the child had undergone a procedure where umbilical vein catheterization was done, and therefore the catheter is a foreign body in the vein, so that can trigger a thrombus formation. The next question talks about this child, 12 kgs. The urine output is only 0.5 ml per kg per hour for 12 hours, and the serum creatinine is showing a doubling. What is the stage of AKI by KDIGO criteria? My request to you would be to kindly go through the app in the acute kidney injury section. There are 3 stages. Please don't mix with CKD. In CKD, it is GFR, no, 90, then 60 to 89, then 30 to 59, then 50 to 29, then less than 15. So we are not talking about CKD, we're talking about AKI. And how to remember it? CKD stage 2 is where there's doubling of serum creatinine. AKI stage 2 is where there's doubling of serum creatinine. AKI stage 3 is where there's 3 times tripling of creatinine. Normal urine output is how much? 1 ml per kg per hour. If it decreases to 0.5 ml per kg per hour for 6 hours, then it is going to be stage 1. If you are having for 12 hours, then you call it stage 2. And if it's 0.3, see 3 coming up again and again, 3 times 0.3, and for 24 hours it is stage 3. So go through the AKI section where I've discussed it, and well, in this question you can very well work out the urine output is half of normal. 1 ml per kg per hour is normal. This is 0.5 ml per kg per hour for last 12 hours with doubling of serum creatinine. So you can see from the table that the correct diagnosis of this person would be a stage 2 of AKI. And anyway, for CKD guys, it is not a stage. No, in CKD it is grading. In chronic kidney disease, we basically have is a grading, and in acute kidney injury, what we have is a staging. So if you can go through this table, it's simple. 6, 12, 24, 0.5, 0.5, 0.3, and 1.5, 2, and 3. Just get the numbers right now. I mean, right now, if you just try to get a mental image of this now, you can work out this question. Moving to the next one, I mean, this question has been distorted a lot, guys. This question is talking about a girl with honey crust lesions on the face, which was diagnosed by the pediatrician as impetigo. So he's already told you impetigo, or even if he did not write the word impetigo, honey crust lesions is impetigo. She has now been brought with facial puffiness and is not eating well. So there were 2 questions. One was a pediatric question of acrodermatitis enterohepatica, right? This question is having a girl who's having impetigo, and impetigo is caused by streptococcus, no? It is caused by streptococcus. and one streptococcus will contribute to this, then there could be post streptococcal involvement, that is post streptococcal glomerulonephritis, because this girl will be having RBCs in the urine. And how did I know that it is RBCs in the urine? Because she's having facial puffiness, she's not eating well. So what are the reasons for why a person would be having swelling on the face? Either the heart is swelling, or the liver is not working, or the kidneys are not working. When any person comes to you with puffy face, either it could be allergic reaction to food, nothing like that given it could be heart failing, no heart failure findings. It could be liver failing because albumin will become lesser, so there could be puffiness. If there is no heart issues, there are no liver issues, it has to be the kidney. So this patient is actually having post streptococcal glomerulonephritis, which will contribute to hematuria. So pretty a straightforward one. This is a classic case of PSGN, guys. You can go through the app section. I've described this very thoroughly. You can see impetigo will present after 2 weeks, and that was the history. That this girl has been brought after 2 weeks. She has not been feeling well initially after impetigo episode, and there is a hematuria manifestation. So the clinical presentation is that of PSGN. Coming to the next one, has a physiology overlap. The question talks about a person who's having microalbuminuria. The question said, what is the site of reabsorption of proteins? Now, most guys mark that as podocytes. See, guys, podocytes are for regulation. They stop proteins. Here he's not talking about what will stop the proteins, he's talking about what will reabsorb the proteins in the ultrafiltrate. So the answer for this would be proximal convoluted tubule. So please remember, podocytes are stopping proteins, not reabsorbing the proteins. What is going to reabsorb the proteins? It is PCT, it is proximal convoluted tubule. The correct answer to this is beta. These are a couple of questions that I have gathered at the moment and I have just discussed with you. There are more detailed discussions that would be following up in the app and also on our YouTube channel. So continue listening. And guys, as far as the paper is concerned, I agree it's a difficult one, but then we have to, taking it on the chin, as they say in cricket. I mean, if somebody bowls a bouncer to me, I will not chicken out and say that, oh, you bowled me a bouncer, I'll hit him for 6. I mean, guys sitting here can relate to me better. All of you have played cricket. If somebody tries to be aggressive with you, what will you do? Either answer with aggression or back out. So here what I'm saying is, mentally be aggressive, focus on the parts which I've highlighted before, and I'm very very sure that as you keep on learning, it becomes a habit. I began the discussion by saying knowledge is power. I'm ending by saying knowledge is power, guys. I mean, it's all about what you have here, no, the gray matter. That's what people are going to respect you for. So keep hammering, keep putting in all your efforts, and I'll definitely see you on the other side, that is the side of victory.
In this video, we are going to talk about radiology related questions that were asked in FMGE August 2020. There were a lot of clinical questions and lot of images that were asked in this exam. Let's look at them one by one. So let's get started. So let's look at this first question here. A patient presents with high-grade fever, chills and cough with sputum. Radiographs are taken and are given. What is the probable diagnosis? So if you look at the radiographs here, you can see this clear opacity that is noted on the right lung. And is it in the right middle lobe or right lower lobe? If you see the opacity, it is obscuring the right heart border. It is obscuring the right heart border. And you can see on the lateral radiograph also, it is obscuring the heart borders. So this is the upper lobe, right? This is the lower lobe. Lower lobe is mostly posterior, and this is the middle lobe region. So this is a right middle lobe consolidation. So in right middle lobe consolidation or any right middle lobe pathologies, we have what is called as silhouetting of the right heart border. So silhouetting of right heart border is feature of right middle lobe consolidation. If it was lower lobe consolidation or lower lobe pathologies, you would see the pathology obscuring the domes of diaphragm, right? And it would be mostly posterior on a lateral radiograph. The lower lobes are mostly posterior when visualized on the lateral radiograph. So this is right middle lobe pathology. And this is a reference image from the app where we had discussed about this right middle lobe pathology, the silhouette sign, silhouetting right heart border. Now let's look at this next question here. So look at this question. A 65-year-old hypertensive patient on irregular medication has headache and a blood pressure of 220 by 110. CT head is shown below. What is the diagnosis? Is it intraventricular bleed, putaminal bleed, subarachnoid hemorrhage or a pontine hemorrhage? So this is an elderly hypertensive patient presenting with headache and a increased blood pressure. So if you know the anatomy, you know that this area that is abutting the frontal horn of lateral ventricle is the caudate nucleus. Then this is your lentiform nucleus, and this lentiform nucleus has an outer putamen and inner globus pallidus. So this is the outer putamen part and the inner globus pallidus. This slit-like area here, this is the third ventricle, and on either side you have the thalamus. So this is a hypertensive bleed involving which area? The putamen. The right putamen is inward, and this is the putaminal bleed. The most common site of hypertensive bleed is what? Putamen. And we had also discussed the similar thing in the app where I had showed you the putaminal bleed, and I did tell you that the most common site of hypertensive bleed is what? Putamen, and that was given as a case-based scenario and an easy image-based diagram also. So this is putaminal bleed. Now let's look at this next question. A patient with history of recurrent UTI, the intravenous pyelography image is given. Identify the location of insertion of the ureter arising from left superior pelvis. So if you look at the IVP image, you can clearly see there is duplication of the ureter on the left side. And he's asking, where does the left superior ureter insert? Does it insert below and medial to trigone of bladder? Does it insert above the dome of the bladder? Does it insert near the prostatic urethra? Or does it insert on the perineum? So if you look at the normal insertion, so imagine this is the bladder and this is the urethra, right? Imagine this is the trigone of the bladder, and here is the normal sites of insertion of the ureter. In a duplication, the superior pole ureter, so imagine this is the superior pole pelvic calcium system, and this is coming the normally in duplication, the superior pole ureter inserts more inferiorly as well as medially on the bladder. So it actually comes and inserts near the apex of the trigone rather than its normal sites. So these are the normal sites, but instead the superior pole ureter is coming inferiorly and medially and inserting near the apex of the trigone of the bladder. Sometimes this can actually come and open at the prostatic urethra also. The superior pole ureter may come and open infero-medial to the normal site of insertion, right? It can open even into the prostatic urethra. In males, this superior pole ureter will never open below the external sphincter. So imagine this is the external sphincter, right? It will never open below this external sphincter. So in males with this duplication, they do not have urinary incontinence, right? The external urethral sphincter is intact. The opening is not below the external sphincter. So there is no urinary incontinence in males, guys. Okay, so in males, there won't be no incontinence. In females, sometimes it may open outside the sphincter and also into the vagina also, producing urinary incontinence. So in females, it can produce urinary incontinence because of its ectopic insertion, right? Which pole ureter? The superior pole ureter. So you can learn this, okay, by this Weygert-Meyer rule, which states that the superior pole ureter inserts infero-medially on the bladder and is usually more prone to obstruction, especially in the form of ureterocele. So the upper pole ureter is inserting inferior as well as medial to the normal site of insertion and is more prone to obstructions. Usually you may see ureteroceles developing on this. So if you have to choose an answer from this, the best answer is below and medial to trigone of the bladder. If that is not given, the next best answer can be prostatic urethra. So apex of the trigone, if that is not given, the next answer should be prostatic urethra. So this is the site of insertion of the superior pole ureter. And what about the inferior pole ureter? The inferior pole ureter, or the ureter coming from the lower pelvis, it inserts on the normal site only, right? And superolaterally on the bladder. It inserts superiorly and laterally on the bladder and is usually more prone to reflux, right? It is more prone to reflux. So please understand, the superior pole ureter inserts infero-medially on the bladder. The CMO will help you. The superior pole ureter inserts inferior-medially on the bladder and is more prone to obstruction in the form of ureterocele. And the opposite is also right. The lower pole ureter inserts superolaterally. Instead of inferior-medially, you can say superolaterally, and is more prone to reflux. So if you can remember CMO, right, you will be able to manage what happens with the superior pole and what happens with the lower pole ureter also. Weigert-Meyer rule. And we had discussed this Weigert-Meyer rule in the app also. You can see this clearly, right, seen with duplex kidney or the duplication. CMO, right, superior pole ureter inserts inferior-medially on the bladder and is more prone to obstruction. So here the answer should be below and medial to the trigone of the bladder. At the apex of the trigone is a better answer. If that is not given, prostatic urethra can be a good answer. Here is another place where we had discussed this Weigert-Meyer rule in the app. Now look at this next question here. Identify the marked structure on the CT head. So you can see there is an arrow pointing to a structure on a CT scan head in the orbit, and they're asking you what is this structure. So remember, this structure here coming from the orbit, this is your optic nerve. And this muscle that is present medially, this is the medial rectus. And this thin muscle that you can see here, this would be the lateral rectus. And the arrow here is pointing to what? Optic nerve. We had discussed this in the app also. You need to know which is the optic nerve, medial rectus and the lateral rectus when you look at this CT scan of the orbit. Now look at this question here. There is a 5-year-old boy unable to pronate and supinate since childhood. What is the probable diagnosis? And they gave a radiograph showing the elbow and the both bones forearm. Is it radial nerve synostosis, radial head dislocation, Monteggia fracture, or is it myositis ossificans? Guys, basically this is an integrated question trying to integrate your knowledge of anatomy with radiology. We all know that pronation and supination occurs at radial ulnar joint, not at the elbow, not at the wrist. The pronation and supinations, they occur at what? Radio ulnar joints. So pronation and supination, they occur at radio ulnar joints. And if you look at the radiographs, the superior radial ulnar joint here appears fused. So you can see that the superior radial ulnar joint appears fused. So obviously, what should be the answer here? This is radio ulnar synostosis. Radio ulnar synostosis. Please look at this image. Which bone is fractured in this image? Like if you look carefully, this bone which is larger at the wrist, that is your radius, and this bone is the ulna. So please remember, the ulna is larger at the upper part and smaller at the lower part, whereas radius is smaller at the upper part and larger at the lower part. So you can see this large radius articulating with scaphoid and lunate to form the wrist joint. So that is how you can identify the radius. Radius is larger bone at the wrist. And you see that there is the fracture of radius. So this fracture of radius, distal end of radius, with inferior radio ulnar joint dislocation, inferior radio ulnar joint dislocation. This is called as your Galeazzi fracture, right? So Galeazzi fracture. And this area here, right, you have a triangular fibrocartilaginous complex. So in Galeazzi fractures, even this triangular fibrocartilaginous complex is damaged. Associated triangular fibrocartilaginous complex, that is damaged. Right? Sometimes even the interosseous membrane can be damaged in Galeazzi fractures. So this is Galeazzi fracture. So you can remember Musa, Monteggia is fracture of upper part of ulna with superior radial ulnar joint dislocation, and anterior Monteggia is the most common type of Monteggia. So this is Monteggia fracture. So fracture of upper part of ulna with superior radial ulnar joint dislocation is Monteggia. Whereas Galeazzi, you can remember as GRI. Right? Galeazzi is fracture of the lower part of the radius with inferior radial ulnar joint dislocation. So very important exercise, guys. You need to remember how Monteggia appears and how Galeazzi appears also. Now look at this next question here. Identify the marked structure shown by the arrow. So if you can see the image here, this is a T2 weighted MRI. The CSF signal is bright. So this is T2 weighted MRI. And what is the arrow pointing to? So this is the crus cerebri and this is the interpeduncular fossa. So this supratentorial structure, which is showing the crus cerebri and the interpeduncular fossa, this would be your midbrain. So this is your midbrain. So you can see here in the app also we have done the radiological anatomy, and you can see the midbrain being pointed out here. Now look at this next question here. A 45-year-old male with heart disease undergoes a chest radiograph. What is the likely diagnosis? Is it prosthetic aortic wall, mitral wall, pericardial calcification, or an implantable pacemaker? So if you see the radiograph carefully, you are able to appreciate that there is straightening of the left heart border. And this straightening of the left heart border occurs due to left atrial enlargement. And you can see there is this ring-like area, radiopaque area that you are noting between left atrium and the left ventricle in the region of the mitral wall. So this is prosthetic mitral wall, right? So you need to identify how the prosthetic mitral walls appear on the radiographs. So a comparative image showing you the different locations where to identify the mitral wall, the tricuspid wall, the pulmonary wall, and the aortic wall. So at least remember, right, aortic stenosis, aortic wall replacement, right, mitral stenosis, mitral wall replacements we do. So please look at this representative diagram which shows the location of the various heart walls, right? So this is the location of the mitral wall, the tricuspid, the aortic, and the pulmonary region. So you can see on the frontal radiograph, this is how the mitral, tricuspid, the pulmonary, and the aortic valve would appear, right? If there is a prosthetic mitral wall, aortic wall, you should know where they normally appear. And this is a lateral radiograph, and you can see here this is the locations of the mitral and the tricuspid, and here is the aortic and pulmonary on a lateral radiograph. Look at the next question here. The given skull X-ray finding is seen in. So if you see the skull radiograph, you can very classically see the classic crew cut appearance or hair on end appearance. So this is called hair on end or crew cut appearance. And this hair on end appearance or crew cut appearance is seen in thalassemias or severe hemolytic anemias. Severe hemolytic anemias. So here he asked you, where do you see this? The answer should be what? Hemolytic anemias. In multiple myeloma, you see what is called as punched out lytic lesions, right? So in multiple myeloma, multiple punched out lytic lesions giving what is called raindrop skull. So raindrop skull is seen in multiple myeloma. Increased ICT will cause you sutural diastasis, right? And you'll have multiple convolutions on the skull producing silver beaten or copper beaten skull. So increased ICT produces silver beaten or copper beaten skull, right? Copper beaten skull. So you have a good mnemonic to remember where we see this hair on end appearance or crew cut appearance. So this hair on end appearance or crew cut appearance is seen in high nest. High nest is the mnemonic that you can learn. What is this high nest? H for hereditary spherocytosis, iron deficiency anemia, even the deposits of neuroblastoma, right? So neuroblastoma in a child can produce this lytic lesions in the skull having this classic hair on end appearance. Neuroblastoma, enzyme deficiencies like G6PD deficiency which are also causing hemolytic anemias, sickle cell anemia, thalassemias. So this various causes, especially all the hemolytic anemias, spherocytosis, right, the G6PD deficiency, sickle cell anemias, thalassemias, all of these are associated with hair on end or crew cut appearance, right? High nest, H for hereditary spherocytosis, I for iron deficiency anemia, N for deposits of neuroblastoma, right? N for neuroblastoma, E for enzyme deficiencies like G6PD, and there is a good mnemonic to remember this hair on end appearance. The hair on end appearance on the radiograph is seen in high nest. What is this high nest? H for hereditary spherocytosis, I for iron deficiency anemia, N for deposits of neuroblastoma, E enzyme deficiencies like G6PD deficiency, S for sickle cell anemia, and T for thalassemias. So high nest, try to memorize hereditary spherocytosis, iron deficiency anemia, metastatic deposits of neuroblastoma, enzyme deficiencies like G6PD deficiency, sickle cell anemia, and thalassemias. They are known to produce this hair on end or crew cut appearance. So here in the app also we have discussed this for both thalassemias and hemolytic anemias. You see this hair on end or crew cut appearance. Now look at this next question here. X-ray of a 2-year-old child is given. What is the possible diagnosis? So if you look at this radiograph of a young child, you're able to see that there is a gross distension of the abdomen, right? And you can see the free air around the liver and giving the appearance of a football. So this is your football sign that you see in cases of pneumoperitoneum. So this is the football sign that you see. And in the same radiograph, if you see carefully, you are able to see this inverted V sign, which is due to the prominence of the umbilical ligaments. So this inverted V sign is also seen in cases of pneumoperitoneum. You are also seeing that inverted V sign in pneumoperitoneum. Duodenal atresia would show you double bubble appearance, right? So you would see two bubbles, double bubble appearance. And let us understand how does pneumatosis intestinalis and subcutaneous emphysema appear on the radiographs. So this we had discussed in the app also, classic football sign in pneumoperitoneum. Look at this radiograph. This radiograph in a child with prematurity, if you observe carefully, there is a intramural air within the walls of the intestine. This intramural air that you see, this intramural air is seen in pneumatosis intestinalis. Pneumatosis intestinalis. And how does subcutaneous emphysema appear? Subcutaneous emphysema shows a classic radiating lucencies which appear like this ginkgo leaf. That is called as a ginkgo leaf sign. So ginkgo leaf sign is the presence of this radiating lucencies along the muscle planes, subcutaneous planes, right? So you see this radiating lucencies. This is how the subcutaneous emphysema would appear, showing you that ginkgo leaf sign. So another good example here, you can see this radiating lucencies. This indicate, okay, in the neck muscles also you can see this lucencies. All of this suggests subcutaneous surgical emphysema. Look at this next question. Identify the given barium enema image. So this barium enema image was given and this was very, very classic. This is your claw sign or the pincer sign that you see with intersusception. So we had discussed this in the app, the claw sign or the pincer sign with intersusception on a barium enema image. Look at this question here. A 45-year-old female came for post-surgery follow-up. A chest radiograph was done. What is the most likely diagnosis? So you are given a chest radiograph and they are asking what is the diagnosis here. Is it a left-sided mastectomy, malignancy, fibroadenoma or emphysema? So if you see at the radiograph here, always try to compare the radiograph bilaterally symmetrically. So if you see here, this is the right breast shadow, but you're not seeing the left breast shadow here. So the breast shadow, this is the breast shadow guys, this is the breast shadow that you're not seeing on the left side. And this case is a post-surgery follow-up, probably a case of breast cancer which underwent mastectomy, and that is the reason we are not seeing this breast shadow on the left side. So this is left-sided mastectomy. It can also be seen in congenital conditions like Poland syndrome, right? Poland syndrome is amastia with absent pectoral muscles. So even in Poland syndrome, congenitally, we may have a similar radiograph in them. And we had discussed this condition in the app also. Here is a reference image where you can see we are discussing about post-mastectomy as well as Poland syndrome, showing only one breast shadow. The contralateral breast shadow is absent. And what is this condition? Here you are seeing a homogeneous, well-defined, dense area in the region of the breast. What is this thing? So these homogeneous, dense areas that you are seeing bilaterally symmetrically in the breast, these are your breast implants. So this is how your breast implants in breast augmentation surgeries, okay, or in case of post mastectomy when they try to put the silicone implants, you may see this breast implants, bilateral symmetrical dense structures that are seen at the region of the breast. A female patient with dysphagia, barium swallow image is shown. What is the likely diagnosis? So if you see this barium swallow image, you can see that at the lower end of the esophagus, you are seeing this classical bird beak or rat tail appearance. So this bird beak or rat tail appearance on a barium swallow is suggestive of what? Achalasia cardia. Achalasia cardia. So very simple, straightforward question. The presence of that bird beak or a rat tail appearance, okay, is suggestive of what? Achalasia cardia. And we did discuss this thing very commonly in the, repeat. And we did discuss this condition in the app where we said that achalasia cardia shows this bird beak or the rat tail appearance, and CA esophagus shows this rat tailing with irregular shouldering around. So with the irregular shouldering, if you have, that is suggestive of CA esophagus. A smooth rat tail appearance or a smooth bird beak appearance is suggestive of achalasia cardia. And again, okay, in the app is a reference image for you where we had discussed the bird beak appearance. So look at this next question here. Identify the given HSG image. So a hysterosalpinography image is given and they're asking you what is the diagnosis. Is it biconvate, uniconvate, septate or didelphus? So very simple, straightforward question. You are seeing a banana-shaped endometrial cavity. A banana-shaped endometrial cavity is feature of what? Uniconvate uterus. We had discussed this in the app also, where we said that the banana-shaped endometrial cavity that is seen in uniconvate uterus. Didelphus, you see two separate endometrial cavities opening into two separate vagina. There is a biconvate uterus where we have a wide interconval angle. This is the septate uterus where the interconval angle is narrow. If you have an indentation at the fundus, that would be arcuate uterus, and this thin T-shaped endometrial cavity. So this T-shaped endometrial cavity is seen when you have this uterine hypoplasia in cases of dithylstilbestrol exposure. So in patients with dithylstilbestrol exposure, you have this T-shaped endometrial cavity. So all this was clearly discussed in the app. Now let's look at this next question here. A 65-year-old female fell down in the bathroom and sustained head injury. CT scan was performed. What is the likely diagnosis? So if you see the CT scan image in a patient who had a trivial fall in the bathroom, right? An elderly female with a fall in the bathroom, and she is having this collection noted on the right side. So this collection is seen crossing the suture lines, right? And it is concavo-convex, like a banana shape, like concavo-convex crossing the sutures. This would be what? Subdural hematoma. Being a venous bleed can occur even after trivial trauma. So this is your subdural hematoma, showing this bleed that is crossing sutures, right, and can be seen after trivial injuries. So extradural hematoma would be biconvex, limited by sutures, whereas subdural hematoma will be banana shape and crosses the sutures. Classic extradural and subdural hematomas. So we have discussed that, okay, how these subdural hematomas appear on the radiographs. Now let's look into this image here. Identify the given IVP image. So look at the image here and try to identify what is this. If you see the image carefully, I hope in the region of the bladder you are able to appreciate this cobra head or adder head appearance. So this cobra head or adder head appearance on IVP is seen in cases of uretrocele. So bilateral uretrocele is the correct answer here. And this is the reference image from the app where we had discussed about uretrocele, showing that cobra head appearance or adder head appearance. So there was another question which showed the anatomy of the elbow and they wanted you to identify what structure was marked by the arrow. Is it medial epicondyle, trochlea, capitulum or olecranon? So you have to identify these structures here. Please remember, the larger bone at the elbow is your ulna and the radius is rounded and small. And the ulna articulates with the trochlea. So trochlea is more downward pulley-like. And radius articulate with the rounded capitulum. So the radius articulates with capitulum and the ulna articulates with trochlea. You just had to identify these structures. This would be the medial epicondyle. So you just had to identify these structures. So the answer here is what? Capitulum. So moving on to the next one here, identify the given chest radiograph. What is the problem on this chest radiograph? Is it pneumothorax, hydropneumothorax, pericardial effusion or emphysema? So if you look at this radiograph carefully, you are able to see that in the right hemithorax, towards the periphery, you do not see any bronchovascular markings. So there are no bronchovascular markings, here. And along with that, you are also able to see there is a visceral pleural line. This is the visceral pleural line. And the lung, right lung, collapsed towards the hilum. So this absent bronchovascular marking, visceral pleural reflection with the lung collapsed towards the hilum makes the diagnosis as what? Pneumothorax. And we had discussed that in the app very clearly. Absent bronchovascular markings, visceral pleural reflection, right, with the lung collapsed towards the hilum. This is pneumothorax. Now look at this next question here. A 33-year-old female with fever, weight loss, elevated levels of angiotensin converting enzymes and hilar lipendopathy on radiograph. What is the probable diagnosis? So they are giving you a radiograph and they are saying this is a female with fever and weight loss as well as elevated levels of angiotensin converting enzyme. So when you look at the radiograph, what do you observe? Is it a unilateral hilar lipendopathy or bilateral hilar lipendopathy? So if you observe carefully, in this patient, there are bilateral hilar lymph nodes. Presence of this bilateral hilar lipendopathy and presence of elevated levels of ACE, angiotensin converting enzyme, points towards the diagnosis of sarcoidosis. The symptoms of sarcoidosis are very much close in relation to TB. But presence of this bilateral hilar lymph nodes and elevated levels of ACE makes sarcoidosis the most probable diagnosis in this patient. So we have did this in the app very clearly. I taught you that in sarcoidosis, we have bilateral hilar lymph nodes and right paratracheal lymph nodes, which you call it as 1, 2, 3 sign or also called Garland sign, right? So we also call this Garland sign or 1, 2, 3 sign, right? And on a gallium scan, the same thing takes up gallium, and this gallium uptake in this bilateral hilar lymph nodes and right paratracheal lymph nodes gives you what is called as the lambda. So the bilateral hilar lymph nodes and the right paratracheal lymph nodes, they take up gallium, and this is called as lambda sign in sarcoidosis. And this is seen, lambda sign is seen on what? Radiographs or gallium scan? This is seen on gallium scan, right? Gallium scan. So this is all discussed very neatly in the app. Now moving on to the next one here. Identify the structure being pointed by the arrow. Is this hepatic artery, portal vein, hepatic vein or inferior vena cava? So the correct answer was portal vein. The arrow was there and you had to identify the portal vein. Now look at the orientation of these vessels. The portal veins we studied when we were doing the coinoid segments of the liver, that the portal vein goes transversely in the liver, right, and divides the liver into different coinoid segments. So this vein that is going transversely in the hepatic segments, right, this would be portal vein. So if you try to see how these different structures appear, how does the hepatic artery appear, hepatic vein appear, you should know the basic anatomy here. What is this structure here? This is the aorta. What is this structure here? This is the inferior vena cava. And this is the bifurcation of the portal vein. If it was hepatic veins, the hepatic veins will merge towards the inferior vena cava. Let me show you the image. So please look at this image here. This is the inferior vena cava, and you are seeing these vessels which are coming, converging towards the inferior vena cava. These are your hepatic veins. These are how the hepatic veins will appear, right? They converge onto the inferior vena cava. Whereas the portal vein, they travel transversely in the liver. So look at this image again. You can see between the right and the left crus of diaphragm, between the crura of the diaphragm, you have the aorta. And to the right of the aorta, this is the right side, this is the left side, guys. So towards the right of the aorta, we have the inferior vena cava. So this is the inferior vena cava to the right of the aorta. And you can see this is the area of the portal vein. This is the splenic artery. This is probably a part of the celiac trunk that is shown. And this is your hepatic artery. So the hepatic artery, the splenic artery are coming from the celiac trunk that are seen. So aorta, inferior vena cava, portal vein, and just anterior to the portal vein, you see this small vessel. This is your hepatic artery. So you should know how to check for the hepatic veins. The hepatic veins, they run longitudinally in the liver and they try to converge towards the inferior vena cava. portal vein, they go transversely in the liver. And the hepatic artery is a structure that is present just anterior to the portal vein. And the enhancement pattern also. So whenever the aorta is getting enhanced, these hepatic arteries will be enhancing. And in the portal venous phase, obviously the portal structures will be seen more better. Now, let's try to understand the vessels in this image also. Try to look at the image carefully. I hope you can identify this is the aorta, and this structure here is the inferior vena cava. And just from the aorta going towards the right kidney, if you trace this carefully, this vessel that is coming from the aorta tracing towards the right kidney, this is your right renal artery. And from the inferior vena cava, this vein which is coming towards the left kidney here, this would be left renal vein. So you should be able to tell which is the renal artery, which is the renal vein, by looking and tracing them back to the aorta or back to the inferior vena cava. So the aorta and the right renal artery is shown here, and the inferior vena cava and the left renal vein is shown here by looking at their drainage into these respective vessels. And also, please understand this vessel here, okay, which is a branch of the aorta, okay, which has gone in front of the left renal vein. This is your superior mesenteric artery, And towards the right of the superior mesenteric artery, this structure is your superior mesenteric vein. So superior mesenteric vein will always lie to the right of superior mesenteric artery, And this superior mesenteric artery will be joining this splenic vein. You can see this vein here coming. This is the splenic vein. And both of this confluence will then form the portal vein that we saw, right? So the splenic vein joins with the superior mesenteric vein to form the portal vein. The splenic artery will pass anterior to the left renal vein. And the orientation of superior mesenteric artery and the superior mesenteric vein should be understood. Superior mesenteric artery normally lies to the left of the superior mesenteric vein if there is a malrotation of the gut, right? If there is midgut volvulus or malrotation, you may have this vessels changing their position. The superior mesenteric artery may come to the right and the superior mesenteric vein may go to the left in cases of malrotation. Now let's look into this next question here. A patient met with a road traffic accident, is unconscious, and the CT scan does not show any findings except for few petechial hemorrhages. What is the probable diagnosis? Please remember, whenever a patient comes with a head injury, the first investigation we do is a non-contrast CT. For all cases of head injury, the first investigation that we do is what? A non-contrast CT. And on a non-contrast CT, this is appearing normal. It does not show much findings. But please look at the patient's condition. He is unconscious. He is having poor Glasgow Coma Scale. A patient who is unconscious, poor Glasgow Coma Scale, CT scan is appearing normal, or sometimes it may show petechial hemorrhages, strongly suspect diffuse axonal injury. So please remember, the investigation of choice for diffuse axonal injury is what? MRI, right? So look at this image. We have discussed this on non-contrast CT. If you see if the image is normal or there are fine petechial hemorrhages but poor Glasgow Coma Scale in the patient, strongly suspect diffuse axonal injury. We have discussed this clearly, and we also talked about, right, how the patient would come and what would be the preferred investigation. The investigation of choice for diffuse axonal injury is what? MRI. Please look at this question here. A patient with prostate cancer receives sequential radiotherapy at a dose of 1.8 to 2.4 gray and for 5 days every week for about 5 to 7 weeks. What is this called as? Basically, the question tried to define what we call as a regular or a conventional fractionated radiotherapy. In conventional regular fractionated radiotherapy, we give the patient a dose of about 2 gray every day, once daily, for 5 days a week, Monday to Friday, missing out on Saturday and Sunday. This is how most cancer patients receive their radiotherapy. This is called as your regular fractionated radiotherapy. So in regular fractionated radiotherapy, we give a dose of 2 gray every day, 5 days a week from Monday to Friday, and this is done about 5 to 7 weeks. This is called as your conventional or your regular fractionated radiotherapy. If you are giving a hyperfractionated radiotherapy, in this we give BID or TID doses twice daily, thrice daily, but we give lesser dose of about 1.1 to 1.2 gray, right, for 5 days a week for about 4 to 6 weeks. This is called as your hyperfractionated, where we are increasing the number of fractions per day, BID, TID, and we are reducing the dose of each time that we are giving. Not 2 gray, but about 1.1 to 1.2. So the number of fractions have increased. So this is called as hyperfractionated radiotherapy, also given 5 days a week. What is hypofractionated radiotherapy? Now, hypofractionated radiotherapy is a type of radiotherapy where we increase the dose that we give than the conventional radiotherapy, and it is given for a shorter duration. So if you are increasing the dose, you need lesser fractions, right? So hypofractionated is where we are increasing the dose and we are giving the radiotherapy for lesser duration. This is hypofractionated radiotherapy. And what is this continuous hyperfractionated accelerated radiotherapy? In continuous hyperfractionated accelerated radiotherapy, you are giving a BID TID dose same as a hyperfractionated radiotherapy, but we are giving it continuously all 7 days for about 4 to 6 weeks. This is what is called as continuous hyperfractionated accelerated radiotherapy. And the definition of conventional regular radiotherapy was asked, where we give a dose of about 2 gray 5 days a week for about 5 to 7 weeks. And remember, most cancers we give what is called as your regular conventional radiotherapy. In cases of aggressive cancers like small cell cancer of the lung, okay, or advanced cancers, we want to go for a hyperfractionated radiotherapy. And hypofractionated radiotherapy is mainly used as a palliative therapy or for the treatment of bone metastasis. Sometimes for treatment of bone metastasis, we may give a single fraction of a large dose, maybe 8 gray can be given as a single fraction to treat bone metastasis. So the number of fractions are less, so it is called as hypofractionated radiotherapy, but the dose delivered will generally be higher than what we give in our conventional radiotherapy. And the chart, continuous hyperfractionated accelerated radiotherapies can be given for adenocarcinomas of the lung. Look at this next question here. A 35-year-old patient from Bihar comes with generalized bone pain and was diagnosed to have fluorosis. Fluorosis of bone is commonly associated with, is it associated with osteosclerosis, osteomalacia, osteopetrosis, or osteochondrosis? So if you see the given clinical picture here, this image is showing this brownish discoloration of the teeth with mottled appearance of the teeth, which is classic of fluorosis. And what is the bone finding in fluorosis? The most common and important bone finding that you see in fluorosis is osteosclerosis. There is diffuse generalized osteosclerosis in fluorosis patients. And you also see interosseous membrane calcifications. Interosseous membrane calcifications are also important in fluorosis. And we had discussed this point, okay, when we were discussing fluorosis, that interosseous membrane calcifications as well as dense sclerotic bones are features of fluorosis. The next question here, patient with right hypochondrial pain showing water lily sign on ultrasound, what is the diagnosis? So very easy, straightforward question. Water lily sign on ultrasound is feature of what? High dilated cyst. So we have discussed that, right? Presence of the water lily sign or floating membrane sign, also called as camalote sign, because of the endocyst coming and floating, right? So the endocyst separating off from the pericyst and coming and floating in the cyst cavity, that is called as your water lily sign or a camalote sign. So water lily sign or camalote sign, where you see the floating membrane, and this can be seen in the lung as well as in the liver. Look at this next question here. A 2-year-old child with sudden onset of breathlessness, wheezing and decreased breath sounds in the right lung. Chest radiograph shows diffuse opacity in right hemithorax. What is the probable diagnosis? Is it bronchial asthma, pneumonia, foreign body aspiration, or pneumothorax? Please look at the question carefully. Look at the age group is between 2-year child, and the patient is having a sudden onset of respiratory distress, breathlessness, wheezing, decreased breath sounds in the right lung. And the chest radiograph shows a diffuse opacity in the right hemithorax. Whenever you see a child between 2 to 3 years developing acute onset of respiratory distress with a opaque or a lucent hemithorax, strongly suspect foreign body. Please remember the foreign bodies are more common on the right side because the right bronchus is straighter and stouter. What happens is whenever a foreign body comes and goes into the right bronchus, right, they can cause complete obstruction and a collapse of the lung, producing an opaque hemithorax. Or sometimes the foreign body can obstruct in the form of a ball and wall mechanism where the air entry is happening but it is not allowed to go out, or the air is not exiting out of the lungs, producing hyperinflated lungs and a lucent hemithorax. So presence of both opaque and lucent hemithorax should make you suspect of foreign body in a child between the age group of 2 to 3 years who is having a sudden acute onset of respiratory distress. So very important to understand this thing, right? So not all foreign bodies will be radio opaque. Not all foreign bodies will be seen on the radiograph. You may just see a lucent or a opaque hemithorax, and you should get a bronchoscopy done to identify and remove the foreign body. So please remember this foreign body aspiration for acute onset of respiratory distress in a 2 to 3 year old child showing a lucent or a opaque hemithorax. And we had discussed this case very clearly, right, in the app, where I told you that if at all you are told a lucent or opaque hemithorax in a child, strongly suspect foreign body. Look at this image here. So in this image, I hope you can see that this is the right lung, this is the left lung. The left hemithorax is appearing more lucent. Do you think is this pneumothorax? Look carefully. You are still able to see the bronchovascular markings. It is lucent hemithorax, left hemithorax, but it is also showing the bronchovascular marking, telling you it is not pneumothorax. You are neither seeing the visceral pleural line, right? So this is not pneumothorax. And this child who is having an acute onset of respiratory distress with a lucent hemithorax, and if you see carefully, you are seeing hyperinflated lung fields, right? The left lung is hyperinflated, pushing the mediastinum to the right side. So this lucent hemithorax also should make you think of a foreign body. When you get a CT scan done, you may see that there is this hyperinflated lucent hemithorax on the left side, right, which is pushing the heart and the mediastinum to the right side, probably due to a foreign body that is causing a ball and wall mechanism, producing a lucent hemithorax. So whether you are given a lucent hemithorax or a opaque hemithorax in a child with that age group of 2 to 3 years, where this child has this tendency to keep everything in his mouth, right, strongly suspect a foreign body. Look at this next one here. Prophylactic craniospinal irradiation is done for which cancer? Do remember, prophylactic craniospinal irradiation is done for small cell lung cancer. Small cell lung cancer, because of its early hematogenous spread. Remember, it has that azopardy effect, early hematogenous spread, right, vascular spread, and can come and involve the brain. So it's very important to do this prophylactic craniospinal irradiation in these tumors which can have early spread to the CNS, like ALL, acute lymphoblastic leukemia, even medulloblastomas. We go for what? Prophylactic craniospinal irradiation. And we had discussed this list of conditions where we have to go for this craniospinal irradiation: medulloblastoma, pineloblastoma, acute lymphoblastic leukemia, non-Hodgkin's lymphoma, right, ALL, as well as your small cell lung cancer. And do remember, the most common hormone deficiency that happens after craniospinal irradiation is a growth hormone deficiency. Now look at this question here. A patient with brain metastasis had to undergo head and neck irradiation. What is the most common delayed symptom with head and neck irradiation? So here the question is asking what is the most common delayed symptom. In head and neck irradiation, you may develop xerostomia, dysphagia, dysgeusias, but the most common is xerostomia. Xerostomia can occur as an early effect as well as delayed effect. It is the most common delayed effect that you see in cases of head and neck irradiation. So let's look at this question here. Identify the given X-ray. Look at this given radiograph here. Is it hydropneumothorax, pneumothorax, hydropneumopericardium, or a lower lobe pneumonia? So if you look at this chest radiograph here, and if you observe the right hemithorax, you are able to see this horizontal air fluid levels. So the presence of this horizontal air fluid level makes a diagnosis as hydropneumothorax. And we did discuss this thing in the app also. Very classic. All of you should know this. horizontal air fluid levels are seen in hydropneumothorax. So now look at this question here. A patient with tingling, numbness and paresthesias in the lower limbs suggestive of nerve root compression. From the given radiological image, which disc is likely to be herniated? So if you look at the image, what is this? Is it a CT or MRI? The bones are black, so this is what? MRI. What type of MRI? Is it T1 weighted MRI or T2 weighted MRI? Look at the CSF around the spinal cord. How is the appearance? White. Please understand, water is white on T2. Water is white on T2. We learned it as World War II. Water is white on T2. So this must be what? T2 weighted MRI. T2 weighted MRI. And he's asking you which disc is getting herniated. Is it L3 disc, L4 disc, L5 disc or S1 disc? So if the question was which disc is getting compressed, try to identify the vertebrae first. Please remember, this is the sacral promontory. Identify the sacral promontory or S1 that is there. So if the lumbar vertebrae are like this, the sacral promontory would be curved like this. That is how you can identify the sacral vertebra. So that is the S1 vertebra that you have. So above that, this will be L5, this will be L4, this is L3. So if you have, this is L1, L2, L3, L4, L5, right? Where is the herniation, guys, here? I hope you can see the herniation is between L4 and L5. So the correct answer would be L4, L5 disc. But if I have to choose one answer, between L1 and L2, I will have the L1 disc. Between L2 and L3, I have the L2 disc. Here I'll have L3 and here I have L4 disc. So we have 5 lumbar vertebra and 4 lumbar disc. So which disc is getting herniated? The disc between L4 and L5. That should be what? L4 that is getting herniated. But if the question is asking not the disc, but if they ask you which nerve is exiting, that is a different question. And if they are asking you which nerve is getting compressed and they show the same image, right? There will be 2 different answers for this. Let us try to understand this concept. Now imagine this is your vertebral column. Imagine this is your C1 vertebra, C2, C3, C4, C5, C6, C7. We have 7 cervical vertebra and from here this is the T1 thoracic vertebra. Please remember, we have 7 cervical vertebra and we have 8 cervical spinal nerves. We have 8 cervical spinal nerves. There is a mismatch here. And in the cervical region, the cervical spinal nerves exit above its corresponding vertebra. So the C1 nerve will be exiting above C1, C2 will be exiting above C2, C3 will be exiting above C3, C4 above C4, C5, C6, C7. So the cervical spinal nerves exit above the corresponding vertebra. So if they ask you what is the nerve that is exiting between C6 and C7, the answer should be C7 nerve. But because we have 8 cervical spinal nerves and 7 cervical vertebra, between C7 and T1, what is exiting? Between C7 and T1, the C8 is exiting. C8 is exiting. And this is an important transition point, guys. I want you to concentrate on this. Just imagine that here is T2. Here is T2. What would be the nerve that would be exiting between T1 and T2? The nerve that would be exiting between T1 and T2 would be a T1 nerve. What is happening between C7 and T1? C8 is going. So below this, all the nerves will exit below their corresponding vertebrae. Above this transition point, the nerves are exiting above the corresponding vertebra, and below this level, the nerves are exiting below its corresponding vertebra. So if I ask you what is a nerve exiting between T5 and T6 vertebra, what nerve would be exiting? T5 would be exiting, right? So they will be exiting below the vertebra. So I want you to understand this transition point, nothing much, not confusing. Please remember, we have 7 cervical vertebra and 8 cervical spinal nerves. In the cervical region, the nerves will be exiting above their corresponding vertebra, and below that, in the thoracic and the lumbar region, the spinal nerves will be exiting below the corresponding vertebra. So which nerve is exiting? Please understand, if they say what is a nerve exiting between C5 and C6, because it is cervical region, in cervical region, it will be C6. But if they ask you what is a nerve exiting between L4 and L5, what nerve will be exiting? It is L4 nerve that will be exiting. It is the L4 nerve that will be exiting. So please remember, the nerve that would be exiting, if they asked you the nerve between L4 and L5, what is the nerve that is exiting? The nerve that is exiting is what? L4 nerve. But they may ask you what nerve is getting compressed in a disc herniation or a disc prolapse between L4 and L5. For that, you need to understand that imagine this is the vertebral body, right? And on this, you are having this disc here with the annulus fibrosus, right? And imagine these are the vertebral posterior elements and this is the thecal sac area. The most common type of disc prolapse is a paracentral disc prolapse. So the most common type is the paracentral type. And in the spinal column, we have some exiting nerve roots and one traversing nerve root. So if this is L4 vertebra, between L4 and L5, what nerve is exiting, guys? L4 is exiting. And what nerve is traversing? L5 is traversing. What is the most common type of disc prolapse? Paracentral, not lateral. It is paracentral. So the disc prolapse, which is mostly paracentral, will compress which nerve? L5 nerve. What nerve is exiting between L4 and L5? L4 nerve. What nerve is getting compressed between L4 and L5? The traversing nerve, the L5 nerve. Are you clear with this? So be careful what was asked. Whether they asked you the disc that is herniating, whether they asked you which nerve is getting exiting, or they asked you which nerve is traversing or which nerve is getting compressed. So the nerve that is compressed in a disc prolapse between L4 and L5 is what? L5. So please look at this image here. You see the labeled image here. You should first identify the sacral promontory and then the labeling of the other vertebra becomes easy. And you can see the disc herniation happening between L4 and L5 levels. Look at this next question here. A 35-year-old female, known case of HIV with CD4 count less than 300, presents with fever, dyspnea, cough and chest radiograph has been taken. What is the most likely diagnosis? So this is a HIV positive case with CD4 count less than 300, having features of fever, dyspnea and cough. And if you look at the radiograph, it is showing this fine miliary mottling diffusely in both lungs. So when you see this short, fine miliary mottling diffusely in both lungs in a setting of HIV, having fever and cough, the first diagnosis should be what? Miliary tuberculosis. Miliary TB is common in an immunosuppressed individual. Histoplasmosis can also be there, but because TB is more common, I would like to go for miliary tuberculosis. So you can see this millet seed mottling can be seen in TB, miliary TB as well as in histoplasmosis, but preferably go for miliary TB as your first diagnosis in a case of HIV. Gold standard investigation for functional endoscopic sinus surgery. Please remember the gold standard investigation for looking at paranasal air sinuses, FES, is done to clear up this sinusitis, okay, and for the investigation of choice to look at what is the gold standard investigation for functional endoscopic sinus surgery. Remember, before doing a functional endoscopic sinus surgery, it is important that you get a CT scan done and evaluate the paranasal sinuses. Okay, you need to identify the structures, the Haller cells, the Onodi cells, right? So you have to see that you don't injure these cells while you're doing this functional endoscopic sinus surgery. So the gold standard before doing FES is CT scan. We did learn that the CT scan is the investigation of choice to evaluate paranasal air sinuses. And there were many overlap questions that have come in, guys. They asked you this image and they asked you what is this ratio, inferring if it is more than 50%. So this image is telling you about the cardiothoracic ratio, which if it is more than 50% indicates cardiomegaly. And we did discuss in the app how we measure this cardiothoracic ratio, and if the ratio is more than 0.5 or more than 50%, it indicates cardiomegaly. And they did ask you about these periosteal reactions, right? The Codman's triangle, which is seen in cases of osteosarcoma. And there was also a question on cardiac tamponade. They gave the Beck's triad and they asked you about cardiac tamponade. And we did discuss the periosteal reactions, right? So when you see this light thick lesion having this sun ray appearance, okay, eroding through the periosteum, producing this triangular areas of periosteum. This is your Codman's triangle feature of osteosarcoma. And they also showed a image of a nasal bone fracture, so you have to identify the nasal bone fracture in linked with ENT questions. There was also a case of a lucent area in the neck in a trumpet blower, and the diagnosis was a laryngocele. Okay, and there was also asked what is the finding in aortic stenosis. In aortic stenosis, there can be post-stenotic dilatation of aorta that can be seen on a X-rays. So these are all different questions that were asked. And there was a question asking you to identify the cardiac pacemaker on the radiograph also, and I had discussed that in the app also. So lot of questions, guys, were asked in the exam with radiology, and most of them have been covered in the app. So please go through it thoroughly, and I hope it will help you in your future exams. So stay focused, do the subject thoroughly, and I hope you have a good exam.
Hello, my dear FMG Foreign Medical Graduate students. So let us discuss 2020 anesthesia questions. Well, there were 7 questions asked in anesthesia, and 6 was directly from my app, thankfully, and I hope all of you have answered. One, the last question, which was not directly from my app, but was a pure clinical question, which I think was a very simple question. If you just read it twice, thrice, you could have got the answer. Okay, so let us discuss few questions which was asked from anesthesia. The first question was directly from core anesthesia, that is related to anesthetic agent. The question was that which of the following is contraindicated in acute intermittent porphyria? And for anesthetic agent was an option: thiopentone, propofol, ketamine, etomidate. Now guys, thiopentone. Is a barbiturate, as we have already discussed in our chapter IV anesthetic agent. It's a barbiturate, and like any other barbiturate, it is an enzyme inducer. It is an enzyme inducer. If we give any enzyme inducer to patient with history of porphyria, what will happen? It can get precipitated. So in porphyria, sodium thiopentone is absolutely contraindicated. Well, I just want to tell you that if a question is asked on porphyria and what are the drugs which should not be given, the first answer should be sodium thiopentone. It is absolutely contraindicated in porphyria. If sodium thiopentone is not in the option, the second anesthetic agent which should not be given in patient with acute intermittent porphyria is etomidate. Then answer would become this etomidate, right? If thiopentone is not in the option, okay? Etomidate can also precipitate porphyria. There is a risk of precipitation of porphyria and etomidate, so we try to avoid etomidate in patient with history of porphyria. Now, patient with history of acute intermittent porphyria, if present for some surgery, what anesthetic agent would be agent of choice? Again, very clearly in my anesthesia, I have mentioned in indications of propofol that it is anesthetic agent of choice in porphyria. So, few questions which can be formed by this is: in porphyria, thiopentone absolutely contraindicated, thiopentone not an option, etomidate contraindicated, agent of choice, anesthetic agent of choice in porphyria is propofol. So, propofol would be the best agent to be used in patient with history of porphyria. Okay. Now, what are the other contraindication of thiopentone? Thiopentone basically has 3 contraindication. One is porphyria, which is mentioned here, so I am naming it 1. The second contraindication of thiopentone is shock. We never give thiopentone in shock patient. And third is asthma, bronchial asthma, because it is bronchospastic. So, bronchial asthma, we try to avoid giving thiopentone. Fine? Okay. Propofol has only 1 contraindication. We don't give propofol in patient with shock because again it causes hypotension and bradycardia. Okay. Ketamine has several contraindication, we try to avoid ketamine in all the conditions which does not allow increase in pressure to be favorable for the patient. Like we cannot use ketamine in patient with history of increased intracranial pressure, because ketamine is a sympathetic stimulant, it can increase ICP, etc. So ketamine is avoided, we are talking about contraindication, not indication, mind you. So ketamine is contraindicated in cardiovascular surgery because it is a sympathetic stimulant, so it will increase blood pressure and heart rate. It is avoided in coronary artery disease patient. Ketamine is avoided in hypertensive patient because it will increase blood pressure. Ketamine is avoided in neurosurgery because it will increase intracranial pressure. It is avoided in glaucoma patient, right, because it will increase intraocular pressure. It is avoided in patient with history of epilepsy, because it can precipitate epilepsy. So these are the contraindication of ketamine. Shock is the only contraindication of propofol, and thiopentone has 3 contraindication: porphyria, shock and bronchial asthma. Now etomidate is not used routinely because etomidate causes adrenal gland suppression. So it is not used routinely. It is reserved only in patient with cardiorespiratory compromise because it is completely cardiovascular stable. Got my point? So I have told you a lot of questions in this one question which can be asked in exam. Etomidate is cardiovascular stable. It is reserved for cardiovascular compromised patient. It is not used routinely because it causes adrenal gland suppression. Okay. Other 3 agents I have given their absolute contraindications. Okay. So what was the next question which was asked? So the second question was an image visual question. This image was given in the option and it was asked to identify it. Well, if you have gone through snapshots or a rapid revision of anesthesia or anesthesia, main anesthesia app airway chapter, you must have come across this image. It is proceed laryngeal mask airway. Okay, what do I mean by proceed laryngeal mask airway? That image is proceed laryngeal mask airway. What do I mean by this device? I will discuss about it. But before I tell you about this, I just want to tell you that supraglottic airway device which is inserted to secure the airway and remains above the glottic opening, it's called supraglottic airway device, are basically divided into 2 types. One is first generation and second is second generation. So first generation supraglottic airway device has a cuff and a single airway tube attached to it. So first generation is classical LMA. They have single tube, one tube, airway tube for ventilation, no other tube, and they are only used for ventilation, right? And the prototype of this group is classical LMA. Then we have second generation, a better improvised form of supraglottic airway device. In second generation, we have 2 tubes. See this? This is one tube. Okay, this is the upper one is a gastric tube and the lower one is the airway tube with a connector in it. You can see this airway tube with the connector in it can be used for ventilation, and this gastric tube can be used for decompression of stomach. We can pass a Ryle's tube through it, right? So this second generation supraglottic airway device has 2 tubes inserted in it. What is the benefit of this? This second generation supraglottic airway device gives a good seal. It maintains a good seal, right? And it is comparable to ET tube in preventing aspiration. Okay. There are several very good devices in second generation supraglottic airway device. So, in second generation, supraglottic airway device, we have ProSeal LMA, which is asked in exam, ProSeal laryngeal mask airway. We have iGel airway. We have LMS Supreme, right? They all have two tubes, one airway tube, one gastric tube. ProSeal LMA has a soft silicone cuff and two tubes attached to it. iGel airway, it also has two tubes, one gastric, one airway tube, but cuff of the iGel is not a cuff which can be inflated. It is a non-inflatable cuff. Your LMAs, they have a cuff which can be inflated by pellet balloon system. But iGel does not have this pellet balloon system to inflate it. It is made up of a special material which, when put in oral cavity, it swells up with the heat and secretions of the oral cavity and take the shape of the oral cavity and create a seal. So, it does not need air to create a seal in iGel. It's a very good device. It is, the cuff of the iGel is of green color, which is one way of recognizing it, right? And LMS Supreme is also like laryngeal mask airway. The only difference is that it has a curvature. It has a curvature. It is acutely curved to go into the oral cavity smoothly. And this ProSeal LMA, you can see it is straight, right? It is straight. But LMS Supreme is curved. Same thing, single time used, it is curved, and so that it goes inside the oral cavity smoothly. So, they come under second generation airway device, and this was our ProSeal LMA, which has a soft silicone cuff, two tubes, one airway tube, one gastric tube. The cuff is inflatable by a pellet balloon, and the cuff has two seals. It has a dorsal seal and it has a ventral seal to create a very good seal above the glottic opening. So, the seal created by ProSeal LMA is comparable to endotracheal tube in preventing aspiration, unlike classical LMA, which cannot prevent aspiration at all. Okay. So, they asked classical LMA. Remember guys, classical LMA is similar except it has one tube. ProSeal LMA has two tubes. Okay. Then it has only one airway tube. Okay. ProSeal LMA has two tubes. iGel has two tubes, but the cuff is not attached with a pellet balloon system to inflate it. It is made up of a special material which swells up in the oral cavity, and the cuff portion is of green color. LMA Supreme is curved, not straight like ProSeal. It is curved at an angle to go in the oral cavity with an ease. The next question was again an image based question, and the question was identify the device. This was the device and we had to identify the device. Well guys, again I am repeating the same thing. If you have gone through the snapshots of anesthesia or rapid revision of anesthesia or in anesthesia main app airway chapter, you must have seen this device, pick of this device. This is double lumen tube. This is double lumen tube. This is double lumen endotracheal tube. Guys, when we want to separate one lung from another, then this double lumen tube is inserted. It has two tubes and it has two cuffs. One tube ends in the trachea and the other tube goes into one of the bronchus. So, if this is the airway, this is trachea, this is right and left bronchus, and if this tube is inserted, the double lumen tube, one tube will end in trachea and other will go into one of the bronchus, right? It will go into one of the bronchus, and we will inflate the cuff of the bronchus, bronchial lumen, and will also inflate the cuff of the tracheal lumen. Well, now I have separated this lung from this lung. I can use tracheal lumen to ventilate one lung and I can use bronchial lumen to ventilate the other lung, right? And if I want, I can ventilate both lung also by deflating, not inflating the cuff of the bronchial lumen and using the tracheal lumen for ventilation. So, in double lumen tube, I can ventilate both lung. I can separate one lung from another, right? I can go for a differential lung ventilation as well. Okay. And what is the indication of putting double lumen tube? There are several indications of putting double lumen tube. There are several indications. It is used for thoracic surgery. Thoracic surgery. It is used for separating one lung from another in case of like pneumonectomy, let's say in case of hemoptysis happening in one lung and I have to separate that, protect the other lung from that hemoptysis, or we have to protect the lung from infection. Let's say one lung there is a severe infection and I want to protect the other lung from it, then we put this double lumen tube. So, for lung separation in case of thoracic surgery, or for lung separation because for protecting one lung from another, like in hemoptysis or lung infection, etc. So, I have given just indications of double lumen tube, in which I have written that double lumen tube can be used for lung separation or lung isolation in case of massive hemoptysis, lung lavage in case of proteinosis, etc. in one lung and I have to separate that lung from the other lung, or copious secretion, that bronchiectasis or infection in one lung. For physiological lung separation, in case of one lung is injured and I have to ventilate the other lung, I told you, for differential ventilation, or in case of lung transplant surgery, etc., where one lung is getting transplanted, we have to ventilate only the other lung, or thoracic surgeries, like in case of pneumonectomy, etc. Okay. So, these are the various indications. You just remember indication, we use it for thoracic surgery and when we want to separate one lung from another. It has two tubes attached to each other, one tube end in trachea and other tube goes into bronchus, right? First option was endotracheal tube. Well, in this question, endotracheal tube has a single lumen, so you can easily identify it. Double lumen tube, this is double lumen tube, it has two lumen, one end into trachea and other goes into one of the bronchus. Laryngeal mask airway is a supraglottic airway device. It has a silicone cuff with a tube attached to it, and we have just seen the picture of procele LMA. Well, classical LMA is also more or less same, just with a single tube. Flexometallic tube. Flexometallic tube is a tube with a metallic wire on its inner surface, right? It has a metallic wire reinforced on its inner surface. So, you can just bend the flexometallic tube and it will maintain even its lumen even in bent position. You can knot the flexometallic tube, it can maintain the patency of the lumen even in knotted position. So, basically it is kink resistant. Flexometallic tube is kink resistant. Okay. So, guys, endotracheal tube is a routine tube which we use. Double lumen tube is used for thoracic surgery, indication is thoracic surgery. Laryngeal mask airway used whenever in emergency situation I am unable to put tube, etc., and I have to secure the airway. So, as a rescue device we are using it, or we are also using it in different surgeries as a airway device. Flexometallic tube is used, indication is for neurosurgery, for head and neck surgery, wherever there is less access to the tube and tube can bend. So, flexometallic tube, the indication is neurosurgery, head and neck surgery, right? Prone position surgery, prone position surgery. Remember guys, flexometallic tube is kink resistant, kink resistant. Okay everyone, so it is kink resistant. So, I hope you have answered this question. So, next question is, Okay. Well, there was little controversy in this question, like what was the image actually asked. Some student told me that this was the image, right? You can see this needle. They had asked to identify the needle. Well, I don't know exactly which needle has been asked because number of students gave me varied answers. So I have tried to show you all the needles. So further, if the question is asked or by seeing the needle, if you recognize, then it would be good enough. So you see this. This is a epidural Tuhi's needle. I'll show you few needles, few spinal needles also. But let me first differentiate between epidural needle and a spinal needle. Okay. Spinal needle would not be marked on its surface. There are markings on the surface of epidural needle. There would be no marking on the surface of spinal needle. It would not have any marking. Okay. Spinal needle would be longer and would be of lesser diameter, though we have a wider diameter spinal needle also available, but mostly what we are using today has less diameter. It is 1 or 2 centimeter longer than epidural needle. Okay. Now, epidural needle always have this wing along with it, because when we are putting epidural, we need to stabilize, and this wing is provided to help us in stabilizing the needle. So it also always has a wing on it, right? Okay. Let me show you few spinal needles. Okay. There are two types of spinal needle. Number one, dura cutting, and number two, dura splitting. If you just see the first needle in the picture, it is quinque needle. It is quinque needle. Okay. Well, it has, if you see, it is very sharp and it has very sharp edges on both of its end, right? This is dura cutting needle. It cuts through the dura mater fibers and creates a rent. So, when we use quinque needle, there is a chance that a rent is created in the dura, which would cause the CSF to leak. There would be a possibility of CSF leak, and this leak in the CSF can result in postdural puncture headache, right? This is first one is quinque needle, which is dura cutting needle. Now, second one and the third one is dura splitting needle, Whittaker and Sprotty, Whittaker needle and Sprotty needle. Well, see both the needles, Whittaker and Sprotty, both are pencil tip, right? Both are pencil tip and both are not very sharp on their edge, especially Sprotty. So they do not cut the dura mater, they split the dura mater. And in Whittaker in the picture, it is looking sharp, but it is not this much sharp. If you see the quinque is very sharp on both of its edge. Whittaker is not that sharp on both of its edge. It is more pencil tip. It's called pencil tip. The only problem is of Whittaker and Sprotty is the hole present on it. Okay. You see in the Sprotty, the hole is present on the body, not on the tip, and it is very big. So the problem was, even if the tip of needle was in subarachnoid space and you were giving the drug, there was a possibility of the leak of drug outside subarachnoid space through this bigger hole, right? Since the hole is longer, and so there was a chance the drug would get spilled away from subarachnoid space, even if the tip of the needle is in subarachnoid space. So Whittaker was, the another needle was designed, which is at present considered as the best spinal needle available. It is also pencil tip, but it does not have a very big hole, and the hole is nearer to the tip of the needle. So chances of drug spilling out of the subarachnoid space was minimized. Okay. So just remember these three needles, quinque, which is dura cutting. Okay. So let me write it. For spinal needle, we have two types. dura cutting or dura splitting. In dura cutting, we have quincke. This increased risk of post-dural puncture headache. So, dura splitting needle is better needle in which we have two important needles, Sprotty and Whittaker. Now, both are pencil tip, right? Not very sharp, not very sharp. The only difference between these two is that in Sprotty, the hole is big, and in Whittaker, it is smaller. So, chances of drug spillage is less in Whittaker as compared to Sprotty. So, if you want to know, Whittaker at present is considered best spinal needle with least risk of PDPH, least risk of post-dural puncture headache, right? So, Whittaker is considered as best needle with least risk of post-dural puncture headache, okay? So, guys, see these needle again. Remember, they are smooth with no markings on it. This is Toohey's needle, okay? This is Toohey's needle, which is different from the spinal needle. This is epidural needle. It has markings on it, it has a wing on it and to hold it, and most of the epidural needle have a thicker diameter than the spinal needle, what we are using today. Though, size cannot be a point of distinguish because even we have thicker spinal needle available. But remember that what we are using clinically, spinal needle have very lesser diameter and epidural needle have thick diameter, okay. Again I am showing you these three, A, B, C. A is quincke, B is Sprotty and C is Whittaker. It also has an opening, it is not being shown here, but it also has an opening, okay. You can say this is classical element, okay, right. Again, this is sharp needle, this is quincke, right. The tip is sharp and the tip is blunt. Again I have shown the tip and this tip is blunt, right. The first one is dura splitting and the second one is dura cutting. So, this is Sprotty, this is quincke. So, first one is Sprotty needle and the second one is quincke. This is Sprotty and this is quincke, which has a sharp dura cutting tip. This has a smooth dura splitting end, okay. The fifth question which came of anesthesia was, patient has no pulse, that means patient is in cardiac arrest. On ECG, some electrical activity is seen. Compression ventilation is being done. What is the next step? Okay. Guys, CPCR, cardiopulmonary cerebral resuscitation. CPCR. Now, in CPCR, what is being described in this question is like patient does not have pulse. Patient does not have pulse, but ECG is attached and some electrical activity is seen on the monitor, right. Some electrical activity is seen on the monitor. Maybe a sinus activity may be also seen, but there is no pulse. There is no pulse, but electrical activity seen. This condition is called pulseless electrical activity, or we call it PEA, pulseless electrical activity, or we call it PEA. Well, for cardiac arrest, there are 4 rhythms. In cardiac arrest, we have 4 rhythms. Ventricular fibrillation, pulseless ventricular tachycardia, pulseless ventricular tachycardia and asystole and pulseless electrical activity. Pulseless electrical activity. These are the 4 rhythms. Remember guys, cardiac arrest means patient does not have any pulse, right? So when I am palpating his carotid, I cannot feel his carotid. So patient is considered as pulseless, right? So this condition is called cardiac arrest, and there are 4 rhythms possible in cardiac arrest: ventricular fibrillation, pulseless ventricular tachycardia, asystole and pulseless electrical activity. In ventricular fibrillation, there is fibrillating waves, right, on ECG. There is fibrillating waves in ECG. Pulseless ventricular tachycardia, there are formed waves in ECG, right, but there is no pulse. There are formed waveform, but there is no pulse. In asystole, there is no pulse and no electrical activity seen on the ECG. And in pulseless electrical activity, there is no pulse and there may be some electrical activity seen on the monitor. Okay. Now, ventricular fibrillation and pulseless ventricular tachycardia are shockable rhythm. These are shockable rhythm. So, in these 2 conditions, heart is fibrillating or heart is beating, right? But that fibrillation or beating of the heart is unable to pump the blood out of the heart for the perfusion of the organ. Heart is beating, but that electrical activity of heart is unable to get converted into mechanical heart activity of heart. So pumping of the blood is not happening, so there is no pulse, but heart is beating. So in these rhythm, if I give shock to the heart stops. And then we pray that when heart resume after shock, the heart will resume its activity. We pray the activity becomes sinus activity. The natural activity of the heart is sinus activity. So when we stop the heart, it is possible that when heart again assume its rhythm, it becomes sinus rhythm. So shock, defibrillation is the best management in these conditions. So we have to defibrillate as fast as possible. But in asystole or pulseless electrical activity, there is no role of defibrillation. Asystole, there is no activity of heart, there is no blood in the system for any pumping for the heart. In pulseless electrical activity, there is electrical activity of the heart, but there is no blood in the heart to pump. Let's say patient is in cardiac tamponade or hypovolemic shock or any such condition. So giving shock to the heart, defibrillation to the heart will not do the purpose. So we never defibrillate in these 2 conditions. So these are shockable and these are non-shockable rhythm. In shockable rhythm, what is the management? We do CPR, that is chest compression and ventilation. And if we get hold of a automated external defibrillator or defibrillator, let's say manual defibrillator, we defibrillate the heart, right? We defibrillate, we once defibrillate, twice defibrillate, and if the rhythm does not come in sinus rhythm and pulse does not return back, we start giving medication. What are the medication we give? We give adrenaline and amiodarone. These 2 drugs which we give, adrenaline and amiodarone. We give adrenaline 1 in 10,000 IV and every 3 to 5 minutes we can repeat. And amiodarone we give 300 milligram IV bolus followed by 150 milligram IV bolus, right? Twice we can give only amiodarone, right? In case of non-shockable rhythm, we never shock heart. We do a CPR, that is chest compression and ventilation. And what we do? We give emergency drugs. And in emergency drug also only adrenaline, not amiodarone, not antiarrhythmic. So in non-shockable rhythm, asystole and pulseless electrical activity, chest compression and ventilation is done, that is CPCR is being done, chest compression and ventilation is done, and IV adrenaline can be repeated every 3 to 5 minutes, and the cause should be found out so that if it is possible to reverse it, then only there is a possible for the rhythm to become sinus rhythm, right? In ventricular fibrillation and pulseless ventricular tachycardia, chest compression and ventilation is done, and as fast as possible we try to defibrillate the heart. If the defibrillation is not able to convert the rhythm in sinus rhythm, we can give adrenaline and we can also give amiodarone, right? Understood the difference between management of pulseless electrical activity and asystole and management of ventricular fibrillation and pulseless ventricular tachycardia. So let me just tabulate it for you. Ventricular fibrillation and pulseless ventricular tachycardia. Asystole and pulseless electrical activity. Shockable rhythm. These are shockable rhythm. These are non-shockable rhythm. So shockable, we can give defibrillation. That is 200 joules of asynchronized shock. Okay. The drugs, emergency drugs which can be used are adrenaline, IV, 1 in 10,000 dilution every 3 to 5 minutes. There is no limit how many times you can repeat. And the other, we can give amiodarone, IV, 300 milligram followed by 150 milligram. Okay. Asystole pulseless electrical activity, non-shockable. The only emergency drug which we can give is adrenaline. Adrenaline. IV, 1 in 10,000 every 3 to 5 minutes. Okay. So this is the difference between management of VF and PVT and asystole and PA. Remember guys, in ventricular fibrillation and pulseless ventricular tachycardia, defibrillation can make the rhythm into sinus rhythm, and as fast as possible we should defibrillate the heart. In asystole and pulseless electrical activity, the only thing which can reverse is finding the cause. So we need to find the cause as fast as possible and reverse it. Then only there is a chance of getting a sinus rhythm. Chances of resuscitation is much higher in ventricular fibrillation and pulseless ventricular tachycardia, right? And chances of successful resuscitation is much less in asystole and pulseless electrical activity. Okay. So what is the answer? Patient has no pulse on ECG, some electrical activity is seen, chest compression and ventilation is being done. What is the next step? The answer is adrenaline. Answer is adrenaline. Guys, atropine, no role in cardiac arrest. Where is atropine used? Only in symptomatic bradycardia. Atropine used only in symptomatic bradycardia. Symptomatic bradycardia. Okay. Amiodarone, it is antiarrhythmic and it is given in VF and pulseless ventricular tachycardia, not in asystole and pulseless electrical activity. Defibrillation is only done in pulseless ventricular tachycardia and ventricular fibrillation, not in pulseless electrical activity and asystole. Got it? So answer is adrenaline. So next question. Okay. A patient with moderate severe cardiac disease with fibroma, right? Which of the following should not be done? Well guys, the answer here should be laparoscopic hysterectomy. Why? In severe cardiac disease, I mean it is not clear, students are not giving me clear-cut answer whether it was written moderate or severe, but I am assuming moderate to severe, and in both the answer should be that laparoscopic surgery should be avoided. What happens in laparoscopic surgery? Now, though laparoscopic surgeries are considered low risk surgery, but a pneumoperitoneum is created. Pneumoperitoneum is created by carbon dioxide insufflation. right? CO2 is insufflated. This pneumoperitoneum created by it and CO2 insufflation can cause hypercarbia, can increases afterload, preload, and decrease cardiac output. This all can lead to hemodynamic imbalance. And in cardiac disease patient, we try to avoid any hemodynamic imbalance because maybe a compensated cardiac disease can become decompensated if patient is put in stress situations like hypercarbia or increased afterload or decreased preload, decreased cardiac output, etc. So, in cardiac disease patient, laparoscopic surgeries are generally avoided. It is preferred to do open surgeries, right? So, laparoscopic surgery should be avoided in cardiac disease patient. Okay, the last question asked was, in post-operative period, chest X-ray showed pneumothorax. They have not mentioned that a big pneumothorax or a very small pneumothorax or whatever. Chest X-ray showed pneumothorax. So, I am assuming that it was not a very big pneumothorax because patient was stable with normal air entry, heard bilaterally. So, guys, patient was stable, had no symptom. Then why to do anything? A small pneumothorax would itself get absorbed. Pneumothorax which is symptomatic or a big pneumothorax seen in chest X-ray should only be treated by tube thoracotomy, or maybe if it is causing symptom immediately, to relieve the symptom by needle thoracotomy, right? So, by needle aspiration. So, remember, so answer would be wait for 24 hours and repeat chest X-ray. Guys, any problem, I am telling you a clinical point, any complication which is not causing symptom, right, then it has to be, we have to wait and watch for its progression or regression. We don't have to treat the investigation that in chest X-ray there is a pneumothorax, I will put a tube in this patient. We don't have to treat investigation, we have to treat patient, and patient is clinically stable. And if the patient is clinically stable, we just have to wait and watch in any condition. Got my point? In any condition. Understood? So, we wait for 24 hours and repeat chest X-ray. If in the same question, if massive pneumothorax with decreased air entry, etc. would have been in the question, then we had to do a tube thoracotomy. Or if the question was that patient post-op had a massive pneumothorax and blood pressure was decreasing, I mean emergent kind of situation was made in the question, then immediately needle aspiration. We go for needle aspiration and then put a tube. Okay. So, in emergency needle aspiration, in sub-emergency, we go for tube thoracotomy, and no symptom, we wait and watch, okay. So, this was our 7th question of anesthesia, okay. So, guys, these were the 7 questions. Let me just revise it very fast for you. First question was, which of the following is contraindicated in acute intermittent porphyria? Answer is sodium thiopentone, okay. Second question, identify this device. 2 tubes, silicone cuff, ProSeal element. Identify this device. 2 tubes, one end in trachea, other end in one of the bronchus, double lumen endotracheal tube. Identify the following needle. Needle with markings on it. This is Tooheys needle. Needle without marking with a very sharp edge, both edges very sharp, Quincke. Pencil tip, both of these are pencil tip, right, not very sharp. Sprotty with a bigger hole, bigger opening, Whittaker with a smaller opening. Okay, I hope this will clarify. Patient with no pulse on ECG, some electrical activity seen, chest compression and ventilation being done. What's the next step? This is pulseless electrical activity. We do CPR and give adrenaline, nothing else. So, adrenaline. Patient with moderate severe cardiac disease with fibroma, which of the following should not be done? Laparoscopic hysterectomy, because it will create pneumoperitoneum and would compromise the cardiac condition of the patient. Post-operative period, chest X-ray showed pneumothorax with no symptom. Wait for 24 hours and repeat chest X-ray, because we treat patient, we don't treat investigations. Okay?
Let's talk about the FMGE August 2020 paper. As long as people will talk about difficult papers, what will come to your mind? November AIMS 2013, All India 2012, FMGE August 2020. These are one of the most difficult papers made in my nation. You are going for a one-day match and you are asked to play a test match, a longer inning, a different temperament. I agree that the rules of cricket, they stay the same. But then the approach and the mindset takes some time to readjust. Exam was lengthy. The questions were multiple liners, long questions, added with clinical scenarios and lots of images. So the road ahead is almost going to be the same. Orthopedics had 10 questions, 8 were directly from the classical points that they can ask you. But then the way of asking them was a little different. Identify the label structure around the elbow. They had thrown an arrow on the lower end of humerus just above the radial head. When I look at the different parts around elbow, this is capitulum, radial head, the lateral epicondyle, the medial epicondyle, the trochlea, and at the back, the olecranon. In fact, we have learned this classical cry-toe. The age of ossification around elbow, 2 years for capitulum, 4 for radial head, 6 for medial epicondyle, also called as internal epicondyle, 8 for trochlea, 10 for olecranon, 12 for lateral epicondyle or external epicondyle. The first one is usually asked. That's what the arrow is, capitulum. Repeat topic. Question number 2. A young girl had a thigh swelling which has a discharging sinus from which a bony fragment came out. The local temperature of that area was raised. The parents were concerned. What was it? When we look at cavity with in the center a dead bone, draining sinuses called as cloacae. So in the center, the dead necrotic bone is called as sequestrum, surrounded by live bone called as involucrum, draining sinuses called as cloacae. So the history says a young girl has a swelling in the thigh with sinus discharging. What are those sinus discharging? Cloacae. There was a bony fragment that came out. Involucrum is not mobile. The sequestrum is. So maybe there's a small bony fragment of sequestrum that came out and the parents were concerned. Some people tell me in the question it was mentioned that there was a similar discharge bony fragment in the past as well. That further takes you towards this chronic osteomyelitis where sequestrum is pathognomic and this bony fragment is nothing but sequestrum. What's a loose body? When they talk about loose body, they'll talk about a joint. They are usually made of bone, osteogenous, cartilaginous, or bone and cartilaginous, osteocartilaginous. Very commonly seen in osteoarthritis or osteochondritis dissecans. But this scenario, unlike. Third question. They had shown an inflamed tip of a finger. This is called as phelon or whitlow, very commonly seen in thumb. The infection of pulse space of finger. Remember in ortho, it's always staph aureus. Question was, it can cause osteomyelitis? Yes. It can be due to pinprick injury many a times. Treated by antibiotic? Yes. Organism is Staph aureus, not Staph epidermidis. Again a repeat. So, sequestrum is a repeat. Staph aureus is a repeat. Capitulum is a repeat. Question number 4. They had shown a hip with proximal femur, labeled them in different parts, and asked the area where TB occurs the commonest. So remember friends, tuberculosis most commonly involves the acetabulum in the hip. In the spine, it will involve the dorsolumbar area, the vertebral body, paradiscal. And in the knee, it is the synovium. So friends, TB involves the acetabulum, number 1. Again a repeat. Question 5. A 46-year-old male presents with a lesion involving the epiphyseal region of the lower end femur. So it's an epiphyseal lesion. Whenever I talk about epiphyseal lesion, if it is skeletally immature, I will think about chondroblastoma. If it is skeletally mature, I will think about GCT. So here, this is skeletally mature, 46. And also remember, chondroblastoma is more common at upper end humerus, this area. Whereas GCT is very common in lower end of femur or lower end of radius. So friends, this looks like an epiphyseal tumor in skeletally mature. Let's look at further. They have multinucleated giant cells and mononuclear cells. So these mononuclear cells happen to be the malignant cells in this tumor. And it's one of the giant cell variant. So the classical answer will be giant cell tumor. Classical question. This time they didn't show you the image. Question number 6. A doctor removed the cast. Which cast is this? This is going around the patella. So it's called as the patellar tendon bearing cast. It will cover the patellar tendon but allow enough space at the back for the knee to flex. This is a specialized cast which is practically made for a person to weight bear after the callus starts forming. Look at the question. A doctor removed the cast and found that the fracture area was deformable but not displaceable. It means patient has callus formation. The doctor applied the cast and asked him to weight bear. Some people say this question they had to mention the PTB cast or the patellar tendon bearing cast and the stage of healing. Some said only the stage of healing. Doesn't matter. You should be prepared for both. So if I look at this, hard callus, also called as consolidation, will not allow any movement. Remodeling, again no movement. So these are out. Hematoma will be deformable and displaceable, and you will not allow weight bearing. So The treatment answer is soft callus. Coming to question number 7. They had shown an MRI of the spine and they asked you which nerve root will it compress. This is a beautiful question, tougher side. If I look at this area, this is S1, this is L5, L4, L3, L2. This is a disc, disc. Here you can see the disc has come out. Here the CSF area looks white. So water means CSF, synovial fluid. When it looks white, it's called as a T2 image. In T1 image, water, that is CSF, synovial fluid, will look black. So here you are seeing a disease where between L4 and L5 something comes out. What is it? The disc. This is a case of disc prolapse. Patient has a backache going to the right lower limb. So he has sciatica. The following is an MRI picture. Which nerve root is involved? Dear friends, if I look at this vertebra, these are the pedicles. This is the L4 pedicle. This is the L5 pedicle. This is the disc in between. When I look at nerve roots, the L4 nerve root will exit beneath the L4 pedicle from the intervertebral foramen, whereas L5 will travel over the disc and exit below the pedicle of L5. So, when there is a disc prolapse, it will involve the L5 nerve root. The lower nerve root is usually involved. When the disc goes out, far laterally, then rarely it can compress the other nerve root like L4, but usually the disc just goes on the lateral margin, just on the outer edge. So, when it just goes on the outer edge paracentral, it will usually compress the L5 nerve root, the lower nerve root. A 36-year-old male from Bihar has a fluorosis. What will the X-ray show? Fluorine is a stimulant of osteoblast, direct stimulant. And when there is fluorosis, high fluorine content, it will cause the calcification and more ossification. So intramembranous ossification will be seen, classical MCI question. It can also called osteosclerosis. Osteoporosis can't occur. Osteomalacia can't occur because these are bone weakening disorders. Osteomalacia is a nutritional deficiency leading to defect in mineralization of the bone. Osteoporosis is a decreased density, whereas osteopetrosis is a genetic defect, which is an osteoclast defect where the bone marrow is deficient. But here in osteosclerosis means dense bone due to fluorine. This was partially a new question. Question number 9. Which of the following condition will you use the brace for? I see a child in which I have abducted the thighs. When I look at the acetabulum and the femoral head, the head is covered by the acetabulum. If the acetabulum is shallow or flat, the head becomes unstable. This disease is called as DDH. So, when you adduct a hip, the head goes out. When you abduct it, the head comes in. So, that's the abduction that you need to maintain, because classical learning is hip reduces on abduction. The test which are done for it is Ortolani test. You will abduct the thigh, the head will go in. And that's the position which you maintain. This is called as Pavlik harness. Obviously in the exam it was not labeled. It is used for DDH. The other test is Barlow's test, also called as the Bahar-Low test. So if you adduct the thighs, the head goes out. So the position of reduction is abduction. Hip reduces on abduction. So remember like this, O rub. ऑर्टोलानी ओ रब, रिडक्शन ऑन एबडक्शन, ओ रब हमारा एग्ज़ाम पास करा देना, प्लीज़ help us clear the exam. Ortolani, reduction on abduction. Remember this. Classical image. And the last question. A child is unable to carry out the movement of pronation supination. So in pronation supination is the radial head which moves. So radius moves around the ulna. 85% of movement occurs at the radius. And if the radial head is fixed and there is no movement there will not be pronation supination. So this is a case of radio-ulnar fusion. In elbow dislocation, these movements can be there. Radial dislocation, these movements can be there. Radial dysplasias can be there. They can be altered but will be there. But when unable to carry out, means the two bones have fused out. So I'll say 8 direct questions. 1 radial synostosis with an image, new very difficult question. 1 fluorosis I'll give plus minus. Dear friends, in an exam where you have to get 5 out of 10 correct, if you maintain your calm, you will be able to do that even such scenarios. The learning which I take away, integrated questions of different subjects will come, images will increase, clinical scenarios will come, lengthier questions will come, and more importantly, remember to practice more images so that you are able to do the paper well. Practice, attempt your grand test, get used to longer questions.
Alright, let's talk about the psychiatric questions that were asked in the FMG examination. The first question is from alcohol withdrawal. A patient presented with history of visual hallucinations and disorientation and is a chronic alcohol user. Last intake was 2 days back. This is a question from alcohol withdrawal, right? Now we know that alcohol withdrawal can present with different symptomatology depending upon the time since the last intake. After 6 to 8 hours of the last intake, what we see is simple withdrawal symptoms like there may be most commonly tremors, there can be nausea, there can be vomiting, there can be sweating. All those symptoms are seen after 6 to 8 hours of the last intake. After 12 to 24 hours, what we see is alcoholic hallucinosis. What is alcoholic hallucinosis? Hallucinations without any disturbance of consciousness. But here we have been provided disorientation, right? So there is probably some history of orientation disturbance also and consciousness disturbance also. So after 12 to 24 hours, we see alcoholic hallucinosis. After 24 to 48 hours, we see alcohol withdrawal seizures. And after 48 to 72 hours, what we see is alcohol withdrawal delirium, also known as delirium tremens. Now, it is saying that the last intake was 2 days back. So already 48 hours have been passed since the last intake. So time wise it appears to be falling into that delirium tremens category. But we just cannot make a diagnosis on the basis of time since the last drink. We also have to go for symptoms. In fact, that is more important. When you talk about the symptoms of delirium, we basically talk of 3 things. We say disturbances of consciousness, where we say things like that patient appears to be confused or patient appears to be in altered sensorium. Second, we talk about disturbances of orientation, loss of orientation to time, place and person. And third, we talk about hallucinations, primarily visual hallucinations. So here we have visual hallucinations and disorientation in a patient who has stopped taking alcohol 2 days back. The likely diagnosis is alcohol withdrawal delirium. Answer is option B, alcohol withdrawal delirium. This was a pretty straightforward question. Alright, now this is a stupid question. What is the commonest emotional state? In fact, there is some controversy about the language of this question, but the answer is love. Now even we did not know about it, even we had to go and search for some literature. So we found an article which said that joy followed by love followed by anxiety and satisfaction are the most common emotional states. So because joy is not in the option, the second best answer becomes love. Now again, this is a weird question. I don't know why anybody would put a question like that, but you can't do anything. So answer is love, option A. Now this is again a very straightforward question. A 24-year-old patient presents with history of excessive cheerfulness, increased activity levels, excessive talking, and lack of sleep. What is your diagnosis? In psychiatry, whenever you get a question where everything is becoming excessive, person is too happy, too energetic, too cheerful, speaking a lot, your mind should immediately start thinking about manic episode. It appears to be an acute manic episode. What is the duration criteria for acute manic episode? 7 days. So our diagnosis on the basis of first 3 lines is acute mania. What is the treatment of choice in this case? Now we have talked about this question multiple times. If you have gone through the video, you must have seen the treatment part also. And there we say that in case you are asked to choose one drug, if you have to choose one drug in a patient who is in acute mania, you would always prefer antipsychotics. Drug of choice for acute mania, antipsychotics. But if you have an option of mood stabilizer plus antipsychotics in the option, mood stabilizer plus antipsychotic in the option, in that case you choose that one. So if you have to choose one drug, it would be antipsychotic. But if the examiner is giving you an option of mood stabilizers plus antipsychotic, that becomes the better answer. Let's look at the options here. What is the treatment of choice in this case? Lithium, that's a mood stabilizer. Lorazepam, that's a benzodiazepine. Carbamazepine, that's a mood stabilizer. Haloperidol is an antipsychotic. So because you choose an antipsychotic over a mood stabilizer, in case you have been given only single drug as the option, haloperidol becomes the better answer. If there was an option of lithium plus haloperidol or valproate plus haloperidol, that would have been the better answer. So the answer here is option B. Alright, again a very simple question. A 21-year-old girl suspects that the college principal is making a conspiracy against her and is planning to fail her in the upcoming exam. She feels that other teachers have also joined the conspiracy and students are helping them too. Now, what is the diagnosis? In the options you have got delusions. Now, whenever a person develops a delusion that others are trying to harm him or her, or others are trying to conspire against him or her, the answer is delusion of persecution. That particular delusion is delusion of persecution. So the answer here would be delusion of persecution, straightforward. What is delusion of reference? In patients who have delusion of reference, the belief is that even the neutral activities are somehow connected with me. For example, if I have a delusion of reference and if I see 2 people talking, I would say that those 2 are talking about me. If I have delusion of reference and if somebody is smiling, I will say she is laughing at me. So everything is happening in reference to me. What is delusion of infidelity? Here basically the person believes that the partner is cheating on me. The patient says my wife is cheating on me. The patient says my husband is cheating on me. This is delusion of infidelity. And Othello syndrome is nothing but another name for delusion of infidelity. So here our answer is option A, delusion of persecution. A 13-year-old boy was brought to the child psychiatrist by parents. The parents reported that child lies frequently at home and in school, misbehaves with the teacher, bullies the younger kids and has been caught stealing money. What is the likely diagnosis? Alright, so is a child, a kid. Now such kind of behaviors which basically are breaking the rules and regulations of society. The question is on such behaviors. Now if you look at the options, antisocial personality disorder, again he is a child. We would not make a diagnosis of personality disorder at the age of 13 years. ADHD, again we don't have any symptoms of increased of inattention or hyperactivity or impulsivity. We are left with 2 options, conduct disorder and oppositional defiant disorder. Now basically these 2 are called as disruptive behavior disorders. Disruptive behavior disorders. Whenever a child indulges in disruptive behavior like not listening to elders, stealing, running out of the house, getting into bad company, smoking, all those things come under disruptive behavior disorder. And there are 2 types, ODD and conduct disorder. Now, oppositional defiant disorder can be considered as a milder variant of conduct disorder. Conduct disorder is more severe. Oppositional defiant disorder is in comparison milder. What is the difference? How will you differentiate? In oppositional defiant disorder, the primary symptom is opposition, as the name suggests. The child opposes the authority figures. The history is the child refuses to listen to the teacher. The child refuses to follow the rules. The child at times tries to irritate the parents or the teacher by not following what they are asking him for. So all those things come under oppositional defiant disorder. A child with conduct disorder goes a step beyond. Apart from not following the rules, not listening to the authorities, these children who have conduct disorder, they indulge in serious violations of the norms of society. For example, they would indulge in behaviors like stealing. They would steal. They would bully younger kids. They may indulge in cruelty towards animals. They may indulge in what is called as truancy. What is truancy? Running out of the house, coming back home very late. And they may indulge in behaviors like, of course, lying. So when you see more serious symptoms like lying, stealing, running out of the house, bullying others, throwing away things, putting things on fire, cruelty towards animals, the answer is conduct disorder. More serious problems. When the question says only this much, that the child does not listen to the authority figure, does not follow the rule, at times irritates the authority figures by going against what they are asking for, then it is a milder form ODD. So the answer here is C, conduct disorder. A 31-year-old female with history of recent divorce. So we have a stressor. We have a history of a stressor. Presents to the emergency with complaints of palpitation, sweating, heaviness and pain in chest. Now, if you are told that a patient with a psychiatric problem presents with palpitation, sweating, heaviness, all these symptoms are pointing towards anxiety, right? And this is the patient given here is also young, 31 years old only. She had multiple similar episodes in last few weeks. So repetitive anxiety attacks are happening here. But see, if somebody is coming to you with difficulty in breathing, pain in chest, you cannot simply assume it to be an anxiety attack. You have to first rule out the physical conditions, most importantly the cardiac conditions, because it is presenting with pain in chest. So now they say the blood investigations and ECG are normal, right? In the past 2 investigations revealed no abnormality. Now this whole history is basically being given to you to rule out any organic cause or any physical cause. So these 2 lines are ruling out any organic cause. Now they're asking you what is the next best step. Before coming to the next best step, what is the diagnosis? It appears that the patient is having a panic attack. An attack of acute anxiety. Acute anxiety attack is panic attack. So patient is having a lot of anxiety symptoms and the symptoms are so severe that she had come to emergency. The investigations are coming out to be normal. It appears that she has been having multiple panic attacks. Probably she is a patient of panic disorder. What is panic disorder? Multiple, repetitive, unexpected panic attacks. So when a patient comes to you in the emergency and now you know that the patient is having a panic attack, what is the next best step? What would you do? The first thing that you have to do is to ensure that patient gets some symptom relief, immediate symptom relief. And how can you achieve that? By giving a benzodiazepine. You give the patient something like alprazolam or clonazepam for immediate symptom relief. But you cannot give benzodiazepines for too long a duration because benzodiazepines are habit forming. There is a possibility of patient becoming addicted to them. Since the question is asking about the next best step, the answer would be use benzodiazepines. But if the question had asked what is the treatment in this case, then probably we would not want to give her benzodiazepine for too long a time. Acutely, we give benzodiazepines, but for maintenance, we prefer SSRIs and cognitive behavioral therapy. SSRIs and CBT for maintenance treatment, for long-term treatment. Immediate symptom relief with benzodiazepines. So answer here becomes benzodiazepines. Admit for detailed investigation, not really, because the question itself says that investigations in the past revealed no abnormality. Start counseling sessions. Well, counseling sessions are important, but when the patient is undergoing a panic attack, probably at that time no counseling would help. We need to bring down the symptoms by using some medical treatment. Beta blockers are more so used in social anxiety. They do not have as much role in panic attacks. So the answer here becomes option C, use benzodiazepines for symptom relief. Now this is a very simple question. Excessive fear of getting contaminated, repetitive washing of hands, repetitive checking behavior, and excessive doubts are all features of course, obsessive compulsive disorder. Fear of getting contaminated and excessive doubts, they are obsessions. Repetitive washing, repetitive checking are compulsions. The answer is OCD, obsessive compulsive disorder. Very straightforward question. Now, a 37-year-old man reports that after suffering from sudden financial loss, so basically we have a stressor here. He developed certain symptoms. He started feeling fearful that someone is about to harm him. What is this? Probably this is delusion of persecution. He could not sleep or eat properly. He also began to hear voices of a female, and that voice would abuse him and say that he was useless and should kill himself. So we have history suggestive of delusion of persecution and auditory hallucinations. His symptoms stopped after approximately 1 week. So duration of symptom is only 1 week. There is no relevant past history, drug abuse history or medical history. So we have psychotic symptoms, but the duration is only 1 week. What would be the diagnosis? Of course, the answer is acute psychotic episode. Here we have the option of brief psychotic disorder. In case you are given history of a stressor, followed by stressor, there are psychotic symptoms like delusions and hallucinations, but the duration criteria is less than 1 month. If you remember, according to ICD, to make a diagnosis of schizophrenia, the symptoms should be for more than 1 month. And according to DSM, to make a diagnosis of schizophrenia, the symptoms should be more than 6 months. Patient with hallucinations, delusions, symptoms more than 1 month or 6 months, you make a diagnosis of schizophrenia. But symptoms of hallucinations and delusions, duration less than 1 month, then you make a diagnosis of acute and transient psychotic disorder according to ICD. And according to DSM, the corresponding diagnosis is brief psychotic disorder. So less than 1 month, if you are following ICD, it is ATPD, acute and transient psychotic disorder. If you are following DSM, it is brief psychotic disorder. According to DSM, less than 1 month is brief psychotic disorder. But if the symptoms are for more than 1 month, but less than 6 months, 1 to 6 months, then it becomes, the diagnosis becomes schizophreniform disorder. This one, schizophreniform disorder. So if you are following DSM-5, less than 1 month, brief psychotic disorder, 1 month to 6 months, schizophreniform disorder, more than 6 months, schizophrenia. If you are following ICD, less than 1 month, acute and transient psychotic disorder, more than 1 month, schizophrenia. The answer here is brief psychotic disorder. They are following the DSM classification. Now it's unfortunate that we have different terms in ICD and DSM, but what can you do about it? So the answer is option B. Now guys, most of the questions, as you have seen here, were clinical. They were giving you clinical scenarios and they were asking you to make a diagnosis. I would say still the questions were quite simple. Now some of you are very tense that they changed the kind of questions they used to ask. The pattern has changed, but I would say it is all for good only. Earlier the FMG students had to prepare for one type of questions to clear their MCA exam, and then they had to prepare for NEET, where anyways the clinical questions would be asked. Now if the patterns are becoming similar, the questions are becoming similar, I would say your job is becoming better. So there is no need to lose hope, there is no need to lose heart. Start preparing the clinical scenarios, the clinical questions, and I'm sure you would do great in the December examination.
So welcome students Today we will be discussing recently conducted FMGE exam. So in this exam there were around 15 questions from dermatology, and we will be discussing these questions and their explanation. Okay, so let us begin with the first question. Most of these questions were already discussed in my regular videos of PrepLadder, and that's why I also mentioned their page number and where you will find them in the notes. Okay. Now there was one question that was auspit sign is seen in. Now this is previously asked question. Auspit sign is seen in psoriasis vulgaris. Okay, now what is auspit sign? Okay, so in auspit sign what happens that the lesions of psoriasis are erythematous scaly plaques. Okay, so they are erythematous. Erythematous means red, scaly, that is lot of flakes and scales are there, and they are plaques. Plaques are solid raised lesions. Okay, so these are erythematous scaly plaques. Now if you take a glass slide, okay, simple glass slide, and start scraping this lesion, what you will find, these scales start coming out. Okay, so more you scratch the lesion, more scales comes out. Okay, once you remove all the scales, you will find pinpoint bleeding spots, that is known as auspit sign. Okay, so if you scrap this lesion, then the end result is, let us consider this is the plaque. So end result is pinpoint bleeding. This is known as auspit sign. This is characteristic sign which is seen in psoriasis. Sometimes what happens that before this pinpoint bleeding is seen, that is once you are scrapping the lesion and you have removed all the scales, sometimes you will find a shiny membrane which is often surrounded by a hypopigmented margin. This hypopigmented margin is known as Warnoff ring, and this shiny membrane is known as Bulkley membrane. So sometimes they ask you these questions also, that Bulkley membrane and Warnoff ring is seen in, but remember auspit sign is feature of psoriasis. Now there are different types of psoriasis. Among them the most common type is known as psoriasis vulgaris, and that was there in the option. Let us move on to the second question. In the second question they are saying ulcer, as shown in the image, you can see these ulcers with overhanging or undermined edges. Now this is a very important point to remember, undermined edges. So many times this question have been asked that undermined edges are seen in, and as soon as you see this term undermined edges, always think of three very important conditions which are seen in dermatology. One, tuberculosis. If these are genital ulcers or in the genital areas, then or history of contact is mentioned, then think of chancroid, and pyoderma gangrenosum. So these are three very important conditions where ulcers with undermined edges are seen, and as you can see one of them is mentioned in the option, that is tubercular, and that is the answer. Okay, so what happens that patient might be having tuberculosis in the lymph nodes and many of them have ruptured, and due to which these ulcers are being formed. Such type of tuberculosis is also known as scleroderma. Okay, so if there is scleroderma in the option, that also you can choose. Okay, so I hope you remember that if you find undermined edges, always think of these three conditions. Okay, let us move on to the next question. In this next question they are asking that which mineral deficiency leads to the following condition as shown in the image, and in the image what you can see erythematous, that is red in color, lesions, and the site for these lesions is perianal or genital area and face, and especially perioral area, that is the lesions are around mouth and around genitals. Okay, so such characteristic rashes are seen in which mineral deficiency? The answer here is zinc. And why the answer is zinc? Because zinc lead to one very important condition, and that is known as acrodermatitis enteropathica. This condition, acrodermatitis enteropathica, is autosomal recessive condition, and it is very obvious from the name itself, because from the name itself you can see acrodermatitis enteropathica. So from dermatitis you can make out that there is inflammation, itis means inflammation and derma means skin. So there is inflammation of skin, so skin becomes red, erythematous, lesions or rashes can be seen. The site is very characteristic, site around mouth, that is perioral, then perianal area is involved or groin area is involved as shown in the image, and not only these areas but also hand and feet, and this you can very easily make out from the acral part. Acral, acro, what are acral parts? Acral parts are hand and feet. So this dermatitis is present around mouth, around genitals, and hand and feet is involved. So this is acrodermatitis. And enteropathica, entero reminds you of what? Yes, intestinal involvement, that is diarrhea. Along with this, patient due to this mineral deficiency may suffer from alopecia, and this alopecia do not cause scarring. So this is non-scarring type of alopecia. So these are the features which are associated with acrodermatitis enteropathica, and this is due to zinc deficiency, and that's why the treatment is zinc. So you need to give zinc, and if you're giving elemental zinc, that has to be 30 to 50 mg daily, okay, and if you are giving in the form of zinc sulfate, that has to be 220 mg, okay. So elemental zinc of 30 to 50 mg daily has to be given, and this has to be given for a very long period, maybe up till adulthood, okay. Then let us move on to the next question. In this question they are asking the first line treatment for acne comedons. Comedons are the most characteristic lesions of acne, and the most common type of acne is acne vulgaris. And from the face also you can see this image, face is being shown. Face is the common site for acne vulgaris. All of you might have suffered from acne, and these look very similar to acne lesions, okay. So the most characteristic lesions of acne are comedons, and comedons occur very big in the beginning of the acne, okay. So this is also known as grade 1 acne, okay. So let us first discuss, before the answer, let us first discuss about the grades of acne. So they can be grade 1, grade 2, grade 3 or grade 4. Now these different grades are based on the type of lesions. So if over the face of the child, if you find, or if the at the adulthood, or mostly they start occurring at the time of puberty, so in this teenager if you find that the lesions are mainly comedons, then it is grade 1, okay. If it is mainly papules, then it is grade 3, grade 2. If it is mainly pustules, it is grade 3, and if you find nodules, cyst, then it is grade 4. That's why this is also known as nodulocystic acne. Now the important questions which are asked here are that what is the drug of choice for nodulocystic acne? Already this question have been asked. So remember, for grade 4, which is also known as nodulocystic acne, this is the most severe type. Here the drug of choice is oral isotretinoin. So oral isotretinoin is the drug of choice for grade 4 acne, okay. But here they have not asked about grade 4, they are asking about grade 1. So initially when there are only comedons, we treat with a topical treatment. So topically we give gel or cream for application, and we treat with topical retinoids like adapalene, tretinoin. If it is grade 2, along with topical retinoids, you can give topical antibiotics like clindamycin, And if it is grade 3, then along with topical retinoids, you need to give oral antibiotics. Oral antibiotics like doxycycline, and you can also add benzoyl peroxide. So these are various commonly used agents for the treatment of. So coming back to this question, here they have shown initial lesions, grade 1, and grade 1 is characterized by comedons, which is mentioned in the question. So here the answer is topical retinoids. Yes. Okay. Now moving on to the next question. Identify the condition shown in the image. So you have to identify the condition by just looking at the lesion, and when you look at the lesion, what you can see? Let us try to understand this image. The first thing which you can see here is that lesion is not exactly round, it is asymmetrical. Like you can see, if you divide this lesion into two, it is not exactly round, it is asymmetrical, something like this. Okay, so lesions are asymmetrical. Okay, now second point which you can notice here is that the borders of the lesions are irregular. It is not exactly round or sharp edges are not there, they are irregular, isn't it? So borders are irregular. Third thing is, if you notice the color of the lesion, it is variable, isn't it? At places it is very dark, at places it is light, at places medium colored. Okay, so it can be very dark, in between, or lightly colored. So different colors can be seen, variable colors can be seen. If you look at the diameter of the lesion, it is quite large lesion, more than 6 mm, isn't it? And if you palpate the lesion, which is not possible in this image, but if the patient is before you and if you palpate the lesion, you will find that there is evolution of the lesion. At places it might be elevated as well. Okay, so all these points which I have told you can very easily be remembered by these 5 alphabets, that is A, B, C, D, E, isn't it? And whenever you find A, B, C, D, E, the answer has to be malignant melanoma. Okay, so malignant melanoma is clinically characterized by, or you can identify the lesion very easily with the help of A, B, C, D, E. So this is a very simple mnemonic to remember. A stands for asymmetrical lesions, B stands for borders and the borders are irregular, C stands for color and the color is variable, at places different colors can be seen. D is for diameter, the lesion is gradually increasing in size, it is more than 6 mm, and E is for evolution, or you can also remember elevated. So at places the lesion might be elevated, it is evolving lesion. Okay, so there might be a benign nevus present and gradually it might have these changes and it has convert into a malignant lesion, that is malignant melanoma. Okay, so these are very simple points and a very easy mnemonic to remember to identify malignant melanoma. Let us move on to the next question, that is, which organism is responsible for causing erysipelas? Erysipelas. Okay, now erysipelas is caused by, okay, so the most common causative agent for erysipelas is group A beta hemolytic streptococcus. Streptococcus. It is caused by streptococcus. Now sometimes they ask you the causative agent for cellulitis and many a times both appear very similar. Okay, so remember erysipelas and cellulitis. This is caused by streptococcus, as I already told you, group A beta hemolytic is streptococcus, while this can be caused by both strepto as well as staph. Okay. Borders of the lesions, if you see in erysipelas, are well demarcated, they are sharp, while here the borders are diffuse. Now there is one important sign which can help differentiate these two conditions, especially when the lesion is present over face, like in this case. Here you can see this erythematous painful lesion is present over face. So if a patient comes with cellulitis over face and a patient comes with erysipelas over face, how you are going to differentiate these two? Very easy. Look at the ear of the patient, ear, and that is why this is known as Millen ear sign. So what is Millen ear sign? Now in Millen ear sign, you can just examine the ear of the patient and you can differentiate between erysipelas and cellulitis. How? See, cellulitis involves deeper subcutaneous tissue. Okay, so cellulitis mainly involves deeper subcutaneous tissue which is absent in ear, isn't it? So ear are spared in cellulitis. So ear involvement is present in erysipelas, it is absent in cellulitis. So with the help of this, you can very easily differentiate erysipelas from cellulitis. Okay, so cellulitis, ear involvement is absent, in erysipelas, ear involvement is present. Let us move on to the next question. Here they are asking cutaneous horn, and you can see the image also. This is a cutaneous horn. As shown in the image is associated with which of the following skin carcinoma? Okay. Now remember that how to identify cutaneous horn. Horn, all of you know, you might have seen horn over the head of cow, buffaloes, isn't it? So how they appear? They are very hard. Okay, so are these lesions. So cutaneous horn, they are very hard. They are generally yellow or brownish in color, and these are the outgrowths which are coming out of the lesion. Okay, so initially the patient presents with a lesion and then gradually this outgrowth comes, which is, if you touch it, is it very hard, yellowish or brownish in color. So these are cutaneous horn. Okay, now there are few predisposing factors, there are few lesions which might develop when the patient have cutaneous horn. Okay, so these predisposing conditions are actinic keratosis, so it might occur on actinic keratosis lesion, squamous cell carcinoma, which is there in the option, then epidermal nevus, verruca vulgaris and seborrheic keratosis. Okay, so cutaneous horn can occur on any of these, but the malignant change which occur is squamous cell carcinoma. Okay, so squamous cell carcinoma is the malignant change which might be seen in a lesion of cutaneous horn, or it might develop over the lesion of cutaneous horn. Okay, so whenever a patient comes with cutaneous horn, what you should do? The treatment is excision, and you should completely excise and give it for histology. And on histology, you can very easily identify that the predisposing factor was malignant or any other condition. Okay, so that's why the answer here is squamous cell carcinoma. Okay, now remember that actinic keratosis is also mentioned here. Okay, now actinic keratosis is considered as a pre-malignant condition. Okay, so this can also lead to the malignant changes, but here they have asked about skin cancer, and skin cancer, a malignant condition which is usually associated as squamous cell carcinoma. Okay, so both can be associated, but the answer would be squamous cell carcinoma. Now here again they are asking you to identify the condition as shown in the image, and the area involved is again perianal. And around perianal area, what you can see? You can see these growths. If you look at the surface of the growth, they are rough surface. So these are rough warty growths. And these rough warty growths which are present around perianal area are which type of warts? Because these are warty, these are probably warts, and these are which warts? These are anogenital warts, because they are occurring over genital areas. So these are the lesions of anogenital warts, and anogenital warts are also known as condyloma acuminata. Yes, acuminata, not lata. Condyloma lata is associated with secondary syphilis. Okay, so these are the characteristic lesions of condyloma acuminata, that is anogenital warts, and anogenital warts, as you all know, are caused by human papilloma virus. So this is a viral condition caused by human papilloma virus. Commonly subtypes are 6 and 11. If both are given in separate option, choose 6 followed by 11. Okay, so remember, anogenital warts are caused by human papilloma virus 6 and 11. Okay, so this is a viral condition. Okay, and what is the treatment for this condition? Generally we use topical treatment in the form of imiquimod. If imiquimod is not there in the option, then you can choose podophylotoxin. Now the point to remember here is that both these agents are teratogenic. So never use them in pregnancy. Never use them in pregnancy. In the next question, they are asking that patient suffering from ulcerative colitis presents with ulcer on anterior leg as shown in the image. So in the image you can see that over the leg of this patient there is one ulcer, and the patient having a predisposing factor or a condition, that is ulcerative colitis. And can you tell me which condition is usually associated with ulcerative colitis? Yes, pyoderma gangrenosum. Pyoderma gangrenosum is usually associated with inflammatory bowel disease. Inflammatory bowel disease, commonly ulcerative colitis, also sometimes Crohn's disease. Okay, so this is the most important clue which is present here, that is patient is already having ulcerative colitis and the ulcer is present. And if you recall, in the beginning I told you that whenever you find undermined edges, you should always think of three conditions: tuberculosis, chancroid and pyoderma gangrenosum. And this is a lesion of pyoderma gangrenosum. So this ulcer, if you see the edges, they are undermined. You can see these undermined hanging edges. Okay, so remember these points: ulcer with undermined edges, usually over lower leg, so lower extremities are commonly involved, with associated condition, commonly inflammatory bowel disease, that is ulcerative colitis more than Crohn's disease. And if you find these features, then probably you are dealing with a case of pyoderma gangrenosum. And in such cases, the drug of choice is systemic steroids. So systemic steroids is the drug of choice for pyoderma gangrenosum. In the next question, they are saying that common complication associated with following condition. And what is the condition? If you look at the image, face is being shown. So site is face. Over face, there are lesions, and these lesions have crusting. And these crusted lesions have a characteristic color. Look at the color. The color is golden yellow. It looks like honey, isn't it? Honey colored. And can you tell me which condition presents with golden yellow honey colored crusted lesions over face? Yes, it is impetigo. And this is which impetigo? Non-bullous impetigo. So we know the condition, and the condition is non-bullous impetigo. And how we identify the condition? Site, which is face, crusting, which is golden yellow honey colored crusting. So both these features are of non-bullous impetigo, but still the question is slightly different. They are asking what is the complication associated with it. Now non-bullous type of impetigo is commonly caused by, so remember there are two types of impetigo. Non-bullous, which is more common, and other one is bullous. Non-bullous is caused by strepto followed by Staph aureus, while bullous is caused by Staph aureus. Okay, and here they are asking about complications. So because the causative agent commonly here is strepto, the complication must be related to strepto, that is post streptococcal glomerulonephritis. While here the causative agent commonly is Staph aureus, so the complication should be associated with Staph aureus, that is staphylococcal scalded skin syndrome. So remember that post streptococcal glomerulonephritis, because the causative agent commonly is strepto, is the complication of non-bullous type of impetigo, while staphylococcal scalded skin syndrome, because this is caused by Staph aureus, is commonly a complication of bullous type of impetigo. Both are there in the option. Which one to choose? Yes, post streptococcal glomerulonephritis is the answer, because the case is of non-bullous type of impetigo. Okay. Now in the next question they have shown nail. So here there is a nail, and around this nail you can see there is redness, red erythematous, and in the question it is written that this female comes with complaint of pain. So there is pain also. in her fingernail. On examination, red nail folds with pus discharge. There is pus also coming out. So, pus discharge, diagnosis. Okay. So, what are the features here? Around nails, the skin is red, it is painful, and there is pus coming out. Probably patient has developed infection, isn't it? And this infection is where? Around the nails, in the nail folds, isn't it? And that's why the nail folds are red, painful, and there is pus coming out. So, what is the infection of nail folds known as? Yes, it is known as paronychia. This paronychia can be of two types: acute paronychia and chronic paronychia. Acute paronychia is commonly caused by Staph aureus, while chronic paronychia is usually associated with not only bacterial infection but also fungal infection, and fungus which is usually associated is candida. Okay, so the points to remember here is paronychia can be acute paronychia or can be chronic paronychia. Acute is commonly due to Staph aureus and chronic is commonly due to candida. So simple to remember. A acute aureus, C chronic candida. Okay. Now the features here are suggestive of acute or chronic condition. Yes, acute. Why acute? Because all the acute inflammatory changes are there. There is redness, there is pain, and so collar, robber, dober. Okay, so there is pain, there is redness, and there is pus discharge also. So this is what? This is acute paronychia. So though there is only one option, paronychia, but if next time the question comes and two options are there, acute paronychia, chronic paronychia, then this is a case of acute paronychia. Okay. Let us move on to the next question. In this question, they are saying that patient presents with history of severe burn after only a few minutes in the sun. So within few minutes patient have severe burn. So this is what? This is photosensitivity. Whenever patient goes out in the sun, within few minutes he start developing lot of sunburn. Okay, there is freckling. Freckling is again a change which is associated with sun photosensitivity. Okay, over sun exposed areas, dry skin, and the changes in the skin pigmentation. There is skin pigmentation also. What is the diagnosis? So there are so many clues here. First of all, there is lot of freckles. There is dry skin, there is pigmentation again it might be due to freckles, and there is photosensitivity. All these are clues towards xeroderma pigmentosa. Yes, xeroderma pigmentosa. Why? Because xeroderma pigmentosa see, this is so simple to remember because you can see that from the name of the condition you can remember so many points. Zero. Do you know what is xerosis? Xerosis means dry skin. Okay, so zero comes from xerosis and it is mentioned here, dry skin. Okay. Then derma means there will be skin changes. So there are skin changes which are present here. And pigmentosum means darkening or pigmentation. So there is pigmentation like freckles. Okay, so from the skin, from the name itself you can make out that the skin is dry, there is pigmentary changes, and this is a photosensitive condition. Okay, so in this condition what happens? There is DNA repair defect. So due to this DNA repair defect, what happens whenever patient goes out in the sun, like we go out in the sun, what happens? If there is some damage due to UV radiation due to sun, it get repaired, but in these patients it do not get repaired. So whenever they go out in the sun, there is some damage and it persists, and gradually what happens, this damage initially presents with the form of this pigmentation, that is freckles, that is darkening of the skin, these small macules, and gradually patient start developing lot of sunburn, and it's later on patient can develop malignant changes as well, like squamous cell carcinoma. So these are the features which are associated with xeroderma pigmentosa, and this is a genetic condition, and genetically patient's skin is predisposed for these changes. So how you are going to identify? Over the sun exposed areas in a young child and early in the age, you will get lot of freckles, lot of dryness, and malignant changes might also be present. In the next question, they are saying that a child presents with sores in the mouth, hand, feet. What is the causative agent? Okay, so there are ulcers. or sores like you can see here, and they are present over which sides? Mouth, hand, feet. Does this remind you of any condition? Hand, feet, mouth. Yes, this is hand, foot, mouth disease. Yes, and the causative agent for this condition is picornavirus, commonly Coxsackie A16 and enterovirus 71. Okay, and how these patient presents? Initially, patient will present with prodromal symptoms like there will be fever, there will be malaise. Okay, and later on patient start developing these ulcers or sores, and the common site is, yes, from the name itself it is suggestive, hand, foot and mouth. Okay, so this is a case of hand, foot, mouth disease and the causative agent is mentioned here. So this is the answer. In the next question they are saying again child presents with fever. So here also prodromal symptoms are there and the rashes are present, and these rashes are pleomorphic. Do you know what is pleomorphic? Pleomorphic? Yes. So different stages of the lesions are present together. Okay, so pleomorphism. Okay, like Durga ji, isn't it? Durga ji have so many roops, isn't it? So that is one example of pleomorphism. Different roops are there. Okay, so different types of lesions are present together. Okay, so as shown in the image, like if you look at this image, what different type of lesions you can see? You can see that there are few fluid filled lesions. These are known as vesicles. There are few solid lesions. These are known as papules. Then some of them have ruptured, like these blisters of vesicles, they have ruptured to form ulcers. So you can see the ulcers here. If there is no fluid filled and they are only solid lesions, then these are papules. Okay, so there can be papules, blisters, ulcers. So different types of lesions are present together. This is pleomorphism or pleomorphic rashes, and pleomorphic lesions are commonly seen in, yes, chicken pox. How the patient presents? Patient initially present with fever, malaise, prodromal symptoms followed by these pleomorphic rashes, and the causative agent here is varicella zoster virus. Okay, varicella zoster virus, and because it is varicella zoster virus, the treatment here is acyclovir. If the child is very young, you can just treat him symptomatically, but if the condition is very severe, you can use acyclovir. Sometimes what happens that this virus lie dormant in the nerves and later on can reactivate later in the life. That is known as herpes zoster. So herpes zoster is the reactivation, and because this virus was there in the nerves, the reactivation occurs along the distribution of the nerve. So here the lesions are different. Here the lesions are unilateral. They are dermatomal along a particular dermatome, and they are also grouped fluid filled lesions, vesicles. They are painful. So if you find unilateral, that is only on one side along a particular nerve segment, if you find vesicles, fluid filled lesions, then it is herpes zoster, which is due to reactivation of varicella zoster virus. But in childhood, generally patient presents with chicken pox, which is the infection of varicella zoster virus, and that is what they are asking, and the characteristic feature here is pleomorphic rash. Okay, so this is a case of chicken pox. So thank you very much.